traditional healer, and this is submassive hepatic necrosis. And this was from a popular Ayurvedic product, multiple ones, which was even advertised for joint pains in the media, and so on. So here, the result says that the duration of the drug intake was just for 28 days, and some patients died. Arsenic and mercury were significantly associated with death, and these hepatotoxic volatile chemicals were detected in more than 70% of the samples. And a couple of years ago, in 2017, we published a couple of papers on unscientific therapies in diabetes, and also wrote a chapter in a textbook. So I will briefly go through the CAM in diabetes. So what is the definition of complementary? So these are the therapies that are used along with conventional treatment, whereas alternative therapies are used in place. So you substitute and you stop it. So there are many of our patients who will stop modern medicines and they will go only for the herbal remedies. So that is alternative therapy. So the ADA position statement doesn't recommend the use of any of these therapies unless their safety and then efficacy has been established. It is very important that you have to establish not only the safety but also the efficacy. The complications are multiple. They can alter the PK/PD properties of the conventional therapies when they are used as a complementary one. And in case of PK interactions, it can alter the absorption of the product, distribution of the product, metabolism and excretion, and it can interfere with the intestinal and hepatic enzymes. And in pharmacodynamic interactions, the herbal remedies can interact with the same target molecule. So when there is synergy, it increases the toxicity. Whereas when there is antagonistic interactions, it can result in a reduced efficiency or efficacy of the product. So these are some of the common concerns with the popular Ayurvedic medications which are marketed for diabetes. There is variability of the same product from one lot to the other. There is absolute lack of standardization. There is misidentification. There is mislabeling and contamination. So this is a long process, and the discussion itself will take more than an hour. So I will be very brief for the sake of time. An example of a contamination of a herbal product, Aristochia serpentina for Stephania tetraenovis, resulted in urothelial malignancy in several deaths. The Chinese herb-induced nephropathy in quotations. And the biological complementary therapies for diabetes, cinnamon, gymnema, aloe, fenugreek, and so on. And then a brief discussion on fenugreek. We are also conducting an RSSDA supported research on fenugreek in our center. It contains coumarin constituents. It increases the effects of anticoagulants. So need to be very careful when it is given along with anticoagulants. Enhances the effect of our sulfonylureas, gliptins, thereby increasing the chances of hypoglycemia. Look at this FDA notification, quite interesting and widely popular in our country, but nothing happens in our country. So this is about a Chinese herbal product, Liquang 4, dietary supplement capsules being marketed online in several parts of the US for diabetes. And they found that there is a contaminant, none other than glibenclamide, glyburide. So the Indian herbal products claiming to be anti-diabetic, they also have been reported to be contaminated with drugs such as glibenclamide. We know the fact, and a large percentage of medications from Ayurveda, both US and Indian manufactured, they have lead, mercury, and arsenic. Lead, mercury, and arsenic. Several Indian herbal medicines were found to have lead toxicity in diabetes. And there are such therapies being even propagated by the modern medicine doctors. So this is one therapy which has been very popular in Kerala from northern part, and that is a sweet therapy being propagated by a modern medicine doctor for stimulating the pancreas, the sleeping pancreas, and population people are going in groups. And this is an analysis of 25 patients that we have done. And this is the average age, and this is the duration of therapy, 6 to 8 months. That is the average duration of sweet therapy. And this is before therapy and this is after therapy. Look at the A1C, 7 versus 11. Spot 23 versus 245. We do have laws in our country, and this is very old. In 1954, the Drugs and Magic Remedies, and this is uh, uh, one interface from the same Drug and Cosmetic Act, and it says that where diabetes is also in the list, that you should not propagate a drug as a prevention or cure for the following illnesses. I am very particular that why these scientific therapies are existing. So we need to explore why are these scientific therapies existing, and these are the probable reasons. Many of us have very close friends or even relatives who are involved in this. So we don't want to deliberately hurt them or probably invite trouble. Evidence on hepatic toxicity, renal toxicity, they are not getting published in the way it need to be published. And there is a subgroup of modern medicine doctors who believe that these therapies are good and efficient. But ultimately, the reason could be why it is still existing could be the fear, especially by the modern medicine doctors. But recently, I know that there are a group of young doctors very active in the social media from our own modern medicine, from Indian Medical Association. And this is something which is so comforting for us. So they are open. So what can we do? What can we do to stop this? And these are again the international recommendations. You cannot just tell the patient to stop it because that is their own belief. Respect his health beliefs. And we need to address in an unbiased manner. But I will say that there should be no experiments with these unscientific and unproven remedies, both for diabetes and for COVID, especially during this pandemic era. Very, very important that we should be instructing our patients. And these unscientific remedies are probably going to exist because diabetes is a very, very ancient disease. And the claims for cure can easily attract even the educated lot. And unproven therapies will exist. And this is a recent paper from a group of doctors, including me, initiated by Dr. Mohan from Chennai on diabetes and coronavirus disease, what to do and what not to do, and the precautions. I would like to start with a cartoon which we created a couple of years ago. And this is in 2005 when he has stopped all his medications and adopted the insulin plant. So he's very excited. I saved a lot of money. And this is 10 years later when he is blind, when the kidney is gone, and all the wealth is gone along with a limb amputation. So that is the fate of unproven therapies. So thank you very much. Thank you very much. And congratulations to my dear friend Shabir for this very, very successful event.
So thank you. Am I audible?
Yes, sir.
Am I audible?
Yes, 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 sir.
Thank you very much, all the three speakers. Now it's time for Dr. Sabir. How much time do we have?
No, sir.
We
We
can
can,
have
we can
questions.
have 3 or 4 minutes. Sure, sir.
Yeah, all the three speakers are here. All the three were excellent topics and reasonably controversial as well. And I don't find any questions in the chat box. So questions, please. Questions? Any questions? Or is it that everyone is convinced of the need of whatever had been told?
No, to initiate the discussion, let me ask Dr. Bharadendran sir one doubt. Because when you talk about LDL cholesterol, uh, actually, sir, it is being largely told that beyond LDL cholesterol, it is actually the size of the LDL cholesterol also which matters. And our conventional way of counting the LDL cholesterol together may not be very scientific. and large buoyant LDL particles may not be actually harmful. So, what is your take on that? Should we subdivide the LDL, and should we dissect further? Or should we classify the whole LDL together?
The estimation of LDL cholesterol doesn't estimate the LDL small dense particles. It is very difficult. Estimating the LDL-C, it's very LDL small dense LDL is very difficult, and it is not being done routinely. It may be in some research labs. So, if the LDL is associated with high triglyceride, you can take it for granted the small dense LDL also is high. And second is in diabetic population, we all know the LDL is normal. So the LDL-C percentage of LDL-C is very high, what we call as diabetic dyslipidemia, highly prone to develop atherogenic. More important is the endothelium.
Thank you.
Again, to Sridhar sir, we all know this in this COVID era, there are so many confusion among the people regarding the medications and treatment. And of late, we have seen this other systems of medicines coming and advising and giving drugs as immune boosters. In fact, there are so many confusion going around among the people, whether to, so many are asking these questions, whether we can take these medicines. And in fact, government is also involved. IMA may have their own opinions. What is your take on that, sir?
Yeah, in fact, I was surprised that Jyoti missed the most controversial drug in his first opening slide. So this humbug about arsenicum album actually shouldn't. In fact, I had written an article and I was about to put it up when all these controversies came. So I didn't want it to, get subdued in all these controversies. There is huge evidence from Maharashtra that this is sheer humbug which is going on. And in 2003, actually, what happened was there was this dengue flaring up in Trivandrum. And at that stage, this again, the homeo preventive drug was given widely all over Trivandrum. Those days, I was IMA secretary of Trivandrum branch. And then we undertook a small study. We went into SAT hospital and found out how many of those kids who were admitted actually took the preventive drug. Actually, they were giving it in all the schools also. And then finally, we found out that in the society, all those who took the preventive drugs, 18% of those who took and 11% of those who didn't take got dengue in the society. And in that SAT hospital admission, 46%, if I remember correct, it was an old study. Unfortunately, we didn't publish that. I'm just speaking from my memory. 46% of those who took, and I think 32% of those who didn't take were in the hospital. So then we conducted a huge rally here in Trivandrum, a anti-mosquito rally. And that day, we got all the minister, chief minister, the opposition leader, everyone in one stage declaring that mosquito is our enemy. Kodugana Shatru. We conducted this thing. And last week, I was just glancing through my gallery, and I've taken I've taken a newspaper clipping, a photograph of a newspaper clipping, which was telling, yeah, where the health minister was telling that dengue is caused by mosquitoes, and the only way of control is by controlling mosquitoes. This may seem a small statement. I don't know whether you can see that, but this is a statement. I know it is inverse, but കൊതുക് നശീകരണം മാത്രമാണ് പ്രതിരോധ മാർഗം. And it took almost 20 years for a health minister to say that to prevent dengue, you need to annihilate mosquitoes and not give these preventive syrups. So that is the state of affairs. I completely agree with Dr. Jyoti that we need a huge movement for that. I'm very glad that Jyoti took up this topic and brought it out. I know, many people, including some of our doctors, Jyoti rightly told, they will feel little disillusioned. Why this guy is talking against me? No, we are not talking against anyone in person. And when we put it in the FB also, many homeo friends will ask why you are why you are irritating us, and then they will go on propagating that this guy is a fake. And rightly, as Jyoti told, many wouldn't like to venture into those controversies. So what we tell them is, this is not against you. you are destroying public health, and you cannot actually experiment on people like this. Then they quote some evidence, and one guy was telling, I appeared in a media debate. One guy was telling that, we gave all these medicines to many people in Pathanamthitta or Pandalam. We found it to be quite effective. Now we are going to ask the government and all the drug authorities to give approval. Then I told it is just the reverse. You have to first get the approval, and then you have to give the drug. Now you are already giving the drug, and then you are asking for the approval, and then you put the government in a tight spot where government has to. What the health minister is saying is, I am minister of all departments, so I have to look after the other department also. No, you are minister of public health. You're not minister of modern medicine or any other system. So I think it is a huge issue here, especially in Kerala and in India. I don't want to ridicule any person, but then we have to stay for science. And this, what it produces is, why it damages it is because everyone thinks that I have taken the preventive medicine, I need not wear a mask, I need not maintain distance, and then it will be counterproductive. So IMA has told that there are many allegations, but there is absolutely no doubt that such unscientific systems have to go. And I'll go one step further. I'll say that the unscientific systems, and at least government money should not be spent for unscientific systems.
Thank you, sir. Hopefully, we all think in that positive way. One more question to Jodev, sir. Sir was actually, in fact, showing an article in which Jodev, sir, was one of the co-authors. It is a very, very informative article which very clearly says the scientific reasons behind why we should give insulin in moderate and severe cases, and why to avoid some of the OHAs which are in the usual practice. And sir, it is high time that we need to educate the people regarding the importance of insulin, and especially the control of diabetes. And in later stages, definitely we will have to go insulin. Your take on that, sir?
Yes, definitely, because insulin should be more propagated. And because of the sake of time, I am going to stop here because I can see Ravindra sir waiting over there. So thank you very much.
No, Dr. Jyoti, there is one question. What's your opinion on the use of vitamin C and vitamin D in this pandemic times? This question appeared in the chat box. I think it's from Dr. Sabir.
Yeah, I think there is quite scientific evidence to promote vitamin D, vitamin C, vitamin B12, and zinc. And this is with respect to both the cell-mediated and B-cell mediated immunity, both humoral and cellular immunity. And then there are some studies on endothelial dysfunction as well. And I did a recent lecture also on this. And from modern medicine, because we were discussing about unproven therapies, from modern medicine, we do have sufficient evidence. Of course, it is not for boosting the immunity, but these vitamins are related to immunity. And vitamin D, in a recent study from 20 countries in Europe, they have shown that more critically ill patients who were admitted in the ICU and more deaths were reported in those patients with very low vitamin D levels. And with high vitamin D levels, the survival rates were also higher. So there are still ongoing studies, including some clinical trials related to these three vitamins. So thank you, sir.
Thank you, Jyoti. I acknowledge the presence of Ravindran sir again. Thank you, Ravindran sir. But I have a small question again to Jyoti. It's a continuation of the previous presentation. It's about HCQ, and you have vouched for HCQ in several platforms. I have a question about people who already had a coronary event, who have undergone an angioplasty or a coronary bypass graft. Is HCQ? Is there any contraindication or HCQ in such patients?
Whether it is working or not, honestly telling you, sir, I am also on HCQ because I'm taking hydroxychloroquine once in every 4 days. And I checked my own electrocardiogram, and I discussed with the cardiologist as well. And the international protocol says that up to a QTC interval of up to 480, we can have it as prophylaxis. And it is again related to the same thing that we have discussed, the virucidal effect, and also it has got something to do with the spike protein and its attachment to the functional receptor of the COVID-19. So it works as a prophylactic agent, and that probably is one of the reasons why it is still there in the ICMR protocol. Probably Dr. Sridhar will be knowing more about it. Anyway, personally, I would like to promote, but in those patients who already had a coronary event, we can go by the QTC. And maybe everybody can take it because it is a very, very safe drug, been there for more than 60, 70 years.
Any comments, Srijit? Dr. Srijit, any comments on that?
Actually, I don't want to trigger a controversy, so I think I'll not comment at this stage. Again, I'll say that probably we should go for proven therapies, and the only thing which is known to boost immunity against COVID, it's COVID itself. At this stage, we are waiting for the vaccine, so let's wait for that.
So thank you very much, all the three speakers. It was a session, and also thank you, Dr. Sabir Rashid. Let us conclude this session. Thank you again. Thank you.
Okay, we will move to the. We'll move to the next session. Which is going to be chaired by Dr. Faraz Parisha and Dr. Sabir. Over to you, Sabir.
Yes. Thank you, Joseph sir, Srijit sir, and Bailendra sir for the excellent lecture. Now, coming to the next session. To chair the session, let me invite my dear friend, endocrinologist from Dr. Faraz Parisha. Over to you, Faraz.
Chairman of Ramchandran's Diabetes Hospital, Chennai, President, Indian Diabetes Research Foundation, Chennai, visiting Professor, Imperial College, London, recently awarded the Best Investigator Award by World Indian Diabetes Foundation based in US. He has been awarded with the Thomson Reuters Research Excellent Citation Indian Award in 2015. He's been a speaker in various national and international forums. And then he's going to speak on gut microbiota. Is it and therapeutic option in diabetes management? So over to you, Dr. Ramchandran.
Yeah.
You can take it from here.
Yeah. Good morning, everybody. I'm very happy that I could join the intelligent people today this morning and I've been 40 minutes late, so I've been listening to Dr. Balachandran and also Dr. Jyotidev, two excellent talks. Now we'll go on to a new thing, and I also congratulate the Travancore Diabetes Research Foundation, Dr. Shabir, and also thank for inviting me for this excellent meeting. Okay, can you see my slides now?
Yes, sir. Yes, sir. Please. Perfect.
All right. So I'm going to talk to you on gut microbiota, which is a newer science evolving not only in diabetes, but in total human health. These are my disclosures, just for the sake of my talk. And the outline today would be, first, just discuss about the gut microbiota can influence host health, the role of gut microbiota specifically on type 2 diabetes pathophysiology, and then we discuss there are any therapeutic options to correct this. We have a couple of drugs used in diabetes, including acarbose, which can actually reverse the dysbiosis in diabetes, which is a pathophysiological note. Okay, this is interesting. We are more bacteria than human, and these are some of the facts which are shown on the left-hand side of the slide. The human body is home to complex communities of microorganisms. The total number is estimated to be pretty high, 10 to the power of 14. That is 10 times the number of human cells per individual. So we are more a bacteria than human. The majority of the human associated microbes and the largest diversity are usually found in the gastrointestinal tract. The microbial abundance increases from the stomach to the colon. 95% of the total microbiota belongs to the families of firmicutes, bacteroidetes, actinobacteria, and proteobacteria. So when you have so much of bacteria inside the body, there should be some function. It should have some relation to health, which probably we have ignored in the past. A healthy microbiota comprises a balanced representation of symbionts, that is, bacteria with health-promoting functions, and pathobionts, which are bacteria that potentially induce pathology in the human body. A decrease in the symbionts or an increase in the pathobionts is called dysbiosis. So we are actually learning new terms. And this dysbiosis is likely to be triggered by a number of factors, which could be diet, stress factors, antibiotics, and of course, infections, especially GI infections. So therefore, this can influence the health status of the human body. Dysbiosis has been linked to increased fat accumulation, liposaccharide-induced inflammation, insulin resistance, obesity, and the metabolic syndrome. So for the first time, instead of having any acute repercussions, we now know that the persistent dysbiosis has some relation with metabolic diseases and even cardiovascular disease. So this is an interesting topic, and it's an area of research which is opening up now. A lot has to be learned in future. We know something about it now, but we now know that this is a new science which cannot be ignored. So on the left-hand side, these are the effects of symbiosis, and it actually decreases gut permeability, it reduces endotoxemia, it reduces pro-inflammatory cytokines, and it's a beneficial one and increases insulin sensitivity. Beneficially activate molecules such as short-chain fatty acids and indoles. On the right-hand side, you have the dysbiotic gut microbiota, which increases gut permeability and produces endotoxemia, inflammation, and results in adiposity, insulin resistance, and metabolic syndrome. So therefore, that's a connection, some connection between not only just diabetes, but also cardiovascular disease and the gut. Now, specifically, we can talk about the role of gut microbiota in type 2 pathophysiology, and there have been a number of plethora of papers coming out, the connections. Intestinal flora is a hotspot in the field of diabetes in recent years, and there have been a number of papers. This is a paper which showing the metogenic wide association, and what it has been shown is that a moderate degree of gut microbial dysbiosis is seen in type 2 diabetes, decrease in the abundance of some of universal butyrate producing bacteria, and an increase in the various opportunistic pathogens. So there is still a lot of work to be done, but this is one of the findings which has been universally seen. Some mechanisms have been worked out, but a lot has to be learned. This is just showing that alteration of intestinal permeability after change in the gut microbiota has been shown in mice models, and there is an increased permeation of liposaccharides, and there's a new receptor called the toll-like receptor, which is acted on by this microbiome. So intestinal permeability and increased absorption of liposaccharides leads to metabolic endotoxemia, which is basically an elevated serum concentration of LPS. This leads to, again, this metabolic endotoxemia leads to impairment of insulin signaling. And again, this is experimental animals. At this point, we must also say the origin of metabolic endotoxemia is not very clear, but is strongly suggested that it may be associated with changes in the gut microbiota, leading to increased activation not only of inflammatory pathway, but also impaired insulin signaling. Therefore, the connection between microbiota and insulin and diabetes. This is putting all together. In fact, there has been three mechanisms which has been sorted out today. One is the TMA pathway, trimethylene N-oxide pathway. The other one is short chain fatty acid pathway and primary and secondary bile pathway, all leading to an increased inflammation, endothelial damage, and insulin signaling. So all these have come out from experimental studies in mice. There are only very few human studies, but we know there is a connection between microbiota and type 2 diabetes. So when you're put up slides on pathophysiology of type 2 diabetes. We always talk about genetics, environment, and diet is an important part of the environment. And then talk about obesity, sedentary life habits, insulin resistance. But now you have a new candidate, which is microbiota, which can be added as one of the pathophysiological or ecological factors in the pathogenesis of type 2 diabetes as well as metabolic syndrome. So you talk about genetics, environment, and the environment could be also influenced by not only your sedentary life habits, lifestyle. One important lifestyle is diet, and we only talk about high fat diet, high sugar diet, and high carbohydrate diet, etc. But we must also remember diets which can change the microbiota may be involved in the pathogenesis of metabolic diseases such as type 2 diabetes. Now, it may be interesting that there are a couple of drugs which is used for diabetes, which can actually show correction of the dysbiosis microbiota. One is acarbose, and the other one is interestingly metformin. So I'm going to give you a few slides to tell you some of the randomized controlled trials and experimental and cohort studies to show that. Now, what is the mechanism? Acarbose facilitates production of short chain fatty acids and hydrogen gas by fermenting of undigested polysaccharide in the lower gastrointestinal tract. As you can see, it facilitates increased production of fatty acids in H2, which mediates suppression of pro-inflammatory cytokines and also a number of adipokines like interleukin 6, TNF-alpha, and these can be attributed to cardiovascular benefits. So you have surrogate markers, which are, we can say biomarkers, which can be influenced by the change in microbiota, which is influenced by acarbose. A question may be asked, of course, you know acarbose is an alpha glucosidase inhibitor, whether other alpha glucosidase inhibitors such as meglitol and voglibose, which is already in the market, has the same property, but actually it is not so. It is only acarbose which actually produces higher concentrations of polysaccharide, and therefore it has got this specific action of correcting the dysbiosis microbiota into a less inflammatory microbiota, which actually has benefits both from the cardiovascular point of view and metabolic point of view. This is one of the studies showing acarbose treatment affects the serum levels of inflammatory cytokines and the gut contents of number of bacteria in Chinese patients. Of course, this is from Taiwan, and what is shown is a randomized control trial where 59 were in group A, where acarbose 150 milligrams per day was given, and the other was given treated without acarbose. And what is shown here is that the favorable effects on the microbiome in diabetic patients with acarbose, the levels of the bifidobacterium lognum and Enterococcus faecalis higher in patients with diabetes than in diabetic controls usually. Now, acarbose treatment significantly increased the levels of the lognum and decreased the level of Enterococcus faecalis in both the groups, which is actually correcting the dysbiosis. So this is one of the evidence to show that acarbose, which is an alpha glucose inhibitor, increases the beneficial effects can be seen also by dysbiosis. We also know that acarbose has got an incretin effect. This is a new effect which has now been described from acarbose. There's another study showing the effect of acarbose treatment on inflammatory markers in patients with diabetes, where you have looked at TNF-alpha, high sensitivity CRP, and MCP1 decrease, and then levels of PI1 were unchanged in the acarbose group. So on one side, you have the baseline increase in the pro-inflammatory cytokines in patients, and after 4 weeks of acarbose treatment, there was a significant decrease in all the 4 biomarkers or pro-inflammatory factors, and this is mediated through the change in microbiota. So these are indirect evidences that microbiota in the gut has very important role in the pathogenesis of metabolic diseases, type 2 diabetes, cardiovascular factors, and treatment with acarbose. Not only does this, but you have evidence from the serum surrogate markers that probably it is working and could have long-term beneficial effects in people with type 2 diabetes who already have an inflammatory status and also have a high risk of cardiovascular disease. There's another study, effect of acarbose on gut bacteria, a randomized double-blind control crossover. What has been given is that at each follow-up visit, every participant was asked to have a standard meal with the same dose of medications, and then fecal samples was collected and brought to the laboratory within 2 hours and stored in minus 80 degrees. So it's a crossover study. You do a double-blind study, and then you give one group acarbose, and then stop that, and then you give crossover study. You give the group which did not receive acarbose, you give the placebo, and then continue the other group on acarbose. So that it's a very robust design of study to show that. What is shown here is that total 108 genera was identified, and 40% were at relatively higher abundance after treatment with acarbose. That's a pretty high change for that short period of treatment. There was, after acarbose, higher abundance observed for 5 genera, including Lactobacillus and Dialister, and then lower abundance of these bacteria, which can produce dysbiosis. So therefore, again, this is an indirect clue that acarbose can correct the microbiota and could have a beneficial effect in the long run. So what is the beneficial effect? So Lactobacillus includes improving type 2 diabetes, anti-diabetic and anti-inflammatory effects, and of course, reducing body weight. Megasphaera could potentially transform the carbohydrates into short chain fatty acids, which is beneficial for lactobacillus growth. So these are the actions which has been now shown from mice, and also now we know even the human microbiota, these changes can be reproduced, and acarbose can correct the symbiosis, the dysbiosis which is seen in patients with diabetes, and it could have long-term beneficial effects. Metformin is, of course, is very interesting. We have been metformin is one of the oldest drugs for diabetes, and every time we study the mechanism of action of metformin, we find there are new mechanisms. Now, you know that it increases insulin sensitivity, it has got an incretin effect, it has got effect on the gut, it has got effect also now, a new effect on gut microbiota. And this is not through lactobacillus. This is another bacteria. Metformin increases the abundance of Akkermansia, a mucus-degrading gram-negative bacteria in the gut, which is associated with restoration of reduced regulatory Tegris cells, amelioration of low-grade inflammation in the adipose tissue of animals. Now, Akkermansia is called Municipedia, has been shown to combat diabetes and obesity in obese mice. So therefore, looking into microbiota, we are finding that metformin has another new mechanism of action in reducing not only blood glucose, but also reducing cardiovascular risk by its action on microbiota. So I think it's a very new finding, and a lot needs to be done. So I'm just telling you some of the preliminary data on the connection between the GI bacteria, the metabolic diseases, cytokines, and then we are coming to whether the present treatment, some of the agents that we are already treating, has some beneficial effects on microbiota, which may have long-term beneficial effects, not only for diabetes, but also its cardiovascular complications. So the combination of acarbose and metformin, probably, when we were describing that acarbose and metformin had incretin effect, we found that when you combine acarbose and metformin, the incretin effect was amplified. So similarly, the beneficial effect of acarbose and metformin can be amplified when you give a combination of these two drugs together in type 2 diabetes through different types of bacteria and the short chain fatty acids. So another question. Now, all of you can now ask, till now, we have been describing studies which are actually experimental studies, surrogate markers, but is there any evidence to show that cargos has got any randomized control trials or any real world evidence to show that it has got any cardiovascular benefits? We know there have been two important studies. One is the STOP NIDDM trial, which showed it reduces the risk of diabetes, but it also had a significant reduction in myocardial infarction. The ACE trial in patients with impaired glucose tolerance failed to show that acarbose had any cardiovascular benefits, but reduced diabetes by 16%. Now, what I'm showing here is actually real world evidence showing that a significant lower risk with acarbose metformin combination seen in stroke, atherosclerotic, and myocardial infarction compared with sulfonylurea and metformin, almost 14,000 patients. It's pretty impressive. Of course, this is not a randomized controlled trial. This is a real-world evidence from the population data. So there has been a 33% relative risk reduction in patients treated with acarbose in hospitalization due to ischemic stroke, a 31% relative risk reduction in hospitalization due to atherosclerotic events, a 34% relative risk reduction in hospitalization due to myocardial infarction. So this is a signal showing that what we have just learned from the surrogate markers of beneficial effects of acarbose may be seen in the population in the human beings with type 2 diabetes, and we probably need more studies, more randomized controlled studies in order to see whether it can be reflected in cardiovascular benefits in patients with type 2 diabetes who are treated with. Now, this is a study, a robust study from real world evidence from the Asian population. So to sum it up, we're talking about microbiota in the gut. Dysbiosis of the gut microbiota is increasingly appreciated as a mechanism accounting for diabetes and related metabolic diseases. Gut bacteria use polysaccharide substrates as fuel for their growth and conversion to short-chain fatty acids. Acarbose allows polysaccharides to enter the large intestine and facilitates production of short-chain fatty acids and hydrogen gas. The SCFAs, or the short-chain fatty acids, have beneficial effects on the host energy metabolism and inflammatory responses. In short, these are again surrogate markers, so it may have long-term beneficial effects. Acarbose treatment significantly increases levels of useful bacteria, including Bifidobacterium laudanum, Lactobacillus, and Megasphaera and Dialistem. So this is beneficial to the gut and also increases the cardiovascular protection in the long term. So this is a new, as I told you in the beginning, there is a new science, and we have to learn a lot on this. It only shows that the gut, the bacteria living in our colon, is not an innocent bystander, but maybe an active participator in causing diseases, and probably these may be targets for treating and preventing diabetes and cardiovascular disease in future. Thank you.
Faraz, can you unmute?
I'm trying to do that.
Okay. Faraz. So thank you, Ramendra sir, for the excellent lecture. Faraz, can you unmute? Yeah. We will have some couple of questions right now.
Yeah, am I audible now?
Yeah, perfect. Please go ahead.
Yeah, so thank you, sir, for that impeccable presentation on gut microbiota. And then I would agree that it is ever-changing science. And then I'm really surprised that with the COVID pandemic, that gut microbiota has not been till now linked to COVID, because now gut microbiota has shown benefits in all the points of the you talk about diabetes, you talk about obesity, hypertension, and then there is FMT, that is the microbiome transplantation also, there is, which has been done in AIMS as well. So definitely it is a future which we are looking ahead.
Sure. Yeah, that's a good thing. Yeah. We are learning about COVID every day or every hour with the new science coming out. And the connection between diabetes and COVID is, I was involved in that same article which you was talking about. At this point of time, I am involved in a global diabetes registry where we are looking at new onset diabetes due to COVID, because we find that a lot of people with COVID are getting new diabetes due to not an autoimmune reaction. We do not have still any data on microbiota and COVID at this point of time. We only know that COVID also can present with diarrhea and GI disturbances. There are a variety of presentations of COVID being seen because there are millions of patients who are contracting this virus. So we are learning every day. You're right.
So we'll now move to the next session.
Thank you.
Thank you, sir. So we'll now move to next session. I'll invite Dr. Tehseen N. He's an interventional cardiologist at Malabar Institute of Medical Science, Malappuram. Completed DM from Calicut Medical College. Speaker for many regional and national conferences. And he will be speaking on dapagliflozin, a new standard of care in heart failure management. I think, again, SGL2 is one drug which all of us are learning that it is one drug which is an anti-metabolic syndrome drug. So let us hear it from Dr. Tehseen. Over to you, Dr. Tehseen.
Good afternoon, all. Hope I'm audible to you.
Yes.
Okay.
Yes, Tehseen, please.
Can you see my slides?
Yes, perfect. Go ahead.
Okay. Thank you for this opportunity to talk in front of you. Thank you, Dr. Sabir, and all the other participants and the organizers for this chance to talk. And as you all know, the dapagliflozin and heart failure, it is the hot topic because all the glyphosins started as a diabetic drug, and now it is in the arena of the cardiologist. And we are so happy that we got one more drug to treat the patients who are suffering from heart failure. So SGLT2 inhibitors were added as an add-on OHA, and it included DAPA, MPA, CANA, and epagliflozin. The mechanism was renal excretion of glucose through this SGLT2 inhibition, and it produces osmotic diuresis. And the previous studies showed it has got a very good cardiovascular and renal safety. And those studies also hinted that it reduced heart failure admissions in diabetic populations. So now the golden question that came up after these studies is there any benefit for non-diabetic heart failure patients? Is there any benefit for non-diabetic heart failure patients on top of best available therapy? That includes medicines like ACE inhibitors, ARB, beta blockers, and including devices like CRT and CRT kind of devices. So this is the golden question that we wanted to answer. And for that, this trial was designed. That is the DAPA-HF trial. And the design of the DAPA-HF was, it included around 4,744 patients. That's very good inclusion. And it was conducted in 20 countries. And the inclusion criteria were, one, the patient should be symptomatic, that is NYHA class 2 to 4. And the ejection fraction should be less than or equal to 40%. And there should be signs of evidence for the heart failure, like NT-proBNP should be more than 600 picogram per ml. There are some extensions for that. I'm not going into the details. The exclusion criteria included severe renal dysfunction like EGFR of less than 30 ml, EGFR of 30 ml, and a systolic BP of less than 95 milliliters of mercury, and all the type 1 diabetes patients. And they were enrolled equally, 2,371 in the placebo group and 2,373 in the dapagliflozin group. And the study was published in, it was conducted in across the globe in all the continents, main continents, and most of the patients were recruited from the Europe. And the key baseline characteristics of these patients, I just want you to focus on these areas. One is class 2 patients were more. That is, NYHA class 2 patients were 68%, and the mean ejection fraction was 31%, and 45% patients had diabetes. That means 55% didn't have diabetes. So it's a balance. 50%, around 50% of the patients were diabetic, 50% were non-diabetic, so that we can compare the results into both the groups. And most of other parameters were matched very well. And most of the patients were on diuretic, 93% and 94%. That means the diuretic effect of dapagliflozin doesn't have much effect on these patients. And the patients were either on AC inhibitors 56%, ARB, or ARNI, that is sacubitril valsartan group. And altogether, this comes around more than 90%. And more than 96% was on beta blockers, and mineralocorticoid receptor antagonists, spironolactone or eplerenone were used in 71%. And the best device therapy like ICD and CRT were used for these patients whenever it is possible and indicated. So the baseline was well balanced, and all the patients were given the best treatment available other than the DAPA for the control of heart failure. And all were symptomatic. Major chunk of these symptomatic patients were in the NYHA class 2 group. And the results were published in 2019 in the New England Journal of Medicine. And the primary outcome was, this is not surprising because previous data about other drugs were also showing these data, were indicating the benefit. The primary composite outcome of cardiovascular death, heart failure hospitalization, or urgent heart failure visit were much less in the dapagliflozin starting from the very beginning. So immediate effect and long-lasting effect. And it has got hazard ratio of 0.74 with a very narrow confidence interval of 0.65 to 0.85. That makes it so significant with the p-value much less than 1 in 10,000. The number needed to treat was 21. So it all says that the cardiovascular death, heart failure hospitalization, and urgent heart failure visits were much better in the dapagliflozin. And when we separate these items, the worsening heart failure event, it was much less in the DAPA with a hazard ratio of 0.7, and cardiovascular death itself was significant, even though the p-value is not that important. So major benefit were coming from the prevention of heart failure worsening, and on top of that, there is an additional benefit with reduction in cardiovascular death. Then the secondary outcomes of this trial showed the cardiovascular death or hospitalization. Again, that also the DAPA was good compared or better than the placebo from the beginning itself. You can see that even within 1 month, both the curves were separated, and the hazard ratio was 0.75. And the total heart failure hospitalization and CV death, including first and repeat hospitalization, DAPA was superior. So the question, till now we were discussing about the acute worsening and acute hard endpoints in the course of a patient's life. What about the in-between time? We know that if we are giving dapagliflozin to 100 patients, their acute worsening, acute admissions, and sudden death or death due to cardiovascular cause are less. What about the intervening period? Whether they have an important, significant symptomatic benefit out of DAPA? That was the next question. And that question was answered by comparing the Kansas City Cardiomyopathy Questionnaire, KCCQ. It's from 0 to 100. The questionnaire is from 0 to 100. And the DAPA patients had a change, improvement. When it goes up, the score goes up, that means there is more improvement. The DAPA had a plus 6.1 point improvement, whereas the placebo had only 3 plus 3.3 point improvement, with a significant difference between the DAPA group and the placebo group. So that means that when you start the patient on dapagliflozin, the patient immediately gets the benefit, symptomatic benefit, and in meantime, it prevents the sudden worsening of heart failure and also the cardiovascular death. So altogether, there is improvement. When we check the point score, this KCCQ, more than 5 points improvement is required to say that there is an improvement. So how many percentage of patients had this improvement? In the DAPA group, it's 58%. In the placebo group, it's only 51%. And it's significant. And again, the deterioration also, some of them deteriorated even on DAPA and placebo, but that deterioration was much less in the DAPA group. That is, it's only 25% compared to 33% in the placebo group. So the placebo, it was also statistically significant. So these are the outcomes, the hard endpoints. And all-cause death, that's also a secondary endpoint. All-cause death was also less in the DAPA group, but you can take it that the p-value is only 0.02, but the hazard ratio of 0.83 with a wide confidence interval of 0.71 to 0.97. I think this point we should not be focused. We should not be focusing on the all-cause death or the cardiovascular death. My point is basically the heart failure component, acute worsening, as well as the continuous symptomatic improvement of the patients on top medical management and device therapy. This medicine has got an additional benefit over the placebo. That was the result. And what about the safety? From the previous trials, we had so many concerns regarding this molecule, this group of molecules, these gliflozins. And these safety concerns were analyzed in these trials also. Patients exposed to at least one drug were analyzed. So adverse events, volume depletion, because this drug has got an osmotic diuretic property. So volume depletion leading to BP fall or elevation in creatinine can happen. But when compared to DAPA to placebo, there was no significant difference in these two groups regarding the volume depletion. And renal adverse events, again 6.5 versus 7.2. When fractures were similar, it can cause osteoporosis. Then amputation, in canagliflozin study, we know that there was slight increase in the amputation rate. And again, in DAPA study, this heart failure study, it's only 0.5 and 0.5, both are same. Major hypoglycemia is the same in both groups. And diabetic ketoacidosis, because of volume depletion, diabetic ketoacidosis can occur, but still it is not significant. So adverse events leading to treatment discontinuation was similar, and any serious adverse events, including death, was also similar in both the groups. And volume depletion, again, if we are taking it separate, depletion serious, because both the groups didn't have much difference compared to DAPA and compared to placebo. DAPA didn't have much increase in the volume depletion. Then renal safety. The previous studies showed that over a long-term period, the renal function is stabilized because of gliflozins. But in the acute setting, it can cause reduction it can produce acute kidney injury because of the compounding effect of diuretics with this drug. So the renal safety is separately measured, assessed, and the renal adverse events were the same in both the groups, 153 versus 170. Serious renal adverse events were much less in the DAPA group, which was much significantly reduced in the DAPA group. And renal adverse events leading to discontinuation is same. And serious acute kidney injury was also much less in the DAPA group. And what we look, these are the acute presentations. And what about the long term, over a period of time, how the creatinine goes when we are starting this patient on DAPA? That is the doubling of serum creatinine. The doubling of serum creatinine was much less in the DAPA group compared to the placebo group, and it is actually significant, statistically significant. So altogether, then the next problem that we used to see was the recurrent urinary tract infections and genital infections, especially candidiasis in females. And compared to placebo, urinary tract infections and urosepsis was similar to placebo in the dapagliflozin group, and there was no significant difference between these two groups. But if you see the genital infections and the side effects on genital infections leading to discontinuation, it was there in the dapagliflozin group. Basically, it was the genital candidiasis in this trial. Then hypoglycemia, decay, and Fournier's gangrene, all these are potential side effects of DAPA. And major hypoglycemia, we already discussed, there was no significant difference between these two groups. And diabetic ketoacidosis, it was not, there was a non-significant increase in the DKA in the study group. And Fournier's gangrene actually happened in the placebo group, not in the DAPA group. It was only one case. So all these complications happened in the diabetes subgroup, basically because they are more prone and there will be additional drugs on top of this to cause the hypoglycemia. Then subgroup analysis to compare the diabetics versus non-diabetics. This is the question of the study, whether this drug is effective in non-diabetes, whether it is as good as in the diabetes population. So in the diabetes population, the hazard ratio is 0.75. And in non-diabetes, it is actually 0.73. So it's more effective or equally effective compared to the placebo to prevent the cardiovascular death, heart failure hospitalization, and urgent heart failure visits. So this drug is effective, and the benefit of this drug in the heart failure patient population is independent of its diabetes control, and it is may be independent of its diuretic effect. It has got some other mechanisms. So many postulated mechanisms are there for these benefits for DAPA and other gliflozins. Benefit seen irrespective of EGFR status. That's another point. Some studies show that the benefits of gliflozins decreased when the EGFR is coming down, especially it is close to 30 ml. But in this study, even if the EGFR is less than 60 or more than 60, the benefit is almost same. And this is very well depicted in this picture. As the EGFR is coming down, the benefit is improved. This is better. DAPA is better than the placebo. Here, the DAPA is far, far better than the placebo, and the hazard ratio is 0.4. So there are studies and there are sub-analysis and meta-analysis showing that gliflozin's effect comes down, especially its anti-diabetic effect comes down when the EGFR is coming down. But its heart failure benefit is not coming down with the reduction in the EGFR. Then there is an interesting point that we already discussed. That is a 44% reduction in the incidence of acute kidney injury that I already showed the data. That the DAPA group, it is 1.8%, and the placebo group, it's 3.2%. And DAPA reduces the acute kidney injury. So in the nutshell, the take-home message from these trials, these data, is that DAPA, gliflozin, and all other gliflozins, maybe, we don't know, reduces heart failure admissions and death. It reduces heart failure symptoms that is happening in between these acute heart failure admissions. And it is safe to administer this drug. It is renally safe. It has got very good side effect profile. and it is effective in both diabetics and non-diabetics. That is the point. And we should watch for the volume depletion, and we should watch for the DKA, and we should estimate the EGFR frequently to avoid complications. And in my experience, that happened in actually 2.5 years back, I remember. A patient was on all the medical therapy, but she was not at all improving. It was an ischemic cardiomyopathy with severe obstruction. And I started the patient on Jardiance and empagliflozin. And she improved. And after around 2 to 3 months, because of the cost of Jardiance, they requested me to stop Jardiance. I stopped Jardiance. The next week, she got admitted with acute pulmonary edema. Then I restarted her on Jardiance again. Then again, this patient was on Jardiance. Again, I stopped the medicines personally without telling them. The patient again got admitted. Third time, when I was asking them, this is costly, should I cut it down? They so told that you can cut all the medicines, but not Jardiance, because whenever you are cutting Jardiance, she is getting admitted and we are losing a lot of money on admission. So that is my personal experience regarding the liflozins. And regarding the where we should, sorry. When to start liflozin for heart failure? That is the difficult question that now we have. In my practice, what I'm doing is, all diabetic patients, if they have symptomatic heart failure, I used to start liflozins before the ARNI, that is the sacubitril/valsartan combination, because both are costly, both has got definite benefit in heart failure, but this has got an additional benefit because the patient is diabetic. We'll get a better diabetic control, weight loss, and all those things. And definitely before devices in patients with diabetic symptomatic heart failure. Whereas in non-diabetic symptomatic heart failure, I prefer to start ARNI first, then I'll go for gliflozins, definitely before the devices. These are my thoughts on when to start gliflozins without any evidence, without much evidence from the literature. Thank you so much for the patient listening. I hope I'll get more information from you because you all are using this medicine more than us.
Thank you so much, Dr. Taisin, for this elaborative on the study of DAPA-HF. I think we were never surprised, and now also I'm never surprised because SGLT2 molecule has been taken over more by the cardiologist than by the endos or the physicians or the other groups. Just because considering the pleiotropic benefits what it has, leaving the glycemic. So of course, we are not so much concerned or not enthusiastic about the glycemic benefits, but we are definitely looking at the other pleiotropic benefits which the entire group has. And even the 2018 ADA ESD consensus have also clearly endorsed on what you were saying, that if you have any patients with diabetes with pre-existing history of heart failure or CKD, then after metformin, it has to be SGLT2 inhibitors. So thank you so much for that elaborative lecture. And then over to you, Dr. Sabir.
Thank you, Faraz. Thank you, Dr. Taisin and Dr. Amendra sir, for their wonderful lectures. If there are any questions to Dr. Taisin, I think we can take it now. Just one question. Dr. Faraz, you need to comment something?
Okay.
No, if there are no more questions, I think we'll go straight away into the next session.
I think he has already answered
Faraz,
most of
it's
them.
not clear audio.
Yeah, I think we will go to the next session.
Okay, perfect. So we'll move on to the next session. Next session is something related to the role of vitamin B12 and vitamin D in metabolic syndrome. So for this, we have an eminent speaker from Cochin, Dr. Bobby K. Matthew. Dr. Bobby Matthew is my very close friend. He's the senior consultant endocrinologist at Wellcare Hospital, Cochin. He did his DM from KEM Mumbai, and I think his presentations, way of presentation and way of lecture is very peculiar and very interesting, and it's attracting hundreds of many medical professionals. So he has presented papers in more than 100 national and international conferences. Over to you, Bobby.
Yeah, slide show. Slide. Slide sharing, Shabira.
Just, yeah. Can you please share that slide, Bobby?
Yeah.
You can share it. Yeah. Okay.
You are seeing the slide. Can I start?
Yeah. You just make it on that PowerPoint mode.
Shabir, is it correct?
Perfect. Go ahead.
Only 20 minutes, no? Yeah. So
yes, something about 20 minutes.
Something about metabolic syndrome, vitamin D and vitamin B12, nothing. 90% of diabetes that we see is type 2 diabetes and 10% is type 1 diabetes. We know that type 2 as well as type 1 diabetes is on a rise. Open Harrison used to tell us that 90% of type 2 diabetes people have a BMI more than 30. That is known as diabetes or metabolic syndrome. Now, invariably, we know Indian studies have shown that up to 50% of the type 2 diabetic that we see in our OPD doesn't have a BMI more than 30. Up to 50% of type 2 diabetes that we see in our OPD have a BMI between 23 to 30. Many times we see morbidly obese ladies coming to the OPD with a body weight of 120 kilogram. We think that they'll be coming for evaluation of HbA1c. You check their HbA1c, it comes to be 5.5 or 5.6. They'll be showing you 0.5 or 5, thinking that subclinical hypothyroidism is causing weight gain. You look at this lady having massive amount of fat in her abdomen, thighs, breast or buttocks, but her HbA1c is hardly 5.5. By the side of this massively obese lady, maybe a thin calcic husband who will tell you, no doctor, she's not diabetic, doctor, I am diabetic. I checked my HbA1c 3 months back, my HbA1c is more than 9. This guy with a small pouch of abdomen has an HbA1c more than 9, whereas this lady having a massive amount of fat in her breast, thighs or buttocks hardly have an HbA1c of 5.5. That is known as a thin, obese Indian phenotype. An Indian may be looking thin externally, but he or she can be obese internally. Just to understand that, think of a person like me, age 43, 44 years, with an abdominal girth 95 centimeter, with a grade 2 obesity. You take a US citizen with the same abdominal girth as that of me. You take a CT scan abdominal L4, L5 level of me as well as the US citizen. Indian with the same abdominal girth is thought to have 3 to 5 times much higher visceral or intra-abdominal fat mass compared to the Western person. That is, an Indian may be looking thin externally, but we are obese internally because of the increased piling up of visceral fat. This itself explains why 99% of Indian type 2 diabetes, the moment you diagnose a type 2 diabetes, you go for an ultrasound abdomen, it shows a grade 1 to grade 2 fat liver disease. That shows that our subcutaneous fat is less, whereas our visceral fat is much more higher. And abdomen, if you have high chance of type 2 diabetes compared to female having a largest amount of fat in their thighs, breasts, or buttocks. So basically understand, we all studied in MBBS, abdominal fat is divided into two components: subcutaneous fat that is behind our skin and visceral fat that is yellow fat in and around the omen. Subcutaneous fat is an inert fat. It doesn't cause any complication at all, but visceral adipocyte is thought to be highly metabolically active. That is, triglycerides stored in the visceral adipocytes gets easily broken down to glycerol and free fatty acids. And these free fatty acids drain directly via portal circulation to the liver, causing a hepatic insulin resistance and fatty liver. That is, our subcutaneous fat drains to the peripheral capillaries, whereas our visceral fat drains to the liver, causing hepatic insulin resistance. This explains why liposuction, which is a cosmetic surgery to reduce our body weight, never controls our HbA1c, whereas a bariatric surgery, either a banding or a bypass, which reduces the visceral fat, reduces the HbA1c. That is, liposuction is a cosmetic surgery, whereas a bariatric surgery is a metabolic surgery. Second point, understand, when we all used to study for MBBS MD, we used to think that thyroid gland is the largest endocrine gland in the body. Now we know it is the adipose tissue, which was once considered a waste energy depot, that is now considered to be the largest endocrine gland in the body, because adipose tissue produces a host of hormone, right from leptin to resistin to adiponectin to angiotensin to estrogen. Leave it. Basically understand Indian is having a thin obese Indian phenotype. So whenever you see an Indian with a BMI more than 23, you see or you check all the parameters of metabolic syndrome that you examine for a Western person with a BMI more than 30. It is not the subcutaneous fat that is important, it's the metabolically active visceral fat that contributes to metabolic syndrome, insulin resistance, and type 2 diabetes. Now we know fatty liver is having a major chunk in the counterpart of metabolic syndrome. Suppose you are having a female who comes to a gynecologist for evaluation of PCOD. She is doing an ultrasound abdomen, not an ultrasound pelvis. It shows a grade 1 to grade 2 fat liver disease with a PCOS. So invariably, the patient or a young lady, 25-30 years, is having a fat liver disease. You are first asking the patient whether she has any history of alcohol in the exitals. She has never taken alcohol in her life. You are doing the hepatic markers, HbSAg, anti-HCV, ferritin, all the hepatic markers are negative. You are doing the LFT. LFT shows SGOT, STPT elevated. So ultrasound showing a grade 1 to grade 2 fat liver disease with an LFT showing SGOT, STPT elevated. That's a pure NASH. How do you deal with the NASH now? Diet, exercise, weight loss reduces NASH by 31%. Metformin 850 mg BD reduces NASH by 58%. Pioglitazone, which was once thrown out due to the bladder controversy, osteoporosis controversy, is now considered the drug of choice of NASH. Pioglitazone in dose of 30 to 45 mg reduces NASH by 75%. So metformin reduces NASH by 58%. Pioglitazone reduces NASH by 75%. Statin, fibrate, vitamin E, 400 mg BD, Orlistat, and the SGOT inhibitor can reduce NASH by 20%. And understand, don't think that every person with an ultrasound showing a fat liver disease is going to die of a fat liver carcinoma or a liver failure person, nothing. 75% of the people with a fat liver disease die of nothing but a coronary artery disease. 20% die of cancers other than liver cancer. Maybe a CA breast, CA colon, CA endometrium. Only 5% of the patients where your ultrasound or LFT shows a fat liver disease going to die of a hepatocellular carcinoma or a liver failure or a ketogenic cirrhosis. So fat liver is a marker of metabolic syndrome, insulin resistance. Your diet, exercise, metformin, pioglitazone, statin, and vitamin E is going to prevent your fat liver from progression to ketogenic cirrhosis and hepatocellular carcinoma. And now the concept of metabolic syndrome that we know: abdominal obesity more than 80 centimeter in a female, more than 90 centimeter in a male, a fasting blood sugar more than 100, a BP more than 130 by 85, a triglyceride more than 150 in both male and female, and HDL less than 40 in a male, less than 50 in a female. This you and me knows because we have been studying in Harrison or Davidson right from 1995, the Evans criteria or the three-quarter even. What is the extended criteria for metabolic syndrome? Look at this. Now these are the extended criteria for metabolic syndrome: hyperuricemia, NASH, hypogonadism, increase in small dense LDL, microalbuminuria, polycystic ovary syndrome, obstructive sleep apnea, and subclinical hypothyroidism. Don't go into it. Just understand, an obese person coming to you with high uric acid is no longer gout. It is a part of metabolic syndrome. Your diet, exercise, weight loss, metformin, pioglitazone, losartan potassium or telmisartan, your SGOT inhibitor, your DAPA, CANA, EMBA, as well as fenofibrate, everything, and bring down your uric acid to a level less than 6 milligram. An obese person, a middle-aged guy, 35 or 40 years, coming to you with decreased libido with an erectile dysfunction, where you are checking the total testosterone, it is coming to be less than 3.5 nanogram per ml. That is also a part of metabolic syndrome. You ask the patient for a diet, exercise, and weight loss and reduction of the BMI from 40 to 25, testosterone invariably increases because of the reduction in insulin resistance. And subclinical hypothyroidism. Look at the last sentence which I have written. The extended counterpart of metabolic syndrome is hyperuricemia, NASH, hypogonadism, increase in small dense LDL, microalbuminuria, PCOS, and subclinical hypo. We know that whenever you see a TSH more than 10, it should be treated. It is known as overt hypothyroidism. A TSH 4.5 to 10 in between is known as subclinical hypothyroidism. You treat the subclinical hypothyroidism with a TSH between 4.5 to 10 if your antibody is positive. If your antibody is negative, you treat the subclinical hypothyroidism when there is goiter or the patient is having infertility treatment or in pregnancy. Why did I tell that? Even now, females come to the OPD and tell the doctor, I am having hypothyroidism. I'm taking thyroxine, doctor. My TSH is 1, but still I am not losing weight. Even now, because just like the sir was telling about the statin controversy, even now physicians sends patient to an endocrinologist think that she's hypothyroid, not gaining weight. So do the metabolic evaluation. Does hypothyroidism actually cause weight gain? Now studies have shown that the maximum weight gain associated with severe, long-lasting, untreated hypothyroidism with a TSH of more than 100 is thought to be between 1.5 to 2 kilograms. If the maximum weight gain in a person who is living with a TSH more than 100 is 1.5 to 2 kilograms, the maximum weight gain associated with subclinical hypothyroidism between TSH of 4.5 to 10 is thought to be somewhere between 20 to 40 grams. So hypothyroidism is the most common association of obese ladies. Ladies gain maximum weight after pregnancy and most common time period in the life of a female where hypothyroidism due to Hashimoto occurs also in the postpartum period. So hypothyroidism never causes obesity, vice versa. Obesity can cause subclinical hypothyroidism due to leptin resistance. So whenever you see a TSH 4.5 to 10 with antibody negative in an obese person, don't start thyroxine. Ask the patient for a diet, exercise, weight loss, and metformin, and even bariatric surgery can reduce the TSH to normal. So understand, metabolic syndrome doesn't mean that the patient is just obese. It's a syndrome beyond diabetes, hypertension, hyperlipidemia, where you have increased risk factor for all these factors. From this, I'll be going to vitamin D. Now I have only 30. So basically, vitamin D we all know, but what we forget is what we have studied in MBBS, in Ghana, on Guyton, the basic thing. Even now we know some doctors get confused whether to like shell cal, what is the calcium. Some people write shell cal CT, some people write shell cal HD, and how much dose of vitamin D should be given in pregnancy, how much dose of vitamin D in a menopausal lady. Suppose my mother, 70 years, coming with osteoporosis, what's the dose of vitamin D? The absolute criteria many times people forget. So basically, understand about vitamin D, go through this slide, what you have taken from Ghana only. Sunlight falling to the skin, it converts 7-dehydrocholesterol to cholecalciferol, that is vitamin D3. The form of vitamin D3 that is present in almost all the calcium preparation that we write, right from shell cal to McCalvit to D-Rice to D3K tablets, everything contains vitamin D3 or cholecalciferol. Cholecalciferol gets 25 hydroxylated in the liver to form 25 hydroxy vitamin D3, and 25 hydroxy vitamin D3 gets 1 alpha hydroxylate in the kidney to form 125 dihydroxy vitamin D3, that is calcitrol. So understand two things. Vitamin D3, suppose you take a shell cal tablet, which you all have been hearing for the past 35 years. My mother probably has menopausal lady for past 20 years. She has been put by an orthopedician on shell cal for past 20 years. She still continues that. So what does shell cal 500 contains? It contains calcium carbonate 500 milligram with 250 international units of vitamin D3 or calcium or cholecalciferol. And what is calcitrol? Calcitrol is shell cal CT, or calcitrol is always in 0.25 microgram, whereas vitamin D3 or cholecalciferol, it is 500, 1000, 2000 or 60,000 that we see. In the conditions you require vitamin D, let it be rickets, let it be osteomalacia, let it be osteopenia or osteoarthritis, you have to take vitamin D3, not calcitrol. Suppose you have a small child at the age of 5 years coming to with bilateral rickets, just like the practical patient I saw 3 months back before lockdown when I was in Dubai or Sharjah, a young Arab lady bought their third child, 5-year-old boy, who was having bilateral nutritional vitamin deficient rickets with bilateral genu valgum. Serum calcium was 5.5, phosphorus was 2.2, alkaline phosphatase were around 15,000. X-ray risk shows metaphyseal cupping, fraying, widening, what all we study for MBBS. They are taken to an orthopedician. Orthopedician was giving the equivalent of shell cal, international brand osteocare tablet, 500 milligram 3 times daily, and the calcitrol capsule, 0.25 microgram 3 times daily. So the boy, 5-year with nutritional rickets, was diagnosed with a calcium 5.5 3 months back. She came to me in March of 12th before lockdown when I came here. So that time the child's calcium was 10.1 milligram percentage. Calcium increased from 5.5 to 10.1, but still the child was having painful bilateral genu valgum. So that is not a vitamin D supplementation. So that child should be put on injection of araquitol or vitamin D3, 3 lakh single IM shot, or a 60,000 of vitamin D3 sachet, 1 sachet per week for 6 weeks. Because whenever you give vitamin D, that will be 25 hydroxy to 25 hydroxy vitamin D3 and 1 alpha hydroxy to 125 dihydroxy vitamin D3, and rickets can be cured. So your calcium can be corrected with calcitrol, but your vitamin D deficiency can never be cured. Only 2 conditions where therapeutically 125 dihydroxy vitamin D3 or calcitrol is approved by US FDA is hypoparathyroidism and renal osteodystrophy. Understand? Normally, when you think of vitamin D, it is vitamin D3, araquitol, the same, always 3 lakh or 6 lakh IM. We get at 22 rupees, or a D-Rice sachet or with D3 60 tablets, which you get for 20 rupees. Calcitrol is whatever shell cal, CP, gem cal, whatever preparation. It is 500 milligram of calcium carbonate with 0.25 microgram of 125 dihydroxy vitamin D. That is required in hypoparathyroidism, renal osteodystrophy. The same scenario. 3 weeks back, I had a patient admitted to the hospital with very bad carpophotic spasm with seizure. The patient had done a total thyroidectomy for a papillary carcinoma thyroid 3 weeks back. So after the total thyroidectomy, the surgeon had put her on a shell cal or whatever McCalvit tablet 3 times daily. 5th day, she had a very bad carpal spasm with some amount of stridor. She was taken to the local hospital. There was she was given 10% of 10 ml calcium looked at 3 times. And on the third day, again, the stridor and carpal spasm continued. They phoned the surgeon. Surgeon asked to increase the shell cal tablet 111 to 333. Again, after 5 days, she had a mild amount of tonic-clonic seizure. The surgeon told, no problem, increase the calcium to 555. So the patient was taking shell cal, 500 milligram, 5 tablet morning, 5 tablet noon, 5 tablet in the evening. That is 15 tablets per day. Still, when the patient got admitted with very bad carpal spasm, with a stridor, the calcium was fine. What is happening? Because that is hypoparathyroidism. How much dose of vitamin D3 you give? There is no parathyroid type PTH or parathormone to convert the 25 hydroxy vitamin D3 to 125 dihydroxy. That is the condition where you require calcium. That patient was converted from simple shell cal 500 milligram 555 to shell cal CT, 1 in the morning, 1 in the noon, 1 in the evening. Third day, the patient calcium rose up to 8 and the patient was discharged. So understand, simple vitamin D, simple calcium, anything area vitamin D, nothing. The simple thing, the formulation state. So vitamin D3 is there, 125 dihydroxy vitamin D3 calcitrol, that is in 0.25 microgram. Give it in conditions of hypopara or renal osteodystrophy. We know that we get vitamin D from sunlight. But what is the actual hours of sun exposure that is required per week for adequate vitamin D synthesis? Understand it's clearly all the guidance. You require 2 hours of sun exposure per week in a person who is fully covered with exposure of the face and dorsum of hand and feet, or you require 30 minutes of sun exposure per week in a person who is wearing only a diaper. So in a person who goes to the OPD, we are wearing a full kai shirt and pants with the shoes. We get sun exposure in the face, that too if you look upwards, or the dorsum of hand only. Feet is also covered by shoes. The average time requirement for vitamin D synthesis per day is 18 minutes of sun exposure. Average time exposure for sunlight exposure time for an Indian dog is thought to be somewhere between 1.5 to 2 minutes. So you can't go to the sunlight in 11 to 3 o'clock and remove your shirt and go and get a sunlight of 18 minutes. 99% of we doctors or whatever in-house treatment doctors should take vitamin D supplementation. And what is the best time to get a sunlight for adequate vitamin D synthesis? It is the early morning sunlight of 7 to 9 or mid-noon sunlight of 11 to 3. Even now we have seen many times doctors, no problem, morning sunlight is very good. No, early morning sunlight 7 to 9 is UVA, which we have studied 320 to 400 nanometer. That is for PUA therapy for psoriasis and vitiligo. Whenever you have to synthesize vitamin D by getting sun exposure, it's the mid-noon sun exposure between 11 to 3 o'clock. So that is the UVB of 290 to 320 nanometer. That you have to get 18 minutes of sun exposure per day. So basic things, understand clearly. Vitamin D3 is cholecalciferol. That is the shell cal, metcal with D-rise with D360K. Calcitrol is your CT preparations where you give only for hypoparathyroidism, renal osteodystrophy. Suppose you want to get adequate sunlight exposure and synthesis vitamin D by your skin yourself, go and stand in the sunlight between 11 to 3 o'clock, get UVB of 290 to 320 nanometer for at least 18 minutes. In spite of adequate sunlight exposure, vitamin D synthesis may be poor in black skin people, people wearing parda, elderly people, obese people where vitamin D is getting sequestrated, people in the urban population because of the ozone layer and winter climate. And how do you check vitamin D? Suppose you have a form of DDRC or a Medivision or a Metropolis, you have 3 fitting vitamin D3, 25 hydroxy vitamin D3 and 125 hydroxy vitamin D3. Whenever you have to check for the vitamin D store in the body, always check the last sentence. It should be 25 hydroxy vitamin D3, which gives the maximum faithful representation of vitamin D store in the body. So 25 hydroxy vitamin D3 has a half-life of 2 to 3 weeks, whereas 125 dihydroxy vitamin D3 has a half-life of 6 to 8 hours only. So whenever you have to check vitamin D status of your child or your pregnant wife, of your grandmother or a mother who is osteoporotic, always write 25 hydroxy vitamin D3. And this slide, understand, these are all international recommendations now by international endocrine associations. So basically understand each sentence, the minimum level of 25 hydroxy vitamin D3 for the skeletal, non-skeletal effects is 30 nanogram per ml. So minimally it should be 30, preferably it should be 40 to 60 nanogram per ml. And vitamin D level less than 20 nanogram per ml is vitamin D deficiency, 20 to 30 is insufficient. Just understand 2 things. Minimum level is 30, preferably keep your vitamin D level 25 hydroxy vitamin D3, 40 to 60, less than 20 is deficiency. And understand the last sentence, you require 2000 to 4000 international units of vitamin D3 intake per day to keep your 25 hydroxy vitamin D3 in the preferable range of 40 to 60 nanogram per ml. What is the importance of this? Whenever we used to study, I finished MBBS Preventive Medical in 93-99, MD Preventive Medical in 2000-2003, that time MCQ, the frequent question taken from SPM part, what is the RD of vitamin D 20 to 50 years, 200 units, 50 to 70 years, 400 years. So we have never heard a dose of vitamin D more than 400 international units. Now we know you require at least 2000 to 4000 international units of vitamin D3 per day to keep your 25-hydroxy vitamin D in the preferable range above 40 to 60 nanogram per ml. Suppose the whole shell cal preparation you are taking, it contains only 250 IU of vitamin D3. So my mother is having 70 years. She requires 2000 IU of vitamin D3. She has to take 8 tablets of shell cal. That will give her 4 gram of calcium as well as 2000 IU of vitamin D3. So she doesn't require that. That is why now the newer preparations of VD, Caltayo, everything contains 2000 IU of vitamin D3 plus 1000 milligram calcium. So always understand the minimum requirement of vitamin D3 per day, irrespective of age, right from a newborn child to an elderly of 100 or 120 years, is somewhere between 2000 to 6000 units. Average in an Indian is 2000 to 4000 units per day. And understand about this slide. Vitamin D is Kumar and Clark Davidson, same side. Look at the left side. Vitamin D is implicated in the pathogens of dementia, to depression, to schizophrenia, to upper respiratory infection, to lower respiratory infection, to tuberculosis, to coronary heart disease, to bone pain, to muscle weakness, to osteopenia, to osteoporosis, to osteoarthritis. Leave it. You know that vitamin D is a sunshine vitamin. You are not getting vitamin D by sunlight, or it's a cloudy climate, you are in the urban city, or winter climate is that. Take a vitamin D. It is not like promoting a growth hormone which may cost you 50,000 per month. It is not like promoting a newer insulin analog which may cost you 15,000, or a Victoza which costs you 12,000 per month. It is just a simple tablet which costs you 20 rupees per week. A vitamin D tablet per week or a sachet per week costs you 20 rupees. So weekly once for 8 weeks, followed by one sachet or tablet per month. So annual treatment may cost only 250 rupees. So no controversy about vitamin D. Some benefit somewhere, maybe dementia, depression, osteopenia, your muscle contractility, your memory, your Parkinson's, your corona. You get some benefit, go for it. As doctors or healthcare practitioners, we should not have our vitamin D less than 40, preferably keep it 40 to 60 nanogram per ml. And understand this slide, because I have to go for vitamin B12 also. So basically understand this slide. This is got upper respiratory infection, coronavirus, and vitamin D level. Whenever you keep your vitamin D in the preferable range of 40 to 60 nanogram per ml, you can reduce the upper respiratory infection, especially viral infection of croup or bronchiolitis in child, by 90%, reduce the chance of influenza by 27%, and reduce the chance of pulmonary tuberculosis by 50%. What more you need? Vitamin D has a pivotal role in reduction of infection, especially upper respiratory infection. I've told you macrophages contains and 1-alpha hydroxylase. Whenever you load with vitamin D, this 25-hydroxy vitamin D in the macrophages get converted to 125-dihydroxy vitamin D3, which increases the leukocyte activation, chemotax, and phagocytosis. And invariably, we know vitamin D promotes cathelitin, whatever. It's an inflammatory cytokine, but it is an anti-inflammatory or antimicrobial peptide per day. So whatever studies in coronavirus and vitamin D, with Joe Dev representing that, go for the next slide. So basically, internationally now for the past 8 months, so many studies have been conducted comparing severity of corona with vitamin D. Invariably, all the studies have shown that people with the most severe of the coronavirus infection or corona complication at the lowest level of 25-hydroxy vitamin D level, and people with the highest level of 25-hydroxy vitamin D3 as the least severe COVID virus infection. So basically, what to lose? What the controversy? Let the studies come after 3 years, 5 years. Let the vaccine come after 6 months. But suppose you and me are deficient in vitamin D without checking itself. As an Indian, we know 99% of Indians have high melanin content in the skin. We are vitamin deficient. Take a vitamin D tablet once in a week for 8 weeks. That's a loading dose in an adult above 18 years. And after 1 tablet per week for 8 weeks, take a 1 tablet per month in summer climate and 2 per month in winter climate. That's a maintenance therapy. So invariably understand upper respiratory infection, lower respiratory, including viral, bacterial, fungal. Everything can be reduced by keeping your vitamin D not at 30, preferable range of 40 to 60, at least above 50 nanogram per ml. And now vitamin D supplementation, which I've told you, but hypervitaminose D is getting a norm nowadays, because Harrison used to say 90% of hypercalcemia invariably in the clinical practice is due to primary hyperparathyroidism or MIH, malignancy-induced hypercalcemia. Now look at the last 2 editions of Harrison. They've changed it. 90% of hypercalcemia in clinical practice may be due to hyperparathyroidism, malignant-induced hypercalcemia, which is PTH independent, or it can be due to hypervitaminose D, because people are getting bombarded with vitamin D. 1 minute I record before going to vitamin B12 and finishing in 3 minutes. Basically, 2 weeks back, I had a nursing staff, that's a sister, a non-sister admitted with hypercalcemia, where PTH was undetectable. Calcium was 14. Sister developed severe polydipsia, polyureters, hyperreflexia. When the neurologist did a calcium, it was 14. He did a PTH. PTH was 0, undetectable. He suspected that she's an elderly and maybe a breast cancer. They did for mammography, multiple myeloma, urine BJP, everything was negative. They did a whole body MRI and 18 FDG PET also. Everything didn't show a focus of calcium cancer for a PTH-RP production. Invariably, the patient came. We just did a 25 hydroxy vitamin D. It was 600 nanogram per ml. We just asked the sister to just mail from the whatever her institution, the whatever chart she has been treated. She went to an orthopedician 2 months back with a back. Orthopedicians gave 2 injections, one of over and 50 milligram with a vitamin D3 Arakitol 6 lakh. The physician had already put her in a menopausal phase with a Viddical 2000 interactions per day, and the gynecologist went for some tiredness and hot flush. She again put her on a vitamin D3 sachet, so 1 sachet per week. So none of the doctors were looking at the back chart. The orthopedician has already given 6 lakh IM of vitamin D3. The physician is already giving Viddical tablet, 1 tablet per day. On top of that, the gynecologist invariably added a 60,000. 3 type. One is an injection, second is a tablet, third is a powder. So sister told that these 3 are different formulations for the back pain, myopathy. Ultimately, she landed in very bad hypercalcemia with a calcium more than 40, and she has to be dehydrated. And the drug of choice for hypercalcemia due to hypervitamin D is hydrocortisone. You can give higher dose, even up to 100 milligram of hydrocortisone per day, because vitamin D is a fat-soluble vitamin. Just like organ of phosphorus poisoning, it can accumulate in your body for months and get corrected later. Finish, Shabir. How many minutes there? How many minutes there?
It's already over, so we can you can take 2 minutes. Okay.
Yeah, with vitamin D is over. Now I'll go to the last. B12. But basically understand what is vitamin B12 important. Go for the vitamin B12 first slide and last slide. So vitamin B12 is cobalamin. Understand this first sentence only. Vitamin B12 RDA per day is 1 microgram per day. So whenever we take vitamin B12 tablets, all the Neurabion, for Remylin D, Metildia, all the tablets contains 1000 microgram of vitamin B12. That shows that even though your required dietary allowance is 1 microgram per day, you require such high quantities of methylcobalamin to keep your vitamin B12 level normal, because the inconsistent absorption of vitamin B12 in the intestine. And vitamin B12 is exclusively got from non-veg food. Meat, milk, fish, egg. That is why now the Indian studies have shown that up to 80% of Indian vegetarian people above the age of 50 years have a vitamin B12 level less than 200 picogram per ml. Don't think that the classical definition of vitamin B12, which we study for MBBS, a hypersegmented neutrophil MCV more than 100 microgram per whole cube, that is never got. Whenever you have a patient with a vegetarian diet or long-term metformin or long-term omeprazole, pantoprazole, just go for a vitamin B12. Vitamin B12 level less than 200 picogram per ml is diagnostic of vitamin B12 deficiency. More than 400 picogram is against. 30% of people on long-term metformin may have 30% decrease in the vitamin B12 level. And understand B12, don't look at macrocytosis, hypersegmented. Just check vitamin B12 in every person above 50 or every person above 60 with a vegetarian diet with a long-term antacid. Now, this is the last slide of vitamin B12, Shabir, don't worry. So whenever you are checking a patient, there shows a vitamin B12 less than 200 picogram per ml. Always give an oral B12, maybe a Remylin D or Remylin D once daily for up to 3 to 6 weeks. Then check the vitamin B12. If vitamin B12 is increasing, you know that's a nutrition deficiency of vitamin B12. Suppose you are giving vitamin B12 orally, still your vitamin B12 less than 200 picogram, then think of pernicious anemia, the most common cause of vitamin B12 deficiency on earth, 1 in 100 people. During your MBBS days, you used to do a Schilling test. Now nothing, just to diagnose pernicious anemia, if your vitamin B12 is persistently low, just write an anti-parietal cell or anti-intrinsic factor antibody, which costs you only 1,100 rupees. Once pernicious anemia is diagnosed, give an injection, methylcobalamin. Just understand those. Methicobal, 1000 microgram IM weekly for 8 weeks, followed by 1000 microgram IM monthly lifelong. So basically, this is in short about metabolic syndrome, vitamin D, vitamin B12. I just concise, but at least one point, maybe major doctors are hearing, maybe some practicing doctors are starting practice, at least understand thin obese Indian phenotype, difference between vitamin D3 and 125 hydroxyvitamin. At least when you have a patient with hypopara, don't bombard vitamin D, just put a calcitrol preparation. Whenever you get for sunlight exposure, it's mid-noon sun exposure, not elderly, and invariably every person for 60 years, 1/3 are having vitamin B12. Every person on long-term metformin, vegetarian people, definitely check the vitamin B12 level. You may have serious clinically improvement mentally, neurologically, physiologically, myopathy, everything may include in the vitamin B12 supplementation. Finish, Shabir. Thank you.
Thank you, Bobby, for that wonderful lecture. So I think everyone has understood what exactly is vitamin B12, vitamin D, and all, and its role in metabolic syndrome. Any questions or any comments? I think we can have just one question. Mohanad sir, do you have any comments?
Hello, Shabir.
Yes. Any question or clarification?
Can I
sir?
have one question? Hello.
What's it? Yes.
Can I have a question?
Yeah, please, sir, please. Balendra, sir.
Bobby,
Yes,
it
sir.
was an excellent presentation as usual.
Thank you, sir.
How many days it will take
Sir.
vitamin D3 level to become normal after you initiate treatment in a deficient patient?
Yeah. So vitamin D3, if you are giving an injection of araquitol of 3 lakh or 6 lakh, vitamin D can become normal as early as 2 weeks. If you give a vitamin D tablet 1 per week or sachet 1 tablet, it may take up to 4 weeks for vitamin D to get normal. But there's a fallacy. You are giving 1 tablet per week for 8 weeks. At the end of 5th week, you are checking than 100 nanogram per ml. Then many people think that hypervitaminous, they immediately stop it. No, you give 1 tablet per week for 8 weeks, then enter a maintenance therapy of 1 tablet per month in summer and 2 per month in winter climate. Then only check the vitamin D3. In the loading phase, after 5 weeks, you check, it will be 100 nanogram. It is just like initiation of insulin. It may be low phase, then it will go. So understand, whenever you give vitamin D in dose of 2000 to 6000 units per day, there will never be vitamin D hypervitaminosity. That's why Indian studies, Shashank Joshi and in Japan, recommend you don't have to check vitamin D in any person who is given a standard dose of supplementation and maintenance therapy. You give it in people who are refractory to vitamin D, especially steroid therapy, anti-epileptic, heart therapy for HIV, long-term itraconazole users, or people with suspected celiac disease or gastrectomy patient. Otherwise, you just give 1 tablet per week for 8 weeks, 1 tablet per month in summer and 2 per month in winter, sir.
Thank you.
Any more questions? Or else we will move into the next session because already we are running short of time.
Thank you,
Thanks
Shabir.
for Dr. Bobby for the excellent lecture. Now we are moving on to the next session, that is viral topics, something regarding COVID-19 and all. To chair the session, we have 2 eminent faculties. Dr. Mohan Nair sir, he is the senior consultant physician and diabetologist from Trivandrum, and my dear friend Dr. Arun B. Nair is there. He is assistant professor of psychiatry, Medical College Trivandrum. Over to you, chairs.
So good afternoon once again, and we have a very relevant session now. It's termed viral topics. Of course, it's a viral in both sense. It's viral academically as well as it's viral pandemic that we are having, and we have excellent speakers who have basically first-hand information on how to manage these conditions. We have 3 speakers, Dr. Chandini and Dr. Sunil Prashu. Both are actively involved in the COVID management scenario in Kerala, and we have a speaker from outside, Dr. Irina from Ukraine. And I request by co-chair Dr. Arun B. Nair to introduce Dr. Chandini and continue with the proceedings. Dr. Arun, please.
Thank you, sir. Thank you, sir. So the first talk of this session is by Dr. Chandini R. She is the professor of medicine and head of Department of Emergency Medicine, Government Medical College, Kozhikode. She is the president of Hypertension Society of India. She has been very proactively involved in the COVID-19 management in institutional and state level, and she has been recognized by the government for her efforts in relation to COVID management. So she is the best person to speak about COVID because probably the person who has treated maximum number of COVID cases, or at least one of the persons who have treated maximum number of COVID cases in Kerala. So with great respect, I'm inviting Chandni Madam to start her lecture. Over to
I
you,
think she had also been honored Best Doctor Award last year. I mean, right, Dr. Chandini? Yeah, she had been awarded the Best Doctor Award, I think.
Yes.
Yes, ma'am. Perfect.
Okay, madam, it's visible, please.
Please unmute.
Ma'am, please unmute. Yeah.
It's done. Okay.
Yeah.
Thank you.
Yeah.
Thank you. Thank you, Dr. Shabir, for the opportunity to present this topic in this academic forum, and that too after the power pack presentation by Dr. Bobby Matthew. It's going to be challenging for me. And thank you, Dr. Mohan Nair, sir, and Dr. Arun for the kind words of introduction. I'll be straight away moving to the topic, that is COVID-19 and metabolic disorders. As we all agree, we are into this pandemic, and we don't know how this pandemic and where this pandemic is going to take us. Probably we'll have to live it with this virus for a long time. And we have diabetes, its own unique challenges. and we need to understand the management strategies. Obviously, we need to individualize care, and we need to stay safe. We need to take all the infection control practices for ourselves to be safe in treating these patients. And I have no conflicts of interest for this presentation. The slide is not moving. Okay. And with regard to COVID-19, this is a less known disease. And we must understand there is an asymptomatic or pre-symptomatic phase, and that is causing more infections in vulnerable group. And the death is happening due to ARDS cytokine storm and its cardiac and renal complications. And when we move on to metabolic disorders, I will not be touching all the metabolic disorders. My focus is primarily on diabetes and hyperglycemia because it increases morbidity and mortality in patients with COVID-19. And it's not only hyperglycemia, but glucose variability and hypoglycemia are also going to be challenging situations when we manage these patients. And when we look at the diabetes and COVID-19 link, risk of fatal outcome is increased due to defects in innate immunity affecting phagocytosis, neutrophil chemotaxis, and cell-mediated immunity. There is high prevalence of diabetes in elderly, and advancing age is itself emerging as a strongest predictor of COVID-19 related deaths. And on top of that, we have patients with target organ damage, obesity, obstetric sleep apnea syndrome, fatty liver, and chronic liver disease. All these are giving us challenging situations in managing these patients with COVID-19. What are the reasons for hyperglycemia in COVID-19? We know that the reasons are manifold. COVID-19 infection itself is a challenging situation and it is causing hyperglycemia. The stress involved is huge because most of the patients, when we shift them to ICU, they really believe that they are going to die. And they have seen patients asking, what is the chance? 50-50. So that is the way they are being pushed, and this is a stress involved and stress involved with the disease also. And steroid, most of them, steroid is accepted as a mode of treatment. So steroid is known to cause hyperglycemia. And many of them, because of the hypotension and the situations, we need to start them on inotropes, and it is also acting as a counter-regulatory hormone and increasing the hyperglycemia. And the predisposing factor, mainly family history, obesity, insulin resistance, obstetric sleep apnea, all these, including the autoimmunity, is causing hyperglycemia in COVID-19. And when we move on to SARS-CoV-2 infection, we know that uncontrolled diabetes affects the outcomes. We also know that improving glycemic control reduces the adverse outcomes. An increased risk of other infections in ICU if the patient is having hyperglycemia. So we should understand that diabetes mellitus is no longer an innocent bystander, and we need to understand, we need to document, and we need to tackle it on day one itself in all these patients. So that is the important message I would like to share with you. And there are unique challenges with diabetes having COVID-19 because they are at risk for more severe illness. And they may present with severe manifestations of diabetes, especially diabetic ketoacidosis, hyperglycemia, hyperosmolar state, and severe insulin resistance. So we are perplexed by the amount of insulin, the dose of insulin that these patients requiring to control in these situations. And there are enough studies, and there is enough documentation that there is severe progression in COVID-19 patients with coexisting diabetes. These patients go into severe disease, and these patients have significantly higher mortality than patients with non-diabetes when they come with COVID-19 infection. So in COVID-19, the mortality estimate is 1.4 to 2.3%, but we must understand the critical care capacities are really overwhelmed when we get more of these patients, especially those patients with comorbidities and underlying cardiovascular disease and diabetes. So we need to document comorbidities in all these patients whenever they are hospitalized. And always there is a challenge. Most of the patients may need hemodialysis, they may need thrombolysis, they may develop myocardial infarction while in the hospital. The system must have an opportunity to tackle all these issues. So we need to risk stratify these patients on presentation itself, and we need to prioritize palliative care. Which patient should go for the aggressive management and which patient should go for a reasonable palliative care considering these issues. And specific treatment using drugs of unproven benefits and adverse events. That is another challenge. We are using many drugs and we believe these drugs act in COVID-19 because most of them we use on compassionate grounds, and we don't know what is the drug interaction with diabetic anti-diabetic drugs that we have and the COVID-19 drugs that we use. And most importantly, there is a dysregulated immune response and high risk of thromboembolism that is also going to be very, very challenging in patients with diabetes mellitus. And when we know that most of our patients are having high cardiovascular disease risk, and this is all the more important and all the more severe in patients having type 2 diabetes mellitus. And we know that all these are the mechanisms, and we know that these patients are significantly prone for myocardial infarction, viral myocarditis, cardiomyopathy, and tachyarrhythmias, heart failure. So we have to be more careful in managing these patients when they come with COVID-19. And how SARS-CoV infection is really affected with hyperglycemia. We know that acute hyperglycemia upregulate ACE2 expression in cells and facilitate viral entry. And chronic hyperglycemia downregulate ACE2 in cells, hence vulnerable to inflammatory effect of virus. And expression of ACE2 in beta cells had direct effect on beta cell function, and insulin resistance is disproportionately high compared to other infections. So what does that mean? We know that the ACE2 receptors are responsible for the cell entry of the virus, and this helps in viral replication. And this virus itself and the hyperglycemia actually down-regulate ACE2. But in patients where there is upregulation of ACE2, that is happening in chronic hyperglycemia, and when there is a deficiency of ACE2, we know that the angiotensin 2 to angiotensin 1 to 7, angiotensin 1 to angiotensin 1 to 9, these are good molecules that really decrease when the ACE2 is down-regulated, and there is a high risk of acute lung injury, adverse myocardial remodeling, vasoconstriction, vascular permeability because of the angiotensin type 1 receptor, which is exposed, which is in fact blocked by our ARBs or by the angiotensin 2 is directly acting on this. And if we really able to down-regulate the ACE2, that will be beneficial in these patients, and this is not happening in patients with hyperglycemia. RAS inhibitors and risk of COVID-19 is another important topic that is very much related to hyperglycemia and diabetes, because studies have really shown that previous treatment with ACE-ARB, beta blockers and calcium channel blockers, whatever be the antihypertensive that we prescribe, there is no substantial increase in the chance of a person becoming positive with COVID-19, or there is no risk of severe COVID-19. So we don't have to really stop these drugs when the patient is having diabetes with this drugs as an antihypertensive. So drugs and COVID-19, we should understand we should continue treatment with ACI and ARB if there is no other reason for discontinuation like hypotension or acute kidney injury. But definitely we should understand NSAIDs to be avoided and avoid nebulized medication. That is what is really prescribed in patients with COVID-19 has to be followed with diabetes also. So how do these patients present? Diabetes and COVID-19, it's very, very interesting. There is myriads of presentation. And we have seen maybe about 50 to 60 patients in the ICU, but I have seen all the types of presentation with diabetes and COVID-19 in this ICU. A1C and self-monitoring of blood glucose are the only tools that we have to assess what is the duration of diabetes, what is the risk of this patient having this hyperglycemia for them as with regard to morbidity and mortality. This patient could come with stress hyperglycemia, because even with 18-year-old female, very lean, with normal BMI, with no family history of diabetes, blood glucose has been going to 200 and above. That was really perplexing with regard to management of diabetes. Pre-diabetes is very common, HbA1c between the 5.7 to 6.5 range. Diabetes undiagnosed or diabetes already diagnosed. And we also see patients with advanced disease with diabetic kidney disease requiring dialysis. While on hemodialysis, they have been admitted. There are patients with cardiovascular disease on PTCA, on CABG, coming with COVID and developing infarction, chest pain, and all these things are happening in our clinical practice now. So we need to be very careful in monitoring these patients. Hypoglycemia, especially hypoglycemia unawareness, is a very real challenging problem. So we have to be very careful when prescribing insulin in these patients. So all these patients require a very close monitoring while in ICUs. So how do we do this? Examination during COVID-19, it's very, very challenging. Communication is a real problem. So we don't have the real time to discuss with the diabetes care, diabetes management, and all those issues in patients with COVID-19. So we have to be more careful when using words, because how the words are the only way of communication in these patients, because most of the time in PPE in the ICU, people are really frightened, and we have to be very careful with this regard. An initial assessment and emergency stabilization is needed, because we need to see what is the cardiovascular and renal status and all those complications, hypertension or whatever these patients are presenting to us. And there are a lot of challenges in examination, monitoring of these patients. So we need to have proper insulin documentation, insulin charts. We need to know what was the insulin the patient is receiving for the last 24 hours, whether there is any hypoglycemic episode. So the documentation is very, very important, because patient most of the time it will be difficult to communicate. And trials to feeding, whatever be the feeds, and most of them will not have any bystanders, even in wards. We don't entertain bystanders because of the risk of transmission. So we have to know, we have to be very careful about their feeding, and we need to be very careful in avoiding hypos. So there should be strategies appropriate to the hospital when we manage these patients. And there is a list of investigation, because there is a high risk of thromboembolism, there is a high risk of pre-existing heart disease, myocarditis. All these investigations are very, very relevant and important, and we need to interpret appropriately so that we can modify the management in these patients. And what is the target therapeutic goals? It is about fasting in the 80 to 130, and PPB postprandial maybe less than 180. We don't want to push them into hypoglycemia. And what we need is an optimum glycemic goal without pushing them into hypoglycemia. And what are the drugs that we can prescribe in these patients? Metformin, if the patient is very well stabilized and a milder disease, not requiring hospitalization, asymptomatic or mild symptoms, definitely we can continue metformin, but in a hospitalized patient, always better that we stop metformin. SGLT2 inhibitor, there is a risk of dehydration and diabetic ketoacidosis, especially euglycemic DKA is well known, and we have to avoid initiating therapy during respiratory illness in all these patients, especially in the hospitalized situation or patient coming with a severe illness. We should refrain from prescribing this drug. DLP-1 analog, if the patient is already on this drug, definitely we can continue, but DPP-4 inhibitors may be safer, because there is no risk of hypoglycemia. But all hospitalized patients, it is always better and prudent that we start on insulin and maintain the glycemic status on insulin. How do we monitor? Regular self-monitoring of blood glucose is very essential, because we need to see what is pre-breakfast, pre-lunch, and pre-dinner, and we need to avoid hyposulfonylureas. Milder illness, definitely we can continue if the patient is well controlled, but be on the watch for hypoglycemia. A1C is a tool that will help you what is the type of diabetes that we are dealing with. Definitely there could be immunosuppression, autoimmunity, worsening glycemic status, and most of these patients are mechanically ventilated or drives to feeding. So feeding must be monitored, and it is all under our control what this patient is going to take, or it could be enteral feed or rice to feed. We have to monitor appropriately, and daily monitoring is the key for proper maintenance of glycemic goal. And in hospitalized patients, we can go with regular, or if the patient feed, it's not in our control, or the meal timings are different, or meal is arriving late, we can go for faster acting insulins, and NPH for the basal bolus regime will be the appropriate one. Diabetes and CKD, it's a major challenge, and we are facing it every day. Most of them are coming with CKD, with dialysis or on maintenance hemodialysis already. And I have only 2 hypos among these 50 to 60 patients with diabetes. We have managed very serious illness in the ICU. And this both 2 hypos happened in CKDs, and this is detected just by 3 a.m. monitoring. So the monitoring, I just put this because monitoring is very important, and hypoglycemia unawareness is very well documented. So we have to be very careful in managing COVID-19 and diabetes. And we have different scenarios. Patient may be neurally, so they don't need meal-related insulin. What we need is only basal insulin. There may be postprandial hikes only, especially in stress hyperglycemia, so we can balance with a bolus dose of insulin. It could be a regular insulin, or it could be a faster response or faster insulin analogs. And some patients will need only bolus insulin. So some patients will need the conventional basal and bolus regime. So we have to manage depending upon the need and depending on the type of hyperglycemia. It's not the one way for the all patients, the one prescription that will not hold good. So we have to be very careful in prescribing. So we need to understand challenges. We need to estimate our facilities, our manpower. Knowledge and chance of human errors is also very high because the people will be rotating. The manpower is a huge challenge in all of these ICUs. So there could be errors with insulin and prescription. So we have to be very, very careful. And we have to emphasize that all the people involved in diabetes care are really educated and adequately trained. Meal timings may go beyond our control. Goals we have to individualize. There is high risk of hypoglycemia. Unawareness is well known. So monitoring should be more frequent, and that is the only way that we could achieve the optimal glycemic control, and we can titrate the drug appropriately, and we need to provide psychosocial support. Vulnerable groups in elderly, especially there is delayed ED visits, there is delay in procedures because they come late, and admissions in wrong places because of dementia, because of mass clinical presentations, COVID, non-COVID, all these issues happen. And the admissions and isolation really posing a big challenge in elderly people. And missing treatment for comorbidities is really increasing the risk of death in these patients. So we have to be very careful, especially in vulnerable groups. And what are the severe disease indicators? It is just the same in COVID-19. We have to be very careful about hypoxia. We have to be very careful of the need for oxygenation, timely initiation of ventilator support or oxygen therapy. And we need to warrant long-term follow-up because it is already known that this patient go for fibrosis of the lung. So they may need long-term follow-up, and this is also the major challenge. So, okay, so this is how we need to do, and we need to individualize care. And there are positive evidence from clinical trials. So we have to use most of them compassionate and looking at the challenges, we need to optimize the dose. I have been trying to take you through some of the aspects, and most of them are known, or most of them are really, we are learning it. We need to follow up, and we need to modify our knowledge in the coming days. Thank you so much.
Thank you very much, Dr. Chandini. Wonderful presentation. And since that we are running short of time, can you please stay back till the whole session for any questions?
Yeah. Thank you, sir. Thank you, sir.
Chandini, can you please stay back? Then we can move on to the next session, next speaker, none other than Dr. Sunil Prashop. Dr. Sunil Prashop, he is the probably the most promising upcoming academician. And currently he is the additional professor of internal medicine, Government Medical College, Kollam, and he had been a alumnus of my alma mater, that is Trivandrum Medical College, from where he did his MBBS as well as MD. And incidentally, he was my classmate for the postgraduate diploma in diabetology in Annamale University. And he was associate professor in Trivandrum Medical College. He is a fellow of Royal College of Physicians and fellow of American College of Physicians. And he had also his postgraduate program in diabetology from Johns Hopkins University and certificate course from the MDR of Chennai. And over to Dr. Sunil Prashop, who will be sharing his experiences in COVID management. Over to Dr. Sunil Prashop.
Okay, am I audible?
Yes, very much.
Okay, thank you.
Yes,
thank you, Mohan Nair sir, Arun, and thanks, special thanks to my very dear friend Sabir for this fantastic opportunity. So my topic is basically based on recent updates on COVID management. We all know diabetes, the corona is growing in epidemic proportions. And if you look at the present statistics, you can know worldwide statistics says that around 6 lakh, more than 6 lakh people are affected in India. And if you look at the death rate in India, around 4 lakh 30,000 people have already died. So it is definitely growing in epidemic proportions. And the WHO has declared it as a world pandemic in March 11, 2020. This is basically an iceberg disease, just like diabetes we see. Around 80% of the patients are often not diagnosed, and around 5% becomes critically ill. And the case fatality rate of this COVID infection is to the tune of 4 to 5%. The most important risk group as far as COVID is concerned is basically three. The people who are aged above 65 years, people who live in nursing home or long-term care facility, and people with comorbidities like the obesity, severe obesity, uncontrolled diabetes, hypertension, COPD, immunocompromised patients, pregnancy. All these are high-risk group. But the most important aspect that we all should understand is all patients who develop viremia may not go in for a very, very difficult stage. For that, the immune system of the host is very, very important. We do have two types of immune systems, the innate immunity and the adaptive immunity. The innate immunity mediated by the interleukins, interferons, the natural killer cells plays a very, very important role initially. By the time the COVID attack happens, the innate immunity fails to respond in the initial stage. And that is the reason why the adaptive immunity also fails. The adaptive immunity is basically mediated by the T cell mediated immunity and the plasma cell mediated antibody mediated immunity. The adaptive immunity also fails, and the dysregulated adaptive immunity plays a very, very important role in the development of cytokine storm syndrome. The cytokine storm syndrome can either be localized or diffuse. And the localized cytokine storm syndrome usually happens to lungs, most commonly heart, endothelium. If it happens in a diffuse manner, it leads to multi-organ dysfunction. As Chandri Madam already told, the AC2 receptors play a very, very important role because the SARS coronavirus attaches to the AC2 receptor present on the surface of the cells. These AC2 receptors are present in a wide variety of areas, predominantly in the upper respiratory tract, also in the lungs, intestinal tract, even in pancreas. These AC2 receptors are there, and it plays a very important role in determining the severity of the disease. This Chandri Madam has already alluded, the ACE2 pathway and the ACE pathway. The ACE pathway is actually very, very bad because it causes vasoconstriction, hypertension, cardiac hypertrophy. And homologous other pathway is the ACE2 pathway. This ACE2 pathway. This ACE2 pathway is actually good because it causes vasodilation and it is actually protective. But when we give AC inhibitors or the RAS blockers, what happens is there is an upregulation of the ACE2 pathway. So we think that ACE2 pathway may be good, but unfortunately the virus entry happens through this ACE2 pathway and there will be a downregulation of the ACE2 pathway. So although there is an upregulation of the ACE2 pathway, on the other side, there will be a downregulation by the entry of the SARS coronavirus. So that is why the reason why all guidelines have said that you can continue with the RAS blockers. So who all are the high-risk patient groups? Definitely the patients with comorbidities, which I have already told. Then the clinical assessment, the patient initially with hypoxia, tachycardia, respiratory distress, hypotension, and the initial lab parameters also very, very important because other than the usual routine blood checkup, we specifically looking for the inflammatory markers like the C-reactive protein, ferritin, D-dimer, troponin T, because as I have told you, when the inflammatory markers are very much elevated, we should suspect a cytokine storm. This is what the national guidelines say. We should categorize all the patients who are coming to us to mild, moderate, and severe. Mild is basically uncomplicated upper respiratory tract, moderate is pneumonia, and severe is severe pneumonia. Mild people usually don't have hypoxia, and the moderate will have a respiratory rate of more than 24, SpO2 in the range of 90 to 94. Severe people usually have an SpO2 less than 90 and respiratory rate of more than 90. Patients with ARDS, sepsis, septic shock, multi-organ usually come under critical group. So this is the natural history and the natural progression of the disease that we see. By 8th day, most of the patients who progress to a severe stage get admitted. And one of the most important thing is by 10 to 12th day, the patients who go in for a cytokine storm can develop ARDS. This is a classic X-ray picture that we usually see, the ground glass opacities, the peripheral ground glass opacities in the X-rays and CTs we see. Initially, we thought that SARS coronavirus basically concentrated on the lung itself, and most of the patients had ARDS and pneumonia. But now it's a disease which affects many of the systems. It can affect the heart, kidney, and cause sepsis. So many other problems are there. when time has gone by, we do have more tests now. We do have the nuclear amplification tests like RT-PCR, TrueNet, CBNet, and the RT-PCR is a gold standard test for diagnosis. The rapid antigen test has come in handy because we use this test to test people in hotspots and containment areas. The results comes in very fast. Then there is rapid antibody test used for surveillance. The natural history of the COVID, if you look, there is an initial stage of viremia, second stage of pulmonary phase, and the third stage or the late stage is a hyperinflammation stage. This is what is more important. In the initial phase, the antivirals are effective, and in the late stages, anti-inflammatory drugs are very effective. So if you look at the treatment and the evidence, there are only indirect evidence and observational studies and RCTs, not so convincing. We have to wait some more time. So if you look at the drug armamentarium, there is antivirals, which the most noticeable ones are HCQs, remdesivir, and favipiravir. And if you look at the anti-inflammatory and immunomodulators, there is glucocorticoids, dexamethasone, convalescent plasma, and tocilizumab. This is how the antivirals act. The hydroxychloroquine, which is a fusion inhibitor, it inhibits the multiplication of the virus. The lopinavir, ritonavir, which is not used, this is a viral protease inhibitor, and the remdesivir and favipiravir is a viral RNA-dependent RNA polymerase inhibitor. So these are the usual viral drug antivirals which we use. The HCQs usually used in mild to moderate disease, given as oral tablets. But the most important thing is the QT prolongation. We should be very, very cautious about this. Then the drug which we use these days is a remdesivir, usually used in moderate disease patients who are not responding to adequate oxygen, usually given as intravenous injections. The most important thing is the QT prolongation. Again, QT prolongation should be the most important thing and looking for. Another contraindications are renal failure, hepatic failure, pregnancy, lactation, and other QT prolonging drugs. The favipiravir, although it is approved, not used these days because the pill burden is more, it is usually indicated in patients with moderate disease, and it is given orally, and in one important portion is hyperuricemia, but this is not used these days. If you look at the evidence, there are so many evidence coming in for HCQs. The initial enthusiasm which was there initially is now not there for HCQs. And we do have a very large trial. It is funded by the Solidarity trial. The WHO funded Solidarity trial will give an answer to our question regarding whether it is a remdesivir, HCQs, lopinavir, or interferon. All these things are studied in a big way in the Solidarity trial. One very important trial which came recently is the recovery trial, which showed that steroids, especially the dexamethasone, is a very, very useful drug because it reduced the mortality in severe patients to the tune of 30%. The steroids, glucocorticoids, dexamethasone can be given intravenously and is usually indicated in moderate to severe disease. Another very important drug is the tocilizumab, which is a human monoclonal antibody against interleukin-6. It is usually indicated in moderate to severe disease with very, very high inflammatory markers. Another important treatment armamentarium, which has come handy these days, is a convalescent plasma, which is usually indicated in moderate disease patients who are not responding to adequate oxygen, but the ABM incompatibility and also the post infusion, we will have to wait to look whether there are allergic tendencies. Cytokine storm is very, very, very important. What we all should understand, the simple viremia is not going to kill the patient. It is a cytokine storm induced complication is the one which is going to kill the patient. And the most important treatment of CRS is tocilizumab and steroid. These are some of the drugs, antiviral drugs under study. You can see so many antiviral drugs are, and the noticeable ones are the camostat, nafamostat, which are fusion inhibitors, and there are so many other drugs under study. And if you look at the immune active agents which are under study, this is leronlimab, JAK inhibitors, ruxolitinib. Along with this, there is the intravenous immunoglobulin, the itolizumab, then anakinra. So many other immunological agents are being studied in COVID. And this is the national guidelines. I think most of you might be knowing this is a very busy site, and this is a simple format of this national guideline. Mild cases, you can treat the patient in corona care unit or home. You can give HCQs in high-risk patients. In moderate patients, you can treat it in a dedicated corona hospitals. Then oxygen will have to be given. HCQs you will have to give. You can treat with steroids, either methylprednisolone or Dexona, anticoagulation is also necessary. In severe cases, definitely those severe patients will have to be treated in a tertiary care hospital known as the COVID hospital. Increased oxygen requirements in these patients. Ventilation is a very, very important part. You will have to treat with steroids and anticoagulations. And the national guidelines have put this remdesivir, tocilizumab, and convalescent plasma in investigational therapies. Another very, very important aspect is the oxygen therapy. The oxygen therapy, whenever the SpO2 comes below 90, we'll have to initiate oxygen. You can give different modes of oxygen, the nasal prongs, the venturi mask, the non-breathing face mask. And one of the most important the method of oxygen delivery, which has come really handy in this COVID era, is the high flow nasal oxygen, where you can give oxygen to the tune of 60 liters per minute. If the patient is not if the patient does not become better with a high flow nasal oxygen, you may have to go in for a non-invasive ventilation, and it still, if not corrected, you may have to go in for a mechanical ventilation. This is what I told. High flow nasal oxygen has become the dictum in most of our tertiary care hospitals. Another very important aspect is the proning. This cartoon clearly elaborates how it is being done. And the ideal way, you can keep the patient 1 hour in prone position, left lateral position, right lateral position, upright position. By proning, we can improve the ventilation perfusion mismatch in the people, and also we can make the dorsosaphes of the lung more active. So proning has definitely improved these days the life of many patients. Another thing we should be very, very careful is the aerosol generating procedures, the intubation, the non-invasive ventilation, bronchoscopy, the drilling surgeries done by the orthopedicians. All these are very, very dangerous because they are aerosol generating. The comorbidities, Chandani Madam has beautifully covered. The diabetes, insulin is the treatment of choice. Hypertension, you can continue with the RAS blockers. And the COVID and the heart, the most important manifestations are myocarditis, acute coronary syndrome, arrhythmias, endothelial dysfunction, and hypercoagulability. This endothelial dysfunction was a reason why we read that there was an incidence of Kawasaki syndrome in some of the Western countries and was noticed even in Mumbai. Hypercoagulability is one another important because COVID is a condition which is thought to be like a DIC-like situation, a procoagulant. So multiple thrombosis is always a possibility. In respiratory system, always continue with steroid inhalers. The coagulability, the increased coagulability and COVID is now known as the CAHA, corona-associated, the COVID-associated hemostatic abnormality. And this COVID-associated hemostatic abnormality, the thrombosis can happen, particularly the lung, the small vessels of the lung and the large vessels of the lung. The small vessels of the lung, it can cause inflammation, thrombosis, inflammation, and ARDS. If it happens in a large vessels, it can predispose to pulmonary embolism. And the treatment of choice is heparin. So how can we conquer COVID-19? We all know the social preventive methods that we adopt, the development of treatment, the repurposed drugs, the passive immune therapy, the convalescent sera, the human monoclonal antibodies. But the definite answer or a genuine answer to this will be the vaccine. We will have to wait some time for the vaccines, but we do have highly optimism as far as vaccine is concerned because several studies are going on. The RNA virus, the live attenuated, inactive actin, subunit vaccine, viral vector vaccines. These are some of the frontline vaccine, Moderna vaccine from US, the Oxford vaccine from UK, which is a viral vector vaccine, then Pfizer vaccine, the Sinovac vaccine, which is an inactivated vaccine. The India is not far behind because we do have vaccine known as Covaxin. It is being developed by the Bharat Biotechnology in association with ICMR and NIV. So in the last 5 months, we have learned a lot. We know about the happy hypoxia, and the hypoxia it causes. Oxygen is a definite treatment for this thing. Prone positioning is also very, very important. The tests have improved, the number of tests has increased, the nucleic acid amplification test, the antigen test coming in, the results coming in very quickly, the pulmonary vascular thrombosis, the CAHA, the cytokine storm, which is a real cause of death of many patients, and then the drugs like remdesivir, steroids, convalescent plasma, tocilizumab. All these have helped in decreasing the mortality in our patients. But we do have several concerns like the ICU facilities, the PPE, the ventilators, and the community transmission is really staring us. Well, this is the thing that we have seen. Initially, everybody was in a panic mode, but when the number of cases increased, everybody changed to a picnic mode, and that is the result that we are now facing. But in spite of all these things, we still have to adhere to the social distancing, sanitizing, hand mark, and the preventive measures because it still works now. Thank you for your patient listening. We will take up a few questions later.
Thank you, Dr. Show, for that extremely lucid, clear, very enlightening, and very practical presentation from all points of view. So let us go to the next speaker straight away. We have got an international speaker
I
right
don't
now.
know.
Hello. Shall we go to?
Yeah.
Yeah, we have got an international speaker as the next faculty. She's none other than Dr. Irina Vlasenko, who is the Vice President of International Diabetes Federation. She is the Associate Professor of the National Medical Academy of Postgraduate Education in Ukraine. She is a member of the European Medicine Agency, EMA, and she is a co-author of the celebrated book, Self-Management of Training of Patients with Diabetes. And she was also the director of the first International Diabetes Football Championship, which was titled Dio Europe, which was conducted in 2012. So Dr. Irina, we are extremely privileged to have you here in our forum as the speaker today. And she would be enlightening us on the very relevant topic, COVID-19 and diabetes, the challenges and perspectives. We would love to hear your talk about the global perspectives and your experience with regards to the management of diabetes in the background of COVID. Over to you, Dr. Irina.
Did you hear me?
Yeah.
Yeah. Thank you. I would like to say big thanks to Dr. Saber Russia for this opportunity. This is second conference. Last day I was involved in another Indian conference, and now I'm feeling that I'm in India, very close with you. I'm very happy because I interested Indian culture from my childhood. Thank you so much. Now we will talk about COVID and diabetes. It challenges not only for doctor and patient, and also for our a big organization like International Diabetes Federation. And as Vice President of this organization, I would like to show our resource, our possibility, and what we will do, and our challenge and perspective. I like join global effort to reduce risk for people with diabetes during COVID-19 pandemic. And if you go to our resource, you can find many documents, you can find links which with collaboration with other organizations, which is very professional and not government organization. You can find the recommendation.
Ma'am, Doctor, I don't. Ma'am, can you kindly share your slides? Ma'am, slides are not visible. Can you kindly share your slides?
Sorry, just a moment. I think that I should share.
Madam, could you please share your
Yeah,
slides?
like the way you did your demo. Please share, ma'am.
Yeah, I share. Sorry.
Just share it, ma'am. Just.
Yeah.
No, it's not.
No.
One second.
It's not, ma'am. You just share the, press the share button.
I know that.
Hello, doctor. Can you can you press the share button?
Yeah, I press. Press. I know exactly. Yesterday, the same opportunity.
Okay, we will share.
Ma'am, shall we share?
Yeah, that would be better.
Fine, fine. Ma'am, we will share. We'll share. Meanwhile, you can
Okay,
just continue the talk. We'll share in a moment, ma'am.
Okay, ma'am, you can
thank you.
continue with your lecture.
നിക്ക തുടങ്ങണ്ട.
Ma'am, you can continue with the lecture. We are sharing, ma'am.
Okay.
You can resume your lecture, ma'am.
Yeah. But I didn't see. I didn't see slide. It's okay. I can continue.
Yeah, you can continue, but the slides are not shared. You can continue.
No problem, ma'am. We are sharing. Yeah. We have started sharing.
Okay.
One second, ma'am. 1 second. It's uploading.
Yeah, I see. Yeah, thank you.
Yeah, that's almost visible. Yeah, the first slide is visible, right?
1 second, ma'am. Can you see?
Yeah. Second slice.
Yes.
Change to slideshow. Please change to slideshow mode.
I think the slideshow format is not working here. We will do that one, sir. Previous one.
Yeah. This is okay.
Fine.
Go ahead.
Fine. Okay, madam.
Okay.
The slides are here.
Yeah, thank you so much. And this is about our thing to do for people with diabetes. You can find a lot of recommendation. It was developed with another professional organization, and I would like to see COVID outbreak guidelines for people with diabetes, which was created by IDF Europe region. And if you look this time, this is ending on April, and we have already done this. But we know that, next slide, please. We know that scientific publication related to the risk of cause severity with COVID-19 in people with diabetes will help to lobby
Next slide. Please.
for evidence-based policies. And the IDF president-elect, Professor Akhtar Hassan, has edited a special issue of diabetes research and clinical practice. It's IDF official scientific journal, the special issue addressing the important topic of diabetes and COVID. And you can find in this scientific and evidence article in this journal and about different aspects in coronavirus and diabetes. And this is very good use because the journal reputation is grown because in content being quoted widely in scientific journals. Next slide, please. Thank you for my colleagues who explained big risk and for people with diabetes. And we now it's half year we live with coronavirus, and a lot of scientists make some research, and I want to underline diabetes associated with COVID-19 mortality risk in large UK study, and that it shows that this risk diabetes for coronavirus. And next slide, please. Yes, this more research showed that this can increase COVID-19 severity. many people has another disease like cardiovascular disease 30%, and disease close follow diabetes 32%, and chronic lung disease 19%. But we have also good news that people who has normal glycemia control has less mortality. In this case, we must make right the message to people with diabetes. Next slide, please. And you must, of course, you treat people, and you must give recommendation, general recommendation. But my point, you must underline diabetes management, and this is recommendation must include many aspects, and also in physical and mental health, exercise. And now we in IDF Europe organized new questionnaire about influence diabetes COVID-19 of diabetes management, and we soon will get results. And also you must give recommendation if person sick get treated quickly. And of course my colleagues before explain how it's very important check ketoacidosis, because it's also possibility more risk. And next slide, please. Your suggestion must include practical suggestion. And of course, you understand very deeply situation with people, but sometimes people don't understand, not take a lot of attention for this. And your suggestion must be practical and even include very simple, like make sure that you have good supply of diabetes medication you need. Think what you would need if you will be in quarantine in few weeks, and even simple suggestion, but it's very important that make sure that you have access to enough food. And this is information result of studies sent to me yesterday, Indian colleagues, Ravindran, that reverse quarantine and COVID-19 to reduce the mortality and morbidity associated with coronavirus. These people also must know that you must explain to them, and they will be decide. This is very good for infectious disease. Next slide, please. And the next challenges, also mental health response. Stress and anxiety for both people with diabetes and healthcare professionals. People with diabetes are worried about being infected with coronavirus and what this means for their own health and well-being, and also for that of their families and loved ones. And the healthcare professionals are concerned about becoming infected and affecting their immediate family, and not being able to perform their regular roles in patients' care. I find very good resource like Australian Diabetic Federation make resource for help, for support this both category of patient and healthcare professional. Next slide, please. But this big significant impact COVID-19 impact to health services for non-communicable disease. Access to insulin and diabetes supplies in some countries restriction imposed to tackle the spread of the COVID-19 pandemic and distribute the supply chain for insulin and other essential diabetes medicine. And IVF is activity monitoring issue arising helping to determine what assistance can be offered. Next slide, please. And this is very important. WHO found a study which involved in 155 countries that related with diabetes complication, for like 50% make weak nation and interpreted service for treatment of hypertension, cancer treatment, and cardiovascular emergency. This is, I think, is the most important topic, and we must underline on this because this is also increased mortality because many appointment was cancelled, and we cannot support people as usually we did this. And this is having a great impact and should be changed. Next slide, please. And this is also big challenge. And if you remember that 2006, we got United Nations resolution about diabetes. It was first time in case not communicable disease, and before it was infection. And we make alliance, and we are part of alliance not communicable disease. And this is in this area we make a lot of progress. But in this time, this pandemic may reverse this trend, and we must work together and need focus on broadcasting of the message that diabetes increased in the prevalence. But if we manage this, we can have good result and outcome result of treatment. Next slide, please. I cannot say, I must say about also virus. Thank you for my colleagues who explained before, but I want only like general say that after the January 10th, after the when scientists in China announced of complete genetic make-up on the novel coronavirus, after this rise to produce vaccine, to develop vaccine forward began. We know many producer promise that we will have vaccine. It's from message from USA after the 12-18 months. But another expert says that it's very optimistic prognosis, and normally the vaccine development take 8 or 15 years, and I know only one case. It's only 5 years was development one vaccine, but this is another case. Maybe we got earlier than usually, because a lot of resource, a lot of money involved in this. Next slide, please. This is analysis of landscape of COVID-19 candidate vaccine, which published by WHO. This many candidate vaccines, it principal evaluation, and also some of them 26 candidates in clinical evaluation. And as you know, some of them maybe in soon go, but we don't know about results. Next slide, please. Following approval, the vaccine can be manufactured, and the WHO make judge many countries, like 150 countries, who like facility about global access facility to vaccine. Next slide. And now global challenge vaccine. If you see here, vaccine as soon as possible, but we have anyway challenges. For example, the repeat clinical trials program, safety, we don't know about results. Manufacture, it's not only a cost and economical available, and also even packing material. It's not enough glass, and now it's a lot of prediction and a lot of message that we must more product something. This distribution, cost, economics available. Who will decide who get this vaccine? This also a big challenge. And you know, the anti-vax movement, vaccination and law. I am a member, you present me, I am a member of European Medical Agency Patient Consulting Group, and we speak about vaccine, how improve situation with vaccination from last year, but it's of course not about coronavirus. But this is a situation very dangerous for the world, and because very strong anti-vax movement. But anyway, we must also thinking about vaccination and law, with no obligation. And challenges, how effective a vaccine will be against a mutating coronavirus. We don't know this. And of course, related with our diabetes, influence vaccination on people with diabetes. We don't know how it will be conditioned, how glycemic influence on glycemic control and complication. Next slide, please. I hope I make a big picture that we have a lot of challenges, and we must work together, and we must to learn how to live with coronavirus, and how help during this situation people with diabetes. And we can of course use and improving telemedicine and consultation, video consultation. This help to save patients. I'm hope that we can do this. Thank you so much for your attention. Next slide, please. I want to share my picture from Ukraine. I hope after the stop coronavirus, welcome to Ukraine. I'll be very happy introduce with my country. Thank you so much for attention.
Thank you very much, Madam, for that extremely since we are already running short of time, we are forced to wind up this session because the next session is already overdue. I'm handing over the mic to my senior post chairperson, Dr. Mohan Nair, sir, for the concluding remarks.
Thank you, Dr. It was a wonderful session, even though we had some silly technical problems. Since that we don't have much time for questions. If somebody feels that there is a very pressing question, they can ask, or otherwise they can contact speakers directly for their doubts. Any pressing questions? Otherwise, we wind up this session and proceed next. Thank you, Dr. Sabir, and thank you all the organizers. Thank you, and all the speakers. Thank you again.
Thank you.
I think, thank you everyone. That was a wonderful lecture on COVID-19 and associated condition. Now we are moving on to the next session. Next session is a very interesting topic related to gliptins and all. To chair the session, we have a physician from Pathanamthitta, Dr. Prashant Shankar. Over to you, Dr. Prashant.
Thank you once again, Dr. Sabir, for giving another opportunity for me. It's my privilege to chair this session by two eminent speakers, two of my favorite speakers, Dr. A.G. Krishnan and Dr. Rajiv Kovil. So since we are running late of time, I will just go ahead with the introduction of Dr. Rajiv Kovil. And he is one of the dynamic diabetologists of the country. And I would term him as the celebrity among the diabetologists of the country. And he runs Dr. Kovil's Diabetes Center at having two branches in Mumbai. He is a diabetologist at Nanavati Hospital, Rahita Hospital, and also BSCS Hospital. He is a faculty for numerous international and national seminars, conferences, and workshops. He's a founder member of the United Diabetes Forum, which has been running the CID conference successfully for the last 5 years. He has the first diabetic foot clinic in Mumbai. Many original articles in international journals. He's an investigator for many international trials, and he's also the faculty of teaching for diploma in diabetology for students. So over to you, Dr. Rajiv, for your enlightening lecture.
Thank you, Prashant. Thank you, Prashant. Thank you, Sabir. Thank you, MSD, for having me here. I'm trying to. Is my presentation being seen? Okay. So, what COVID, apart from all of us have become COVIDologists, but apart from that, also all of us have become very trained in using different types of technology over the last 3 months. So necessity is the mother of invention. From technology point, COVID was the mother of invention. So for me, it's a very thank you, Sabir, again. It's a very clinical topic where we look at elderlies and young. Do we treat them differently? And this pandemic, which threatened all of us, our existence, taught us that elderlies and comorbid conditions are the highest risk factors for COVID-19 complications. So I am a clinician. I see patients, I treat patients to the best of my ability, and that's what I'm here for. And when we clinically divide patients based on their age, 35 to 50, we would consider them as being young. The average age for diagnosis in India is close to 41. More than 65, we would contribute, or we would put them in the bracket uh, for elderlies. And do we need to approach these two people differently? Do we need do we need to approach everyone differently? Is that what I think some my can you all hear me?
We can hear you.
Yeah, but somehow I'm not able to move my slides. I don't know, it was moving. One that this
Can you just stop sharing and try again sharing?
okay, I'll do that. Technical glitches have now become a part of presentation, unfortunately. So I was able to share I was able to move. I'm not able to move now. Once that annotations came in, somebody, I think there was a live sharing to YouTube on. And okay, okay. So the elderlies are a very under studied subjects in the population, and we kind of extrapolate a lot of things which happens in the younger people to the elderly, and they are an understudied population. But what are the unique issues? Cancer mortality, vascular death, functional disability, falls and fractures, very common. Geriatric syndromes. Again, a lot of drugs which work in the younger may not work in may work differently. There are multiple pathophysiology. Now we have a pathophysiological approach. Lifestyle issues, higher chances of adverse events, and again higher diabetes related complications. Another tolerability considerations which we need to keep in our mind, that as the decade of years increases, polypharmacy comes in, drug metabolism may be different in the elderly, forgetfulness, Alzheimer's, dementia, multimorbidity, autonomic dysfunction, higher risk of hypoglycemia, unawareness, and so many others, infection, so many things keeps coming in. Polypharmacy is very frequent in the elderly, as you can see, that 12% of the population in the elderly take 10 and 10 plus medication. And polypharmacy itself can affect a lot of adverse drug reactions. 6% of adverse drug reactions have serious consequences. And again, when you have polypharmacy, you can have drug-to-drug interactions. Now, being in the diabetes field, the only two drug-to-drug interactions which comes into our mind is probably a sildenafil with an isosorbide or a QTC prolongation. But a lot of serotonin syndrome complications come along. And nowadays, when we use an EMR, which tells us about the various drug-to-drug interaction, it helps us. But where we are not using an EMR, it can be very, very difficult. What causes polypharmacy? Again, a lot of patients go to multiple doctors. They go to different orthopedic specialty. I have patients who go to a knee specialist, go to a spine specialist, go to a shoulder specialist, and go to an ankle specialist. And all of them shoot in vitamin D and NSAIDs to them. So there are a lot of patients itself love doctor shopping. Another consensus: clinicians and patients have different targets and have different ways of reaching them. Age-related issues. A lot of elderly may be dealing with Alzheimer's and forgetfulness. Follow-up. We don't have a structured care. Patients do not follow up with us even in chronic care unless they have an emergency. Use a lot of OTC drugs. As you can see right now itself, vitamin C and so many things are being consumed by patients. Even HCQs are being consumed by patients as a prophylactic measure. Trust issues. Doctor shopping is a culture in India, and I think we need to build a lot of trust. And that's how, when we treat a patient holistically, that trust comes into being. So consensus: we need joint decisions, we need special care. Follow-up: we need to make sure that we use drugs which are safe first, and again, build trust. That's extremely important. How do we reduce these harmful habits? Instruct patients to bring all OTC medicines, screen for unnecessary drug, prescribe drugs with better or less side effect, give them simple drug regimen. That's extremely important. Diabetes treatment is doing simple things best. And once we do simple things right, we can reach the target. Thoroughly explain, provide clear written instructions to accompany medications. Again, as William Hostler has always said, he's a physician who of modern medicine, who told us that first prerogative for a good clinician, for a good physician, is to not to do any harm. And common OADs have a lot of interactions, and we must use drugs which do not have much interactions or do not have much kind of an excretion or an adverse reaction. Fully metformin and sitagliptin are minimally metabolized or excreted to the hepatobiliary system. Sita, Vilda, EMPA, and DAPA have no clinically relevant drug-to-drug interactions. So when there are no drug-to-drug interactions, it actually builds the confidence of all of us who are using these molecules, and we know that the patient will not end up with a complication the next day related to the drug that we use. Again, with increasing age and advancing diabetes, what happens? There's a gradual reduction in EGFR. So some of the drugs need to be tweaked. Some of the drugs which actually work on tubular reabsorption of glucose, like the SGLT2s, may be reduced. There's again reduction of active beta cell mass. Again, reduction of active beta cell mass, which reduces, and the efficacy of SUs may be dependent on active beta cell mass. Now, sitagliptin is one of the first gliptins in the market. It was one of the first gliptins which came in, and the confidence that it has built over the last 15 years is purely because it has no drug-to-drug interaction and no hypoglycemia. So the incretin-based therapy, because it's insulinotropic, builds the confidence of all of us that the patient will not develop a hypoglycemia. That's the reason it makes us very confident to use it in the elderly age. Now, it has a study which is a randomized study done in an elderly age group. And if you look at the mean age is 72, with a mean HbA1c baseline of 7.8 of sitagliptin as monotherapy. And as you can see, at the end of 24 weeks, there's a reduction in HbA1c. So the most important part was there was no adverse drug reaction. Now, at any EGFR, the gliptins work, and sitagliptin has been tested in all EGFRs, as compared to an SGLT2, which looks at the glomerular filtration as a fulcrum on which the drugs work. So if your EGFR goes down, the SGLT2's efficacy as an anti-diabetic does go down. It has multiple other benefits which may not go down, but the anti-hyperglycemic efficacy does go down. and a lot of tolerability issues also. And we know that gliptins do not have any specific age-related tolerability issues. Hypoglycemia is a huge challenge, and we should be using insulinotropic drugs in especially in patients especially in the elderly who stay alone, and socially, if they develop a hypoglycemia, they may not be having people to recognize it or give them first aid at home itself. Symptoms are very non-specific. It could be misdiagnosed for a stroke or a vertigo. Patients already have dementia, and hypoglycemia continues to be the rate limiting step in retargeting a very tight HbA1c versus keeping it relaxed as such. Again, there's a lot of interplay of risk factors, multiple medications. There may be multiple oral over-the-counter medications. You may have blunted counter-regulatory response, hypoglycemia-associated autonomic failure. All this puts the elderly at a very high risk for hypoglycemia. This is a real-world evidence which showed gliptins as compared to sulfonylureas had a lower incidence of non-fatal stroke MI in both elderly with history of CVD or without a history of CVD. Again, when most of the patients in the elderly age group would have some comorbid conditions or would be long-standing diabetics and would require the addition of insulin. And it's always a problem when we initiate insulin or we optimize insulin, which should be the oral drug that we continue. And this is a composite IT study which was done by Glargine, and this looked at comparing the effects of continuing sitagliptin versus discontinuing sitagliptin in patients who are titrated or initiated on glargine in the background of metformin. So you have two groups. One is glargine plus metformin. The other one is glargine plus metformin plus sitagliptin. And again, the patients at the end of 30 weeks, the patients with glargine plus sitagliptin plus metformin, again, the HbA1c was better. But what was remarkable that in spite of the HbA1c being better and a reduction, a difference of almost 0.45 at the end of 13 weeks, the adverse drug reaction or hypoglycemia was also lesser. So it means that addition of sitagliptin does improve control, and because of its insulatropic, being an insulatropic agent, the chances of hypoglycemia becomes much lesser. So here you have a 1.8% reduction, getting the patient almost to goal without hypoglycemia when we add on sitagliptin plus metformin in the background of glargine. Again, we all know that elderlies are associated with higher rates of death, whether it's adverse cardiovascular events related to hospitalization due to heart failure or all-cause mortality, or other causes of death which could be related to malignancy or severe hypoglycemia and bone fractures. And this was assessed in the TICOS study, which showed that elderlies were at a much higher hazard ratio for all-cause mortality, hospitalization due to heart failure or death, or severe hypoglycemia as compared to the younger age group. But use of sitagliptin in the elderly was not associated with worsening of any of the MACE, thus showing that sitagliptin was fairly safe to be used in patients in the elderly who are at much higher risk for not only these cardiovascular complications, but also for many other complications like falls, fractures, and infections. Again, bone is very important. Our whole skeletal structure depends upon how good our bone mineral density is. And we know that there are macro and micro architecture abnormalities which occur as age advances. And a few of the drugs, especially the TZDs and the SGLT2s, do have some influence over the micro architecture abnormalities, and they reduce the resistance to mechanical stress, and one can have fractures. And the incretin-based therapies, both the injectables and the oral gliptins, have been found to be fairly safe as compared to its effect on the bone markers. Again, sarcopenia is another complication which is often neglected, and it's been seen that DPP-4 inhibitors, especially sitagliptin, is associated with better sarcopenic parameters, preservation of lean body mass, strength and physical performance indices as compared to other drugs. And this is something that will help us because it does improve the quality of life of patients. Secondly, also Alzheimer's disease, dementia is also related to some amount of insulin resistance in the hypothalamus. Is being called as type 3 diabetes, And here you have an assessment of 250 elderly diabetics, out of which 205 patients completed the questionnaire for mini mental state examination. You had patients with Alzheimer's disease and without Alzheimer's disease, and were compared with sitagliptin plus metformin versus only metformin. And patients without Alzheimer's disease receiving only sitagliptin or insulin showed significantly higher scores as compared to patients receiving metformin alone. Patients with Alzheimer's disease on sitagliptin showed significant improvement in scores as compared to patients receiving metformin. So again, one can say that there is no reduction in cognitive ability, and there's no cognitive impairment which is increased when we use a gliptin as compared to many other drugs, thus making it suitable for the elderly population. Secondly, because of the ease of dosage, lack of adverse drug reaction, we've always seen that the compliance with gliptins is better, which in turn improves HbA1c. So diabetes in the elderly, we need, it's an advanced stage of the disease. Proper drug selection is extremely important. Maybe difficult for all of us to adhere to lifestyle measures. Polypharmacy, so we need to have simplified regimens. They all may have comorbidity, so we need to use a drug where we don't have to look at multiple other systemic disorders as such. So using a gliptin is very simple to the old Hero Honda ad, which I remember in my childhood, which used to say, fill it, shut it, and forget it. So when you use a gliptin, especially in the elderly, you can be safe that the patient is not going to develop an adverse reaction to the drug and will not have a hypoglycemia or any kind of drug-to-drug interaction. And we need to assess understanding and ability to self-medicate, and again, assisted care and family support. The target for glycemic control will be variable, will be personalized based on multiple factors as such. Now let's look at what do we do for the young patients. When we say young is 35 to 50, again, you need to realize they have a long life ahead of them. There are a lot of responsibilities. Most of my young patients who come to my clinic have come as if they've come to an ATM. They want to come in, they want to meet me, they want to do the test and go off in the next 30 minutes. So they are in a life which is in a race against time, and it's very difficult to follow a healthy lifestyle. Though they are living at the moment, they don't look at the future. But lifestyle measures are something that we need to ensure we put on the patients much younger they are and the diagnosis is younger, because we know the legacy effect of glycemic control. And that's very important, that the diabetes prevalence and the cardiovascular prevalence also is been coming down by a few decades as of now. So most importantly, we need to make sure that the drugs we use in the younger patients give them good control, lesser side effects, no adverse events, no drug-to-drug interactions, no, and again, they are durable in the longer run. We should focus on lifestyle, sustainability of therapy, address maximum key pathophysiological approach, because now we know it's not longer glucocentric, it's a pathophysiological approach. We need to focus on prevention of short and long-term complications. Also very important is to make sure that it doesn't interfere with the quality of life. That's extremely important. You have patients, you have younger patients where it affects their quality of life and quality of enjoyment in life. You will have a problem and the patient may actually go ahead and do doctor shopping. So management strategy should not affect their work life, lifestyle as minimally as possible. So this is how the progression of diabetes occurs from a normalcy to pre-diabetes, and when finally your pancreas cannot hypersecrete or hypercompensate by producing more insulin, you develop type 2 diabetes, and initially you try to get stable and then there's severe decompensation, and we usually waste a lot of first years of our natural history, and we would be very happy if our patients came to us earlier. Again, when we use a DPP-4 plus metformin, we are actually taking care of multiple pathophysiological defects in patients with type 2 diabetes, and that kind of an approach, a pathophysiological approach, actually helps in the longer run rather than in the shorter run where we look only at the glucocentric approach. So when we look at sitagliptin, it's been with us for the last 15 years. The HbA1c of reduction of sitagliptin, or the glycemic efficacy of sitagliptin, is comparable among all the gliptins. Do I consider Sita and Vilda to be much more in their glycemic efficacy as compared to Saxa, Lina, Gemi is out of the picture. It's also equally efficacious in its glycemic potential as compared to the other OADs, and again to the other drugs which are available as such. And we all know that that the SUs, though they are more potent in their glycemic efficacy, the durability is a question mark. And as years of diabetes go on, the durability of SUs keeps going down. Now, these are monotherapy as well as dual therapy with sitagliptin plus metformin. On the upper side of the slide, you have a monotherapy study with sitagliptin, where you are looking at 76 drug-naive type 2 diabetic having excellent control and a durability of control over 4 years. Below is a head-on study versus an SU plus med. And as you can see that the SU initially in the first 1.5 years does better in its glycemic efficacy, but over a period of 7 years, you can see that the gliptin plus met, in this case, sitagliptin plus met combination has a much better glycemic efficacy and a much better durability as compared to an SU plus met. And this is what we would encourage in our younger patients, that we treat them well, we give them a pathophysiological approach, and we make sure that they're controlled over a longer period of time.
Dr. Rajiv, I think we are slightly crossing the time.
Fine. I'm just finishing. One is that the drug doesn't require any kind of monitoring. The HbA1c at the end of 1 year is associated with long-term complications. I'll skip these. So sorry. So even in the younger age groups, when you compare TCOS to the other DPP-4 studies, sitagliptin has been found to be has an HR of less than 1. Again, no contraindications with gliptins. If you look at any other complications, again, no black box warning as such. So in summary, whether it's the young or the elderly, drugs like sitagliptin, which has actually stood the test of time with the advent of the SGLT2 inhibitors, also will make the confidence of all of us to write more and more, whether it's the younger or elder, because again, associated with no complications, no adverse reactions, no drug-to-drug interactions, thus builds the confidence of all of us. Thank you so much.
Thank you, Dr. Rajiv, for that wonderful lecture as usual. Since we are running short of time, we will straight away move to the next topic. That is to be delivered by Dr. A.G. Unnikrishnan. Unnikrishnan sir needs no introduction. He has already been lecturing in this meeting. I'll straight away hand over the podium to sir.
I hope I'm audible. Slides are visible.
Yes, sir. You can just make it into a slideshow mode. That's all.
It's coming as I am unmuted. I'm muted.
No, your voice is audible, sir. Only thing is that the screen seems to have frozen.
Hello.
Yeah. You're audible, sir. Yeah, it's okay now. It's perfect now.
Okay. So I hope I'm audible now.
Yeah, yes, sir. You can continue.
So thank you, ladies, for being here. And I'm going to talk about 3 stories of glucagon. One is that insulin is a hormone for feeding and storing, and glucagon is a hormone of fasting and burning. So like Tom and Jerry, let's look at a case. A 45-year-old gentleman, his BMI is 29 kilograms per meter square. He is on an SGLT2 and metformin, and his fasting is 134. His post meal is 201. HbA1c is 7.4. So could this persistent hyperglycemia with SGLT2 be controlled by DPP4? Does glucagon have a role in this phenomenon? So revise the role of SGLT2s here. Now, alpha and beta cells in the pancreas have different roles. So to revise the role of the alpha and beta cells comprise about 15% of the pancreatic endocrine mass, beta cells 70%. Alpha cells produce glucagon, raise glucose. Beta cells produce insulin, lower glucose. Glucagon is released when blood glucose is low. Insulin is released when blood glucose is high. So as you can see, the role of glucagon is to increase the blood glucose level, and the role of insulin is to decrease the blood glucose level. And glucagon actually acts by increasing the hepatic glucose output, and insulin suppresses both glucose uptake. Insulin induces glucose uptake and suppresses hepatic glucose output. Now, notably, glucagon has no action on the muscle. So the predominant action of glucagon is on the liver, and the predominant action of insulin is on the liver, muscle, and adipose tissue. So, insulin causes lipogenesis and glycogenesis, and glucagon causes lipolysis and ketogenesis. So this is to show insulin produces ketogenesis, and SGLT2 inhibitors have been shown to increase endogenous glucose production by increasing glucagon. Here is data showing SGLT2 can increase glucagon, and there is also data that adding a sitagliptin can reduce glucagon. So the question is, as sitagliptin can suppress glucagon, and this is again data showing sitagliptin can suppress the glucagon significantly. So here is data that SGLT2 increase in glucagon can be suppressed by a DPP4 inhibitor. So yes, in this gentleman whose glucose is not controlled on metformin and canagliflozin, DPP4 like sitagliptin can be added. Let's look at another question. We know that insulin deficiency is essential to produce type 1 diabetes. But if somebody says destruction of the beta cells will produce type 1 diabetes, somebody can say that destruction of the beta cell is not enough to produce type 1 diabetes. And yes, that's true. Insulin deficiency is essential, but not sufficient to produce type 1 diabetes. An intact glucagon pathway is important. So let's look at an 80-year-old lady, newly diagnosed type 1 diabetes. Fasting is 300, postprandial 567, HbA1c is 14%, ketones are 4+, CAD antibody is positive. Can insulin deficiency alone explain such hyperglycemic states? So here is a study in animals where streptozotocin was given to destroy the beta cells. You can see that when there was a glucagon receptor present, insulin absence produced hyperglycemia. But when there was no glucagon receptor present, as you can see, the absence of insulin was not enough to produce hyperglycemia. Therefore, insulin deficiency alone does not produce hyperglycemia. You need an intact glucagon receptor pathway. So here is insulin deficiency plus glucagon efficiency producing diabetes. And here is insulin deficiency and glucagon receptor absence producing no diabetes. So therefore, in type 1 diabetes, where the glucagon receptor is working, you will get hyperglycemia and ketosis. And where the glucagon receptor is not working, you get normal glucose and normal OG. So does this mean that glucagon may have a role, glucagon antagonism may have a role in type 1 diabetes? So this is an animal study, and animal studies are different from human studies. Here you can see the unique nature of the pancreatic islet in humans, and here you can see the unique nature of pancreatic islets in animals. Now, if you see in the mouse, you see in the red color the beta cells, and the alpha cells in green color are surrounding that. But see the human islets in the humans, you'll see that the alpha cells and beta cells are more or less interspersed with each other. In other words, the beta cells, if they produce insulin within the islets, they can suppress glucagon. So that's another important message I want you to remember. The beta cells, when they produce insulin within the islet, they suppress glucagon. But when insulin is injected systemically, then suppression of glucagon may not take place. So therefore, ladies and gentlemen, insulin deficiency is essential to produce type 1 diabetes, but destroying the beta cell is not enough to produce diabetes. Insulin deficiency is essential, not sufficient to produce diabetes. You require an intact glucagon pathway. In the first part of my presentation, I talked about Tom and Jerry being insulin and glucagon, insulin being the hormone of feeding and storing, and glucagon being the hormone of fasting and burning. And therefore, a balance between insulin and glucagon is important. If you look at a low carbohydrate diet will reduce insulin but can increase the glucagon. So along with the low carbohydrate diet, you need to have enough proteins on board. So therefore, the insulin glucagon ratio can be optimized. If you have a low carbohydrate diet and lots of fat, again, that may not help in the glucagon ratio. So a low carbohydrate diet, enough protein, and then a touch of fat will help. In the second part of my presentation, I showed you that if there is insulin deficiency and if there is glucagon insensitivity, the glucose levels may not be very high. In my third part, I will look at type. You can see that in type 1 diabetes, the blood sugar level is like a roller coaster, up and down. Therefore, this is Steve Russell who used something called an islet. Islet is a special type of bionic pancreas which gives insulin through one tubing and glucagon through the other tubing. You can see that this is with a normal pump, you get good blood sugar levels. But when you give insulin and glucagon, the blood sugar is high, you increase insulin. And when the blood sugar is low, you give glucagon. And the balance of that can mimic, that's the bionic pump, which can actually give insulin and glucagon, can give better glucose control. One of my patients who is on a Dexcom sensor and who's got unpredictable glucose levels in diabetes, the type 1 diabetes, and this is type 2 diabetes, and this is a type 1 diabetes patient, despite basal bolus insulin, having very unpredictable glucose control. So the question here is, when insulin is produced in the splanchnic system, the insulin glucagon ratio is favorable and it gives a better metabolic control. But when insulin is there in the systemic circulation, that doesn't do much good on the splanchnic system. In a type 1 diabetes subject, when you inject insulin from outside, because the pancreas produces less insulin, this insulin cannot suppress glucagon. So there is an imbalance of glucagon and insulin in the portal circulation. And you have to inject a lot of insulin from outside, and this insulin cannot influence the intrapancreatic insulin. So I want to make this concept that in a type 1 diabetes, the pancreas is producing less insulin. That insulin cannot suppress glucagon in the pancreas, so pancreatic glucagon goes up. And by giving insulin systemically through the systemic circulation, it really cannot suppress glucagon. Therefore, you can use metrolleptin or glucagon blockers, and if you're able to block the glucagon like this, then the insulin-glucagon ratio becomes favorable, and you have to inject less insulin from outside. So these are the new concepts coming up. And just to discuss with you the various groups of drugs, you have DPP-4 inhibitors, GLP-1 agonists, metformin, sulfonylurea, thiazolidine, SGLT2. Only the drugs of the incretin system can suppress glucagon significantly, like DPP-4 inhibitors and GLP agonists. And only DPP-4s are oral, and therefore drugs like sitagliptin and other gliptins can increase insulin secretion, decrease glucagon production, and also suppress endogenous glucose production and control glucose better. So 3 points I made: insulin and glucagon are like two fighting children. When insulin does something, glucagon blocks it. When glucagon does something, insulin blocks it. You can call it Tom and Jerry. Second point I made is insulin deficiency with glucagon working is important for severe hyperglycemia. The third point I made is intrapancreatic insulin will suppress glucagon, but when insulin production is decreased, insulin cannot suppress glucagon, the glucagon levels go up, and you require novel therapies. And I told you how DPP-4 inhibitors can suppress glucagon. Thank you so much for listening to me. It's a pleasure talking to you. I understand we are running short of time, so maybe one question. If there's a question, I can handle it, if possible.
There are no questions. We can end this session because we are already running short of time. I would like to thank both Dr. Rajiv Kovil and Dr. Rajiv Unnikrishnan for their wonderful lectures. I think we will move on to the next session.
Thank you very much. Thank you, Dr. Prashant. Thank you, Dr.
Thank you, sir. Thank you, Dr. Krishna and Dr. Rajiv Kovil for the wonderful lecture. Thank you, Prashant, for chairing the session. Now we will move on to the next session. Next section is something very interesting. We have three major topics on the session. To chair the session, we have two eminent faculties from Trivandrum, Dr. Sunil Prashop, Senior Consultant Diabetologist, Medical College Trivandrum, and Dr. Ramesh Gomez, Consultant Endocrinologist from Medical College Trivandrum are there to chair the session. Over to Sunil. Dr. Sunil again.
Good evening. Next, we have a very interesting session. And the next session is on diabetes in a diagnostic dilemma. And the session is going to be dealt by Dr. Vinod Mittal. He's a very famous speaker. He's from Delhi. I know him personally. He's a senior consultant diabetologist and head working in Delhi Heart and Lung Institute. He has done several post-graduations, diploma programs, fellowships, and he is a very renowned speaker. He has got a vast clinical experience in the field of diabetes for more than 30 years and has received many honors and awards. Over to you, sir.
Yeah. Thank you for those kind words. I don't have an option for sharing. Can I, be made present? Can I be made presenter? I want to share my slides.
Yes, you have the present access now.
No, it is not there.
Please check now. Please check now.
No, I see this is not the facility. Yeah, now it's there. Just a moment.
Is it okay, sir?
Yeah, just a moment.
No problem.
Can you see my screen?
No, sir.
Just a moment. Just a moment. Is it there now?
Yeah, sir. You can.
Yes.
It's okay.
Just go ahead with the presentation mode, sir.
Yeah, done. Is it okay now?
Perfect, sir. Please.
Okay.
Thank you.
So, good afternoon, everyone, and I convey my thanks to Dr. Shabi for giving me this opportunity to share my views and thoughts on diabetes in young, which is a very important, a problem in our day-to-day routine, and it's rising day by day. So there's always a diagnostic dilemma in a way. All diabetes in young people are not type 1. There are many possibilities. Type 2, MODI. So there are a number of, I would be discussing, some cases, and that would make us understand, how to differentiate between different types of diabetes in young. So there is a increasing prevalence of diabetes in young world over. And mainly, yes, type 2 is also increasing because of this modern culture and increase in the prevalence of obesity. So basically, the prevalence of diabetes in young is increased and the challenges are that diagnostic dilemma is one, then cooperation and compliance is a major issue, because this younger generation, they won't cooperate in taking medication. They don't take their problems seriously. But at the same time, we have to understand there have been many studies, especially from All India Institute of Medical Sciences, and there is a study national level that diabetes in young, yes, the most common is type 1, but yes, even type 2, MODI, FCPD, etc. are also there. Now, important point they have noticed in this registry is that the complications in these people are more common compared to adults, and they're more severe. So this is an important thing, that we have to address diabetes in young more aggressively, but correct diagnosis is required. And we have to have a patient-centered approach. So the first case is a 15-year-old boy came to us with history of recurrent boils for 2 months, history of polydipsia, polyuria, polyphagia, 1 week, fever, and weight loss of 4 kg in a month. Sugars were very high, A1C 10.3%, urine ketones plus, a family history of diabetes, father is diabetic. Examination, height 162, BMI 25, no acanthosis nigricans, like no signs of insulin resistance. C-peptide 0.2 on the lower side of normal. Anti-GAD more than 10 units, normal is less than 8. So basically this boy was managed initially with antibiotics for boils, insulin infusion, and was discharged on basal bolus insulin. We were not in a hurry to make a diagnosis on this patient. When patient revisited after 10 days, the C-peptide levels had risen from 0.9 to 0.2 to 0.6. Sugars came to normal. Then we reduced insulin, and since a patient was having a family history of diabetes, we also started patient on metformin. And to our surprise, next visit, the sugar remained normal, and we had to even stop insulin. So this is basically a case of a flatbush diabetes, where even type 2 diabetic patients, we can see here, even type 2 diabetic patients, when they have diabetes for the first time, and it can be very severe, sugars can be very high, ketones can be positive, family history may be there, and some small antibody titers around 10, because for type 1 it should be more than 18, may be there. So what I want to say, that despite of ketones present in a person, in a boy, we should not be in a hurry to make a diagnosis, because some of them may be a type 2 diabetes despite of ketones plus. And there are 4 types of flatbush diabetes: ketosis prone diabetes, that is when antibodies are present, and the beta cell function is, that is insulin levels are very low. Second is idiopathic type 1, when both are absent. Type 2, yes, beta cell function is there, C-peptide levels may be very low because of glucotoxicity, and they may be ketones. But then later on, when you give treatment, C-peptide levels rise. And antibodies are generally absent, but in type 2, around, say 15% of the patients, they may be there, but the levels are not very high. And of course, there's another category, which is LADA, where there's some amount of beta cell function is there. Antibodies are also there, but these people do not, survive on OADs for more than 6 months. Like insulin is required after 6 months of treatment. Now we come to case 2. So this case 1 was basically type 2, presented in ketosis. Now other is case, 18-year-old lady, had type 1 diabetes at the age of 8 years, was diagnosed as type 1 diabetes, on insulin treatment, on basal bolus regime, well controlled till last 1 year, A1C 7.2 on insulin. Now this time, there was a UTI, and she's been having UTI recurrent for last almost 2 months on antibiotics. Fasting plasma glucose 180, postprandial 282, A1C 8.5%, BMI 26.5. On examination, BP was okay, a little on higher side, you can say, and skin tags were present. All other system examinations normal. C-peptide 0.3. So again, it's on the lower side of normal. Cholesterol 219, triglycerides 182, LDL 128, HDL. Any problem? Any problem? Any problem? Am I audible now?
Yes, sir. Yes, sir. Yes, please.
Yeah. Okay. So HDL 38. So basically, it has been reported, there are some cases of double diabetes when patient starts with type 1 diabetes, and as the child grows older, because of this Western lifestyle, these children also try to, gain weight, and then they develop, mild hypertension, dyslipidemia, and some signs of insulin resistance. So what I want to say that these people, type 1 diabetics, later on may tend to develop double diabetes, and then we need to add metformin in these children. So this is another important point we have to understand and remember, that type 1 will never remain only type 1. Maybe they develop features of insulin resistance later on, and we have to address this insulin resistance. So this is a second case. So basically, type 1, if we take is, onset is less than 20 years, no family history, C-peptide either absent or very low, anti-GAD antibodies should be more than 30. The levels are very high. And after treatment also, C-peptide levels won't decrease. Like in our first case, C-peptides were low, but on treatment, then later on C-peptides increased. So that means, basically beta cells were suppressed because of glucotoxicity. And when glucotoxicity was addressed, there was normalization of beta cell function. Then LADA is basically late onset adult, latent autoimmune diabetes of adults. So this is generally after 30 years of age. It's a slow onset, but patient cannot remain on OADs for more than 6 months, and ultimately patient require insulin. Type 2 diabetes, definitely there are features of insulin resistance, and C-peptide levels are generally high. But if there is a glucotoxicity, they can be very low levels. And antibodies are absent, but in 10 to 15% cases, as I told you, may be present, but the levels are low. And these people are well controlled on metformin and other OADs. Now, there is another case, third case, case 3, 15-year-old girl having UTI for last 10 days. History of complaining of all features of hyperglycemia, polydipsia, polyuria for 10 days. She was detected to have diabetes at the age of 13 years and was put on insulin treatment. Presently, her fasting is 156, postprandial 256, A1C 9.2, ketones absent. Family history, mother is positive. She is lean, BMI 20, no features of insulin resistance, vital normal, systemic examinations normal. So such patients also we come across, and generally these patients, since family history is there, but ketones are absent, and overall patient is well maintained. Overall, like BMI is not very low. So these patients are generally taken as either type 1 and they are continuing on insulin, or by doing antibody titer also, this may be absent, and C-peptide levels tend to be normal. So it's a little confusing state, and these children continue to be on insulin. But one thing I would like to convey here is that since mother is having a positive family history, and in Modi we have generations, 3 generations can have diabetes, and patient on insulin also is not well controlled, we should give at least think of a possibility of Modi. So this is another case, interesting case. Children, a 13-year-old girl having diabetes at the age of 13 years, say 2 years back, on insulin, still not well controlled and having UTIs. So we should give a thought process that it may be something else. So other lab investigations here, C-peptide was one, so it was normal. So clinical diagnosis, as I told you, may be Modi in this patient, and when pedigree charting was done, we can see here, this is the patient, Her sister was also found to be diabetic. Mother is a diabetic. Then all mothers, side aunts are diabetic, and maternal grandmother is also diabetic. So here 3 generations are having diabetes. So we should suspect that it may be MODY, and MODY patients will not respond well to hormonogenic diabetes to insulin, and these people respond well to sulfonylureas. So this is only one small, interesting fact that even MODY is not that uncommon. We should at least give a thought process. A child on insulin, not getting well controlled and having some abnormal features, we should do at least a pedigree charting. And then later on, if we really think that it is required, we should be doing genetic testing. So this patient, we started the patient on 2 milligram of glimepiride, and we can see there was a good, control on A1C. So what I want to convey that some patients who are on insulin and they're thinking they're type 1, they remain as on insulin, and we keep on giving high doses, a possibility of MODY should be thought of. And especially when age is less than, here, like in this patient, 1 second. So here, as per the Tattersall-Feazan criteria, age should be less than 25 years. It's autosomal dominant, 3 generations involved, absence of ketosis. It can be controlled with sulfonylureas only without insulin, but genetic analysis is a must for the diagnosis. Clinical features, these people are lean, and there are almost 14 types of MODY, and the commonest is MODY 3 in India, which is NF1 alpha defect, but it can be NF4 alpha, and then even glucokinase gene MODY 2 defect and RCAD. So number of other kinds of MODY are also can be there. So these are different types. I will not be going into detail. So I have presented 3 cases till now. One was type 2 flatbush ketosis prone type 2 diabetes, where a boy, presented with diabetic ketoacidosis. The second was a case of double diabetes, and third I presented a MODY. Now, this is a 4th case, 23-year-old male, diabetes for 2 years, and he's been having recurrent pain abdomen, passing oily stools off and on. Family history of diabetes is there. Non-smoker, no consumption of alcohol. He's on OADs for 2 years, poor glycemic control. Fasting and postprandial values are very high. A1C is 8.2. On examination, BMI 19. So he doesn't, typically he doesn't, fit into either type 1 or type 2. Ketones are absent here. And ultrasound, there is a grade 1, a fatty liver. So such people generally, when young people come to us, we think of only type 1 or type 2. We never think beyond type 1 or type 2. So that's an important thing we have to understand. And in this patient, there's a very clear cut, history of loose motions and, oily stool. So that's very important thing, which goes in favor of FCPD. So in this, you do only an ultrasound, or maybe, sometimes you can go for ultrasound. So in this patient, when, just a moment, yeah, I don't know why X-ray is not coming. So X-ray showed calculi at the level of T12 and L1, a typical case of FCPD. Now, management here is important in a way that normally we restrict, calories, but in FCPD, there is a malabsorption, there is a, exogenous pancreatic tissue may also be involved. So you may require to give high calories, and patient, they are ketosis negative. Ketones bodies in urine are negative, but they are insulin dependent. They cannot be controlled because pancreas is destroyed. And they may also be required to be given pancreatic enzymes. So it's a typical fibro-calculous pancreatic diabetes, where generally it's more common in south part of India, in China, in Chennai and Kerala. And diagnostic criteria: tropical country, recurrent pain abdomen, steatorrhea, and abnormal pulmonary pancreatic function test. X-ray abdomen shows calculi, and ultrasound is very important. There may be, pancreatic duct dilatation, atresia. Then CT scan may also be required. Important thing is that this is in absence of other causes of pancreatitis. And Another important thing is, besides insulin dependent, these people have an increased risk of future pancreatic carcinoma. So that has to be kept in mind. So basically, in type, diabetes in young, it may be type 1, it may be type 2, it may be MODY, it may be LADA, it may be FCPD, and it may be, MMDM also, malnutritional modulated type diabetes. Even GDM may be there, and some kind of endocrine diabetes like acromegaly. So this also is a possibility, but those are rare. Genetic syndromes, and then neonatal diabetes, that is mitochondrial diabetes. So these are all possibilities. But here the most important what I want to convey is type 1, type 2, MODY, more than 30 years, LADA, and FCPD. So these are to be kept in mind, and we should not be in a hurry to diagnose. Maybe 3 weeks to 1 month or 2 months time may be taken for the final diagnosis. Till that time, you manage with whatever medications, oral or insulin, and then once you make a proper diagnosis, then a specific treatment should be given. So basically, in all these young type diabetes, there are 4 things which are very important. One is family history of diabetes. If it is there, it goes either in favor of type 2 diabetes or in MODY. Other is ketone bodies. If ketones are present, then basically it goes in favor of type 1 diabetes. Antibodies are positive, it's a typical autoimmune, and if antibodies are negative, it is idiopathic. But yes, in some cases of type 2, ketones may be there because of glucotoxicity. Then third important test is C-peptide levels, which are low to absent in type 1 diabetes, and they may be normal in MODY, and it may be in pancreatic as well as, and they're generally high in type 2 diabetes, but because of hyperinsulinemia, but may be normal. But this is an important test. And the fourth is an autoantibody. So once we do, go through this algorithm, take my words, most of the time, we would be able to diagnose diabetes in the best manner. So basically, overall, it can be type 1, type 2, FCPD, as well as, MODY. So this is my last slide, and the take-home message is very clear here, that that diabetes in young is not that uncommon, is quite common. All cases need not be type 1 diabetes. There is always a diagnostic dilemma. Need to classify these, and it's not always an easy task to classify these people. Always take 1 to 3 weeks time for the diagnosis. Don't be in a hurry, because once a label is put, that label will remain, for a long time, till someone else, does a test and find out some other, kind of diabetes. Type 2 diabetes is the next common after type 1, MODY and FCPD. Accurate clinical history and examination, it goes without saying. This is an important thing which we generally miss in most of our diabetic patients. We only go with the blood glucose value and straight away start some treatment. Some biochemical test and use of an algorithm, which I've already told you. And there are challenges in management. We have to be very aggressive, because young children, they are having very poor compliance cooperation, and they're non-adherent to treatment. They do not bother about their own health because they're not aware. So education and maybe the family members and the parents should be taken into confidence to tell the severity of the disease, and then the aggressive management is to be done. Complications are more common in these, and they're more severe. So awareness, education, and intensive counseling is an important, and it will go a long way in prevention of diabetes or in best treatment of diabetes in young. So with this, I conclude my talk, and I convey my thanks to all of you.
Mithal sir, it was an excellent session, very crisp and clear, highlighting the different types. You have alluded the different case series of type 1, MODY, LADA, early type 2. I think we'll take 1 or 2 questions if relevant questions are there. Okay, Mithal sir, how common is early type 2 diabetes? Before the age of 20 years, we see so many patients. How common is the early type 2 diabetes in your practice, sir?
It is very common, recently only I tell you, only 10 days back, I had a patient. He's still under me. Weight, is gone to from 12th class to the first year now graduation. Age is 18 years, 18 plus. And weight was 98 when he came to me. The family told me, sir, he had gone to the family physician for small fever, okay, and some vague problems. When sugar was done, it came out to be 320, the first value. Then the family physician referred the patient to me. So immediately, so this is very common now. Adolescents, like school going children, college going, students less than 20 years, type 2 diabetes is very common. But yes, we have to get the test done. So I did the antibodies, I did C-peptide, I'm not saying. So they were found to be C-peptide normal, antibodies negative, and patient was initially put only on 1000 milligram of metformin, and now is doing well only on 500 milligram, today. And his A1C has come down from 11.4 to now. I have advised next time he will come, but fasting is 104.
Okay, sir. Sir, in another thing in your common clinical practice, if a suspicious type 1 diabetic patient comes in, and if we are checking and the anti-GAD antibody comes as negative, would you be happy in doing other antibodies?
Yes. We should be doing, either islet cell antibody and zinc T8 antibody. So these are also important in children. Because if you have a strong suspicion that it is type 1 only, then otherwise, if you think it is a type 2, then you may not go for other tests. But definitely if it comes negative, because anti-GAD is only 65 to 70% of the patients, not in 100% of the patients.
Okay. Thank you, Vithal sir, for that wonderful session. Thank you, sir.
Thank you, Dr. Shabir, and thanks a lot, everyone. Thank you.
Okay, we will move to the next session.
Great seeing you.
We'll move to the next session, which is going to be chaired by Dr. Ramesh Gomez. Over to Ramesh.
Good evening, everybody. Yeah. Next, we have an auspicious speaker from Madurai, Dr. Arthur Joseph Ashirvadam. He is the president of Madurai Diabetes Club, and he has did his MBBS and MD from Madurai Medical College, and he has his fellowship in diabetology. And he is currently a consultant diabetologist in Arthur Ashirvadam Hospital and also Apollo Specialty Hospital in Madurai. And he has got the Lifetime Award from Dr. Mohan's Diabetes Research Foundation, and also he is a receiver of KCP Memorial Oration Award for Diabetes. And he has got more than 70 papers in various journals. And we are lucky to have Dr. Ashirvadam today. Over to Ashirvadam sir for his presentation. Thank you.
Unmute. Sir, can you unmute?
Yeah, I'm getting it.
Slides.
Yes, sir, it's okay. You can share.
Am I audible?
Yes, sir, perfect.
Right, thank you. Respected Chairman and my dear friend, Dr. Sabir, it's really a nice opportunity to be a part of this wonderful scientific event. The most unfortunate thing is I'm missing his personal, what I should say, the love and affection and hospitality, which I'm missing this time. However, this is in the scenario of COVID, probably this is the best that we could do. And I also thank him for giving me this opportunity, and also Novartis for having sponsored this program. So my topic is demystifying, verify from an Indian perspective. So I will take you through what really is to demystify is my concept. So whether you know more about the etiology or pathogenesis of diabetes, the proof of the pudding is to give a good treatment for diabetes. And we have some amount of lack of clarity or probably inadequate knowledge, which probably we should try to get it done in a proper way and in an evidence-based manner. The pharmacological approach for management of type 2 diabetes has a few queries. Is drug combination useful? Is drug combination targeting the pathogenic mechanism? And what is the role of treatment from the beginning? Patients will always like to have some relaxation initially, and later on they would be interested in doing something. Are we justified in allowing it, or probably start the early treatment in a very intensified manner, what you call as a hit hard, hit early? So the questions posed in front of us do have an answer today, and that is my demystification. And with the evidence from the verified trial, it has been proved that these combination drugs has done wonders as far as a pathophysiological mechanism in producing a durable treatment, attacking the pathogenic mechanism, and also the early treatment, which has given better benefits or in the long run, which we are supposed to have for our younger diabetics, as already mentioned by my previous speakers. The concept of tight glycemic control came up after UKPDS study, and probably if UKPDS has proved that there is no point in treating diabetes to a target, all the diabetologists in the country and all over the world would have vanished. But it is very sure that glycemic control is very important. The hemoglobin A1C correlates very well with myocardial infarction or a macrovascular complication. If not with UKPDs alone, the UKPDs follow-up also showed that it correlates well with hemoglobin A1C, and microvascular complications like nephropathy and even retinopathy, they become worse moment the hemoglobin A1C crosses 7. So that is not a difficult entity, but to understand. But the onset of treatment is something is questionable, was questionable, and today we have learned one more lesson as per the Diabetes Care article in 2019, wherein the literature confirms that strict glycemic control of less than 7 from the beginning or less than 1 year of onset reduces the risk of micro and macrovascular events and even mortality. So if that is possible, we should try to provide this to our patients, convincing them about a tighter control from the beginning. It is well known as far as cancer is concerned, even patients are now aware that if cancer detected early could be treated very well. So also diabetes should be identified early, treated vigorously from the beginning to achieve good control, and that would give you the benefits in due course. The results of the Diabetes Care article showed that if you have a hemoglobin A1C of more than 6.5 during your first year of therapy, it was associated with an increased future micro and macrovascular complication. But if it is going to be still high to a tune of equal to or more than 8, it indicates that you are going to have increased chances of developing microvascular events as well as the mortality. So having understood this, if you have a good study to base our status or the concept, this study again proved that when you compare two groups of two cohorts of people who have been having less than 6.5 in the first year or between 7 to 8 in the first year, with a follow-up study of about 13 years, it has been concluded that you have a reduction of microvascular complication by about 40%, macrovascular complication by about 30%, and death reduction is almost by 30% of this particular group with a 13-year follow-up. This is a very sizable reduction of all the untoward effects. Probably we are very aware of the RD sale or probably Deepavali sale, wherein some 20% discount, 30% discount on some commodity attracts our attention. So our attention should be directed towards a massive reduction of 40%, 30%, and 30% of death, micro and macrovascular complications. So if that is so, it is really worthwhile trying to make our patients come under control from the beginning. It is also understood that if you are going to at least give them some good control at some point of time, this is going to be a little more very difficult task to achieve it. At the same time, the benefit is going to be there much lesser when you start it late. So better early, the first year onwards, the treatment should be aggressive and also energetic. So that is the most important thing that we should remember. This is a very common slide that we see due to the clinicians' inertia, wherein you have a reduction of blood glucose, like exercise, diet, monotherapy, combination therapy, and finally with uptitration, and probably you need a basal insulin therapy. You already would have spent 7 to 8 years in this regard, and you would have made this patient develop some complication or other. So our idea should be like the blue line, which brings down the hemoglobin A1C straight down to 7 or less than 7, and maintain it as much as possible throughout. And this would at least give us a leash of 7 to 8 years of tight control, if it is possible with that newer concept of combination therapy from the beginning with tight control. So this is the most important message that we should try to imbibe and tell the patients and convince them to give a modality of combination therapy from the beginning. I still remember my teacher, Professor Alapan, who always used to say, you start with one drug, go up to the maximum tolerated dose or maximum therapeutic dose of the drug, and then add on the second drug, whether it is diabetes or hypertension. And this was in 1979. But today the concept has changed. Try to use combination, attacking the various pathogenic mechanism with lesser than the therapeutic dose, so that the side effects of the drugs are not seen. At the same time, you get more benefit. So this concept has been there, but do we have any evidence to do so? Say that. Now we are posed with the three important questions. Does this particular tight control from the beginning useful? And probably if it is going to be beneficial or not, and really it is quantitatively, is it going to be significant? So addressing these three questions are the concept that I'm going to prove. Now, the mist over this particular scenario has been demystified by the Verify study. So Verify study is nothing but a multinational, multi-ethnic study involving 34 countries, 254 centers, of which India also has been a part of it. And this particular study is a very simple study design, that you take the earliest or at onset or almost drug naive patients and put them on metformin alone in the run-in period for about 3 weeks, gradually increasing the dose, and then randomize them into two arms. In one arm, you have metformin and vildagliptin started from the beginning. In the other arm, you continue only initial monotherapy of metformin and wait for what is the outcome. So when the patients are well under control with either monotherapy or probably metformin and vildagliptin therapy, we leave them at it. If there is a possibility of failure of control, which is defined by a hemoglobin A1C of more than 7 during 2 episodes of check, once happening with a gap of 3 months. When you find that the patient is failing, that means you'll have to do something for it. So in the metformin arm, you are going to add a placebo. And metformin arm, you are probably going to add a vildagliptin. And the metformin vildagliptin arm, you are going to add an insulin. This is the idea. But we really do not know which arm contains which drug, the placebo or the vildagliptin. However, it is a double-blind trial. So this is the concept of this particular trial. So if this is going to go ahead, we have assessment at period 1 and period 2. So when you have this particular study, a good comparator would be an UKPDS, which studied the patients during the onset of diabetes and found that definitely tight glycemic control was better than a conventional control at the point of UKPDS as well as during the UKPDS follow-up study, which gave us a concept of legacy effect. In verified trial, it is almost similar, but now that we have developed or come up in our armamentarium, UKPDS didn't have many drugs except for sulfonylurea, metformin, and insulin. But today we have got the entire area of DPP-4 inhibitor. And in verified trial, we have been using vildagliptin and metformin from the beginning in one arm and only one drug at the other arm, wherein whenever there is a failure in the second arm, you add a vildagliptin as a usual pattern of adding the drug therapy. And it was found that the inclusion criteria are not very difficult, usual age, usual BMI, and the most important thing here is a hemoglobin A1C of 6.5 to 7.5. So this is not a patient who has gone out of control or hemoglobin A1C more than 7.5, wherein AACO guidelines also say that you would have to give 2 drugs. But even if the hemoglobin A1C is between 6.5 and 7.5, adding on a vildagliptin over metformin as an initial start therapy, how does it fare? That is our idea. And diabetes should be recent onset of diabetes with a reasonable amount of EGFR and a drug-naive patient. So in this particular entity, the Asian participation was also there. And among the Asian population, you have a participation of Indian population to about almost half of the Asian population. Why I'm trying to give you this particular data is that if I conclude at the verified trial, you might feel that it could be a Caucasian population study, which could be either applied or could be denied in an Indian population. So we are going to discuss only on the Indian subset or the group of patients who were under this particular study from Indian origin. And probably this is what we are going to look at this particular moment. The total participants of this particular group from India was 318, and the patients who have been randomized was 163, half of them for early combination from the first day, and the initial monotherapy for another 81, almost equal, 1:1 arm. And all of them completed, or most of them completed 60 months. 5 years is a reasonable period for diabetes. And what is our conclusion? This is a baseline characteristics which are almost similar in the both area. And again, I am trying to tell you that the hemoglobin A1C average was 6.8 and 6.8 on both these particular arms. Left alone during my earlier phase, I would not have put them on a combination drug. I would have even put them on a lifestyle modification and waited for some time. Then added a metformin and waited for some time. But this particular concept of adding on 2 drugs at the beginning is this purpose of this particular study. And you have a drug like vildagliptin, a DPP-4 inhibitor, which does not produce hypoglycemia. So we are also safe in using this particular drug, even if the hemoglobin A1C is slightly on the lower side. And also we are sure that metformin nor vildagliptin would produce hypoglycemia. So in this particular area, what are the results that we have obtained? In the first period, what is that we have achieved? The combination, the early combination of metformin and vildagliptin failed to a particular period. Metformin alone, but it has been given with a placebo, that also started to fail at a particular point. Let us see when these two failed. It was surprising that there was a 53% risk reduction in time to initial failure versus monotherapy. So that means the combination was running like a Duracell battery, whereas the other group, the metformin and placebo group, was running like an ordinary battery. I think every one of you would have watched this ad. The Duracell battery goes on for a longer time till you see the all other batteries go off. So it is almost like a Duracell battery. This combination is wonderful and existing under good control for a longer time when compared to monotherapy, with a good reduction of hazard ratio. And it was found that monotherapy lasted only for about 1.5 years. And this also was proved by UKPDS that lifestyle modification metformin was useful only in 1/3 of the people and lasted only for a short while. The combination therapy was there till 4.75 years. That is most wonderful evidence to say that if you put this particular patient on this combination from initial period or at onset, you'll be able to give them a trouble-free period. And as I showed you, the blue line which came down straight away and maintained on the same hemoglobin A1C, you are able to provide a good hemoglobin A1C from the beginning, thereby giving a good legacy effect, good hemoglobin A1C control, and probably freedom from complication and mortality. So that is about the duration of study, and this happened earlier in the Indian subsets because we probably have little less insulin secretory capacity. But in spite of this particular 4.75 years of usefulness, that is not the end of it. Diabetes is a progressive deteriorating disease wherein the beta cell mass goes down. So what happens beyond this particular area wherein in the period 2 where the combination also start failing, then you realized that you have to have an insulin as per the protocol. On the other arm, the comparator arm, what you really identified was, even though you added a second drug early, that was not equal to this particular arm. That is the most important second message I would like to convey. You're ultimately putting this patient on metformin and vildagliptin. If you have added it on initially, that gives you more benefit when compared to adding on same vildagliptin later on after some monotherapy of metformin in due course. So comparing these two arms, what is our conclusion? It was really an amazing fact that the starting early with vildagliptin and metformin reduces the risk of addition of a third agent by 58, almost 60%. That means if you're controlling diabetes, the legacy effect happens, the beta cell probably recovers, and that is able to sustain it for a longer time. Thereby, the need for a third drug is going to be reduced by about 60% in due course when comparing the arm in which both the agents have been started early and in the other arm, control arm, wherein metformin was initially on board, you added vildagliptin later, but though both the drugs are there in both the arms, the benefit was much more when it was started quite early with a hazard ratio of 0.42. The next important message is that, as I showed you the blue line which dwindled down drastically and maintained with a durability, you see here almost 75 to 80% of the patients on this particular arm, the arm which both the drugs were started early, had a hemoglobin A1C of less than 7 throughout the study of 60 months. That is really remarkable. So maybe for 20% of patients, we may have to add a third drug like an alpha glucose inhibitor or some other drug like SGLT2. But on the whole, if 80% of the patients are under control, maybe the window shopping of these patients to some other diabetologist would also not happen in 80% of my patients. So in that way, the diabetes is stable, diabetic patient is stable, and the diabetologist also are stable. So that is a good message for all the three of us. And with this particular good news, I am trying to conclude with a key finding that early combination treatment almost reduced by 50% to the risk of time to initial treatment failure. That is, you need not wait for the failure to happen and then go ahead. You can almost fit and forget for 5 years in most of the patients. And the mean time to initial failure was 1.5 in the initial monotherapy compared to almost 5 years, 4.75 years in the early combination or de novo combination therapy. When all patients were receiving combination therapy, in one group it was started early, in the other group it was started as a measure or a rescue measure as an add-on to metformin on board. When you had that, the risk reduction was around 58%. So finally, the strategy of early combination treatment approach with vildagliptin plus metformin in the newly diagnosed patient significantly and consistently improves long-term glycemic durability compared to metformin therapy. So, dear friends, we now have an evidence to start this combination quite early to give our patients a good, durable control and a complication-free control. Thank you very much for your patient listening and for the nice opportunity. I sincerely thank Dr. Sabir once again. Thank you.
That was Dr. Ashirvadam, demystifying verified from an Indian perspective. Now the topic is open for discussion. Please ask questions to Dr. Ashirvadam. If there is no questions, then we will move on to the next topic. Thank you, Dr. Ashirvadam, for that excellent
Thank you
topic.
very much. Thank you very much.
Real demystifying process. Thank you. And next is
Thank
Dr. Ramamohan MV, Senior Consultant Endocrinologist. He's a Senior Consultant Endocrinologist. Monitor the glycemic control, how to manage type 1 diabetes. Definitely, and I hope you will have a reason for that in this talk. Over to Dr. Ramamohan.
Good evening, everybody. I sincerely thank Dr. Shabir sir for giving me this opportunity. And it was pleasure last year meeting all the eminent speakers in Kerala, and we had a very great time there with scientific feast and also had a temple tour there. And so I would like to are you able to see my screen?
Yes.
Yeah. Yeah, today's my topic is glycemic monitoring and management of type 1 diabetes. What are the challenges and solutions? I want to make this topic very simple. We know that type 1 diabetes is a very dreadful disease, and all the kids whom we love, whom are able to take insulin by themselves and who has different difficulties for the lifelong to take insulin, and all these things also will pose a great psychological, financial stress to the families also. So coming to the challenges, what we face in treatment of type 1 diabetes. So I would like to divide these challenges into first challenge will be about HbA1c control. Second challenge will be about prevention of hypoglycemia. Then coming to the how to monitor the glucose is also a big challenge. Then what is the diet pattern of the kids, and it is the most difficult thing to control is the diet pattern in the kids who we are unable to stop the snacking, junk food intake by the kids, and then comes the exercise pattern. So we adults don't do exercise, and we expect our kids to do exercise, which is very difficult. Then coming to the sick day guideline challenges, adolescent transition challenges. So when the type 1 diabetic people turn into from kids to adolescents and adults, what are the challenges? And then prevention of complications is also a big challenge in type 1 diabetes. So we know that type 1 diabetes can present like acute onset type 1 diabetes discovered accidentally by doing RBS for other region, like a life-threatening DKA, flash DKA can also occur. Patients can also have subclinical diabetes precede the clinical onset. What are the four major clinical phases of the preclinical diabetes? We have over diabetes and partial remission or honeymoon phase, then a chronic phase of lifelong dependency on insulin. And clinical onset is not likely to occur until major loss of around 80 to 90% loss of beta cells has been occurred. So coming to the classification, we have type 1A and type 1B diabetes. Type 1A is about patients having autoimmune positive. We have 4 autoantibodies like IAA, IA2, zinc transporter, and GAD antibodies. And we have type 1B, where around 10% of the type 1 diabetic patients will be negative for all antibodies, but still they have a insulin deficiency. Then comes the type 1.5 or double diabetes, where we have both autoantibodies and islet cell resistance. Insulin resistance also occurs. Coming to the management needs a multidisciplinary team. It's not about the only one endocrinologist or a pediatrician to take care of the type 1 diabetic kid. We had to have a multidisciplinary team of pediatrician, endocrinologist, diabetes nurse educator, dietitian, social worker, psychologist with a family care. So what are the principles of management? The principles of base management is on insulin use. We have diet regimen, regular exercise, physical activity, and then we go for monitoring. So first challenge is HbA1c. See, adequate glycemic control, avoiding hypoglycemia is the major goal. And what is your HbA1c goal in kids? So previously, we used to say that with toddlers and preschoolers, to prevent hypoglycemia, the FBS should be between 100 to 180, PPBS should be between 110 to 200. So HbA1c less than 8.5. From school age, 6 to 12, 90 to 180 is fasting, PPBS is 100 to 180, and HbA1c is less than 8. Adolescents and young adults, we have fasting of near adult range 90 to 130, 90 to 150 of postprandial, and HbA1c of less than 7.5. So, but coming to a summary, if there is no impedance for hypoglycemia, or if the kid is cooperating very well and the sugars are under control, your HbA1c target should be in any kid should be less than 7.5. And if they are facing any other problems of hypoglycemia, recurrent hypoglycemias, then we can keep age-related targets of HbA1c. Then choice of insulin delivery, we have multidisciplinary, multiple daily injections and continuous delivery of rapid acting insulin via pumps. So how to reach this HbA1c control by this mechanism, and mainly glycemic control generally similar with both multiple injections and continuous subcutaneous infusion, but only less number of nocturnal hypoglycemias occur with CGM. So multiple daily injections, which we commonly use, we have a basal options. We have NPH, Glargine, Detimar, and Degludec. Prandial insulin, we have regular aspart, ultra fast acting aspart, Lispro, and glulicin. So we tend to mimic the physiological insulin secretion in all the kids so that we are making the kid as normal as possible. So this chart everybody knows. We have a basal insulin with meal related peak of insulin secretion, which we tend to use by basal bolus regimen. So other challenging is about the insulin injection site. See, last week I had a type 1 diabetic patient who is coming first time to my clinic, and I was astonished to find there are large abscesses over the forearm and in the upper arm regions. Saying that what has happened, he is saying that he was taking insulin in the forearm and upper arm regions. Saying that not only prescribing insulin and making the kid to take the insulin, to rotate the areas of insulin injection is also important to prevent lipoatrophy and lipohypertrophy, and to have a erratic hypo and hyperglycemias in these kids because of this lipoatrophy, which is making the insulin absorption in an erratic way. So we had to explain your kids, and I had to make the kids to take insulin in front of you so that they'll learn better. Then coming to the second challenge, hypoglycemia, our goal should be to prevent hypoglycemia at any chance. So you know how dreadful it will be to see the parents having their kid in hypoglycemia, patient with unconscious state, patient with drooling saliva, and patient throwing fits if encephalopathy is there. Like that, this will be dreadful to the parent, and they will be very afraid of the insulin also. So at any cost, we have to prevent hypoglycemia in kids. Mainly, we know that this continuous glucose monitoring system will help to reduce hypoglycemias in our patients. So there is also chance of patients getting into hypoglycemia associated autonomic failure. We know that recurrent hypoglycemias in a patient will lead to autonomic failure, will lead to less concerned about the hypoglycemia, and there will be unawareness of hypoglycemia, which will also be giving a problem to the patient because they are unaware of the hypoglycemia. So every kid, you have to tell them that the clinical symptoms of hypoglycemia, if they have any sweatings, if they are missing any meals, if they are missing any snacks in their school, they should be knowing about the hypoglycemia risk. And if the kid is going to the school, they have to tell to their class teacher, their class leader, and to the headmasters, so that they'll be knowing what to do first aid in hypoglycemia, acute hypoglycemia occurring in a school, so that the first aid can be done and the baby can be saved from severe hypoglycemia. So the solution is minimize hypos, and continuous monitoring and education is also very important. So coming to the third challenge, glucose monitoring, how to monitor the glucose in type 1 diabetic patients. We know that home glucose monitoring system, ideally more than 4 times a day, is advised in all type 1 diabetic patients. But it is very difficult for any type 1 diabetic patient to look 3 or 4 times blood glucose in home and to report to you. But minimum of around at least twice or thrice a month, take pre-breakfast, pre-lunch and pre-dinner and bedtime. They make a chart of it so that they'll come back with the reports to you, so that you will find out how the trend is going on, whether they are going for hypoglycemias or hyperglycemias, are there any extreme excursions of the glucose, blood glucose levels without knowing to you, and you want to change any doses, you'll be knowing properly. So we know that intermittent blood glucose monitoring is like taking a camera, because you know the snapshot which happened at that point of time. For example, if you check a blood glucose fasting, you'll be knowing fasting sugar. If you do a blood glucose at 11 or 12 a.m., you will 12 p.m. or 11 a.m. you'll be knowing pre-lunch breaks of sugars, but you don't know what is happening in between. So continuous monitor is like a camera which captures the whole picture like a video. You know what is happening in continuous way, so it gives them more advantages of glycemic excursions, how they are happening, and you want to keep your blood sugars in time in range. This continuous monitoring helps well. So it is hard to be good at all time. You can see that you can see that 6 a.m. fasting is around 130, 12 p.m. fasting is around 130, again at 7 p.m. 7 p.m. it is 90, and around at 10 p.m. it is around 150, but 140. But if you see, due to erratic food eating behaviors in this kid, you can see the CGMS is entirely different. So it is like you can compare the camera that shots with a continuous glucose monitoring. Here it shows how erratic it was, and when you see the multiple parameters, they are normal, but the CGM is different. So that the benefits are, compared to SMBG, CGM reveals dangerous glycemic excursion. Thus, real-time data allows the patient to intervene and optimize the outcomes. This is the best thing you can do in a type 1 diabetic kid. So we have newer technologies. We have a sensor, we have a transmitter, and we have a monitor for CGMS, and we have a closed loop and open loop system. The future is like, no, we are having insulin injections and episodic glucose monitoring. We'll go ahead with insulin pumps and continuous glucose monitoring. Final, our target is artificial mechanical pancreas. And you know that first insulin pump, how much it looks, how much big it looks like. You can see here in this picture, and in continuous subcutaneous insulin infusion, we have a choice of insulin of rapid acting. Initial dose will be there, basal rate and bolus dosing can be monitored. And we have two types of pumps. We have hybrid closed loop system and automatic closed loop system, which detect the hypoglycemia and they themselves give the bolus also. So we should think like pancreas. So that means how our pancreas works in a normal person. So that if you think like pancreas, then your type 1 diabetic patient will be safe. So you also should keep in your mind that most of the children who came at the diagnosis, time to have diagnosis, will go into honeymoon period. That means, for example, after treatment of 1 to 2 months, suddenly drastically the use of the doses of insulin comes down to less than 0.5 units per kg from 1 unit per kg, and it stays for about around 1 to 2 months or up to 2 years duration in some patients. But you never miss the insulin in them. You try to give low dose insulin treatment, observe the patients, so that they never go again into DKA. This occurs because of the honeymoon period, is because of the that glucose stunning and that pancreatic beta cell stunning. There is a mild recovery of your pancreas, so that some of the insulin is produced more, and the patient's going to honeymoon period. So you have to keep in mind this also while you monitor type 1 diabetic patients. Then coming to the fourth challenge, it is diet. So what is your goal? You should give every type 1 diabetic child a balanced diet. So to remain ideal body weight, to promote growth, the main aim is to have a 3 main meals and 3 mid meal snacks. So you have to have a good carbohydrate, protein and fat ratio, and you should have a good fruit amounts and vegetables snacking amount should be there. You can ask your kid or you can ask your parent to count carbohydrate count if it is possible to them. You make the child and parent learn about the need for fruits and vegetables amount portion in your plate, food plate, so that they never going for uh, unhealthy snacking. And ask the kids to stop taking uh, junk foods, cool drinks, or beverages which are high rich in sugars. So then coming to the exercise, the goal is to keep fit and healthy. So exercise, physical activity, children should be encouraged to participate in all games and sports activities, and you should have a simultaneous glucose. It stimulates the glucose uptake into skeletal muscles, plays a very important role in management of diabetes. It occurs. It does a good work in, so if physical activity or physical exercise does benefit your kids much very well. But you should ask, when the kid is going for a strenuous exercise, you should ask the kid to have a small snack so that that kid doesn't go into hypoglycemia. So risk of hypoglycemia with vigorous exercises occurs. So extra carbs should be given to the kid before exercising. So then coming to the sick day guidelines, main goal is to prevent ketosis or DKA, prevent dehydration, prevent ketosis, or prevent hypoglycemia. Sorry. So ketonuria or ketonemia suggests either insulin deficiency or kid is starving. You should see in these patients. And any infection in diabetic child can precipitate DKA. Maintain dehydration at home, frequent blood glucose monitoring at home, and check urine for ketones if positive. Will need more short-acting insulin. And hospitalization if ketonuria or hyperglycemia persists or patient develops persistent vomiting, so that you have to treat this acidosis as fast as possible. So next complication is next challenge is prevention of complications. We know that the most common complications are acute complications like is there and have an impact on growth. The patient is having uh, poor poor glycemic control, and patient will be having impact on growth and puberty also in type 1 diabetic kids. So complications, long-term complications, we have nephropathy, retinopathy, neuropathy, and limited joint mobility. We know that indications for screening all the neuropathy at the start of puberty are more than 10 years, which is earlier. Once diabetes is duration is more than 5 years, you have to screen every kid for all these complications and look for hypertension in type 1 diabetes. Measure BP at every visit. Use a children that cuff which is probable for your kids. Now, don't use adult cuff, BP cuff. It gives a false BP readings. And target blood pressure should be less than 130/80. Then coming to the dyslipidemia. So any family history of CV events or family history of unknown hypercholesterolemia, fasting lipid profile more than 2 years of an age should be diagnosis, and family history is unremarkable. Do a lipid profile more than 10 years. Diabetic diagnosed prior or post puberty, post diagnosis immediately do a lipid profile. So don't miss this also. So coming to the other monitoring areas where other complications like other autoimmune diseases associated with type 1 diabetes. We know that autoimmune thyroid disease is highest highest thyroid disorder, highest autoimmune disease associated with uh, type 1 diabetic patients. You have to look for TPO antibodies or thyroglobulin antibodies. It is around 25%, and more than 10% of our kids go into hypothyroidism, overt hypothyroidism. In my opinion, every type 1 diabetic kid at time of diagnosis should be looked for autoimmune thyroid hypothyroidism. And coming to the celiac disease, which is like a very bad disease, but it is not often looked properly. You should look for malabsorption in any kid. You should look for fragile glucose control in any of your type 1 diabetic kid. Erratic glucose readings in your kid which are not up to your expectations. Then you look for celiac disease. Ask for any gluten sensitivity. Then do a tissue transglutaminase antibody test in associated with serum IgA levels, and this is as high as around 18% in our population, and around 10% of type 1 diabetic kids going to celiac disease also. This is also not looked properly by all the diabetologists and endocrinologists. So coming to the adolescent transition, we know that every kid should go into smooth transition from children and adolescents to adults also. Changing insulin sensitivity related to sexual maturity and physical growth occurs because during the puberty, there is a surge of hormones which are against insulin. Insulin is one way, anabolic hormone, other catabolic hormones like cortisol, growth hormone, you have testosterone, all these things are in the other side of your balance, so that you should have a these hormones tend to increase the insulin sensitivity, tend to decrease the insulin sensitivity, tend to increase your insulin resistance in these patients, and ability to provide self-care. They should know about their own self-care. Should be able to take insulin by themselves, and education is also important. Supervision in child care and school. Unique neurological vulnerability due to hypoglycemia and DKA should look in adolescent population. Then attention to family dynamics, developmental stages, psychological, physiological differences related to sexual maturity is an essential thing. So all teens transitioning into emerging into adulthood, healthcare providers and families recognize their many vulnerabilities and prepare the developing teen to become adult, and also see that these people are given good education about their disease 1 year prior to the transition. And both pediatricians and adult healthcare providers should be assist providing support and links to resources for the teen and emerging adults. So I would like to conclude that in type 1 diabetes, we have very number of challenges, and how you approach these challenges will make you successful, and so that your type 1 diabetic kid will be healthier and will be having a good lifespan without any complications. So you should never forget all these 8 challenges which you face commonly in all type 1 diabetic patients, so that you get a definite benefit in treating your type 1 diabetic patients. So I'd like to conclude this. By saying that monitoring and targeting all the HbA1c levels in your type 1 diabetic patients is major role. And so if you follow all these challenges and if you find all the solution to the challenges, your type 1 diabetic kid will be at a healthy state. Thank you.
Dr. Ramamohan, glycemic monitoring and management of type 1 diabetes, the challenges and solutions. Thank you, Dr. Ramamohan, for an excellent presentation. Actually, it was very crystal clear. One question I would like to ask is, how often you have to prescribe oral hypoglycemic agents for your patients with type 1 diabetes for one or the other reasons?
Oral hypoglycemic agent, am I right?
Yeah.
Yeah, see, generally, most of my type 1 diabetic patients, when they become little obese in the teens, I use only metformin in them, but it also doesn't work well. I go around 1 gram per day to decrease the insulin doses up to 10 or 15 units per day. But some patients it works well, but other patients doesn't work well. But we never use any other oral medications. Only in teenage group, as I told you, to reduce the insulin resistance, I use metformin. Other than that, I never used any drug, and they won't work. If that kid is a type 1 diabetic kid.
Thank you.
And using Oglibos, we have some also use Oglibos or Acarbos, but these people are kids, and their tolerability is also a very issue, and their eating habits, and we had to look into that. But around 1.5% of decrease in HbA1c seen with Oglibos in type 1 diabetes. And we have upcoming data about SGLT2 inhibitors, and we need time for that to come true, and we have to look for decay in these patients also.
Thank you.
Okay, thank you, sir. Next, move to the next session and for chairing.
Thank you, sir.
May I welcome Dr. Balakrishnan Velior. Sir, over to you, sir.
Okay, I once again like to thank Dr. Shabir for inviting to chair another session on insulin symposium. In the next 40 minutes, we have got 2 topics by 2 eminent speakers. The first topic is the pragmatic choice for insulin initiation taking clues from the realities by an eminent speaker, Dr. Manohar KN, is the consultant physician and pathologist at Sharada Medical Center, Manipal Hospital. He is the clinical examiner for the PACES in MRCP UK, and again he was the organizing secretary of the Karnataka RSST in the year 2017. And he was the chairman reception committee of the famous APCON 2018, and he had several research, especially in the area of clinical research, and he was the principal investigator for several clinical research. And now he's the medical director, GT Foundation, CMEs and ACP Corporation. And it's a very pleasure and privilege to invite him for his talk. Over to sir.
Thank you, Dr. Balakrishnan. I heard the last three talks were very nice and interesting. And thank you for those kind words. I'd like to thank Dr. Shabir. As Rama Mohan was also saying, we really cherish coming to your place rather than doing it in the digital way. But anyway, the need of the hour or the situation is such that we can only go digital. Well, the topic given to me is the pragmatic choices for insulin initiation, taking cues from realities. I'm glad to say that I was part of these two trials, actually. Not trials exactly, it is a study. The IDMPS study and the landmark study are the two things which we look in, and that gives us a real world data. We all know that the real world data is actually becomes much more important than the clinical phase 3, phase 4 trials, because that is what we see, how the molecule which behaved in a controlled environment in the trials earlier to launch, how does it behave in the community is the thing what we need to look at, isn't it? So type 2 diabetes in India, the ground reality is not really good. We'll look into that. Timely insulin initiation, yes, it's very important thing. How do we do it is what we'll discuss in brief. Basal insulin in type 2 diabetes and some summary. This is how we go over these topics. So landmark study design is the first national multi-center longitudinal prospective observational study. So it is just an observational study, and about 382 sites all across the country was there. We were having about 6,200 patients, and diabetics between the age of 25 to 60 who had diabetes at least for 2 years or more, and who were on oral anti-diabetic agents more than 2. How they behaved over the next 3 years was just observed. There was no active intervention in that. IDMPS is a very famous study, International Diabetes Management Practice Study. It is just designed for the developing world to look at what we talk, is it put into practice, or what is really done in patient's practice? How does it fare over a period of time? There were different waves of the study, wave 1 in 2005 to the wave 8 in 2018 to 2020. I was actively involved in at least 3 of these waves, and the total amount of patients which were in this study was about 85,000 patients and across 50 countries. So this was an important study. So what is this 2 studies data mean to us when you look at insulin as the choice of therapy is what we look at in few slides. So the glycemic control in Indian diabetic patients, definitely even the worldwide it is bad, even in our setup it is bad. The IDMPS wave 7 showed that only about 25% of the people are under control. Even in US it is about nearly 30%. Add to it the ABC, the HbA1c, the blood pressure and the cholesterol, the percent comes less than 10 actually, the worldwide figure. So in India also, the control was about 25.2% were in the ADS set target of less than 7. And the mean A1C was about 8% or so. So we all know that suboptimal glycemic control is equal to increased risk of diabetes complications, may it be, and it correlates much better with the microvascular complications as opposed to the macrovascular complications. So the landmark statistics, which looked into the complications in a more detailed way, looked at that the neuropathy, nephropathy, and retinopathy were definitely higher in those group of patients who had a higher A1C as opposed to people who had a normal or near normal A1C. So, and the complications were present in the, it's about 68% of the people. I think it is astonishing figure, 60 to 70%. Of course, some data are available. Even nephropathy is present anywhere between 40 to 60% of our normal practice, whether it be in the form of proteinuria or deranged creatinines or the eGFR. So we need to thoroughly evaluate and look for these complications. And we all know that neuropathy could be the most common complications. And many times, apart from symptoms, we don't look beyond it to measure the problems with neuropathy. So timely insulin initiation in diabetes, what is the rationale and how do we go about it is the next few slides. We all know that unfortunately diabetes is a progressive disease. We have all beautiful molecules right from metformin to SGLT2 inhibitors, various insulins and GLP-1 based therapies, which all definitely provide good glycemic control, but they don't arrest this as the time passes by. There is a decline in the beta cell function, and with every decline in beta cell function, we don't have anything to reverse it, but we may add on some medications in combinations to try and control the glycemia better. And a better glycemia may help in reducing the decline, but it won't arrest it. So this is a well-known slide. This is more interesting actually. So what it says is about 6 to 7 years from the diagnosis of diabetes, most patients actually end up with insulin. And on to the right, if you look at it, is a very, very interesting and a quite alarming study. Anywhere between 3.3 years to 5 years, most of the complications of diabetes like myocardial infarction, heart failure, chronic kidney disease, neuropathy, stroke, etc. are seen within this about 3.2 to 5.2 years of diagnosis of diabetes. Actually, this was data collected from the American healthcare system, and the analysis was done, and it was shown that in a few lakhs of patients have been taken and analyzed, and this is quite alarming. I think it should wake us all up and to look for complications and try to control the diabetes even in a better way. And also, if you look at the left of it, it says 6 years or so someone may require insulin. If you look at many other studies, it is clearly shown that insulin delay happens at least almost 6 to 8 years. You decide to start insulin today, but by the time we decide and by the time we start, the gap is about 8 years, and it could be due to physician inertia, patient inertia, or the situational issues, which we'll address in some other day. And initiating insulin type 2 diabetes, what should be the important thing, what we should come to our mind? If someone is on more than 2 OADs, which are used maximally, if someone has osmotic symptoms, even see consistently more than 7, but many studies have shown that it is initiated only if it is more than 9, and there is a significant insulinopenia, which is, I don't think we can test it every patient, but it's more of a clinical behavioral pattern of ours, and if the duration of diabetes is more than 5 years, then we should think of using insulin. Of course, we have got some beautiful drugs in the form of DPP-4 inhibitors and SGLT2 inhibitors, which possibly have delayed the insulin use. And I don't deny that fact, and there could be some advantages with the use of those drugs also, but we need to be open that aggressive control of the A1C, as the UKPDs have shown, that it reduces the complications. So if you look at the landmark study 6, study at the study and 6 months follow-up, as expected, people who were comparing insulin patients and people who are on insulin naive, there was a significant statistically reduction of HbA1c, fasting, and postprandial blood glucose. The statistical significance value is quite very significant, 0.30 followed by 1. So insulin definitely helps us. We should make up our mind. We should convince ourselves first. We should convince our patients and adhere to it. Not only that, there are many studies which have shown that starting is fine, then titration also we fail back quite badly. So we should not only initiate insulin, but also we should titrate it accordingly. So insulin initiation inertia should be overcome. And then if you look at this graph, it's very interesting. If you look at the HbA1c on the left, 7 and more than 8, and number of OAD added, and what is the probability that someone will add another OAD or would go in for insulin, only if the A1C is more than 8. And if there are more than 3 OADs, the chance of that patient getting insulin is about 22% only. So it is still, there is a large gap between what we talk and what we really do. Ultimately, we want a good glycemic control, insulin or other medications, modification of diet, exercise, education becomes more important. So even if someone is on 3 OADs in full dose, A1C is more than 8, still only about 22% of the people are thought of giving insulin. So that is an alarming figure. So what is this initiation inertia of insulin? So there is something like insulin. When you talk about insulin, when you say that, most often than not, the patient will say, no, I don't want it. There is an apprehension. There is a dejection, thinking that is the end of the world for them. The diabetes is out of control. They think about discomfort, and they think about some other close by doctor to visit for sure. I think what I generally do is I talk about insulin a bit early, 1 or 2 consultations before only. I prime the patient and tell them that insulin is not a punishment for you. It is not a thing to tell that you have failed your diabetes treatment. So, and when we talk about it positively, many people do accept it. What is the impact of insulin distress? There will be prolonged periods of poor glycemic control. As I said, about 8 years of delay is there. And the poor intensification therapy, that will take another 2 to 4 years. It will realize in a reduced compliance to insulin therapy, greater distress, poor control of diabetes, increased complications related to the diabetes, and its complications becomes more. And this clinical inertia, if you reduce it itself, it can improve the complication is as good as adding another medication to treat diabetes. So what is the HCP behavior? There are some issues with us also. We always are falling short in time, and we do not take enough time to explain, prime the patient, and try to help them understand. Especially it is shown that many people, if we ourselves demonstrate, if we have the time or if we have someone dedicated in our own clinic who can demonstrate the insulin use, it becomes much more easier for the patient to explain, accept it, and also understand it. And it will also include the patient in the management of diabetes actively. The only other place is GDM, where people are really proactive in the management of diabetes. Insulin is another thing. We motivate them, we explain them, and small algorithms, plus minus 2-4 units, they can do it on their own instead of waiting for us to come after 3-6 months and then say that the sugar is not under good control. So in that context, as I was talking, before patient needs insulin, you talk about diabetes, how the decline is there, and role of insulin. I always tell insulin is the rate limiting step of pathogenesis of type 2 diabetes. If that is fine, I don't think we should have diabetes at all. So we should explain to them benefits of it, what are the signs and symptoms, what are the complications. People fear maybe we overdo a bit of hypoglycemia with respect with the newer molecules, especially the basal insulin. The risk is much lesser, and if the patient is taught, the risk is further lower. And long-term follow-up, injection techniques, monitoring of blood glucose techniques, rotation of the site, all these things become very important for us to be educating the public about it. Insulin education program is very, very important. As I said, we are always busy, but if we have some access to diabetes educators, nurses, and most of the companies are providing their services also. If you look at the pre-education and post-education acceptance of insulin, it is a whopping 35% of people whom otherwise wouldn't have taken insulin would take it, provided we make ourselves some time or we have a proper setup to say just to educate and train the patients on insulin. So 35% is a great number to achieve. So coming to basal insulin, which and why and how, increasing basal insulin adoption is seen. Of course, we are always a pre-mixed country, mainly because of the ease of availability, and the NPH was definitely falling short by duration, and also the peaking effect with higher doses, so the risk of hypoglycemia was there. So in 2011, the AppCare study showed that basal insulin use was about 13%, but the landmark study, which we were a part of it, showed the instances of use of basal insulin relatively to premixed insulin has gone up and could be as good or more number of patients are on basal insulin. Again, it is the decision of our own to see where we want to use basal versus the premix. I usually say if the patient is quite early insulin initiation, basal has definite advantages. If someone requires basal plus therapy, possibly premix or basal plus is important. And again, based on the individual sugar parameters also we can decide. And then most of the guidelines, as we all know, talk about basal insulin as a first add-on to metformin also. And even now the Indian guidelines are more towards premix because of the easy availability, covering of the postprandial, but slowly we are also looking into utilizing the basal parameters. This is a famous graph by the Monier et al. Where it says between 7 to 8 HbA1c, the contribution of fasting and postprandial are equal, and higher A1Cs, like more than 10 or so, the fasting contribution is about 60%, as opposed to the postprandial contributions about 39%. Again, there are a lot of variants to it. The Indian data slightly shares different stories, but definitely fixing the fasting first, as this graph beautifully shows. If you knock out that fasting level it to be higher, the postprandial automatically comes down, and that definitely gives us an advantage to manage the diabetes better. So the standard adage what we use, the fix the fasting first. So So is there any data between basal versus the premixed or the co-formulation? Yeah, there are a lot of studies, plus and minus to it. If you look at the other company stocks, they may show that is better. But of course, we are all, each person can be having a different opinion on that. But if you look at these data, what I am suggesting, it says about 26% greater A1C reduction with Glargine U100 was shown in this laptop study as opposed to premixed insulin. Not only that, the safety with Glargine with respect to the hypoglycemia, weight gain, and insulin dosing were all much better as compared to the premixed predecessors. And if you look at the co-formulation also, this study which was published in PLOS ONE showed the HbA1c to be nearly the same whether you use basal versus the co-formulation, but the hypoglycemia risk was slightly lesser with the basal insulin. Possibly the short-acting component of the co-formulation had a slightly higher risk of hypoglycemia. So how do we start it? Well, there are many people who believe in calculations. I'm not a big believer of calculations, honestly. But two things which we need to keep in our mind is the HbA1c or the individual glycemic parameters and the body weight of the patient. If someone's A1C is high and the body weight is higher, you can move to 0.3 units per kg. If someone's A1C is not so high and the body weight is not so high, it is 60 or less, you can just calculate it at 0.2 units per kg. Of course, it requires immediate titration once in 2-3 weeks or once in 4 weeks, depending upon the case. Of course, we know this. There is definite synergism between conventional OADs and basal insulin. Basal insulin provides beta cell rest. So on top of it, sulfonylurea could work more effectively. Biguanides reduce the glucose production. Alpha glucosidase inhibitors especially are useful to counter the postprandial rise. So these options are there, and now the two new molecules, not so new now, the DPP4 inhibitor, SGLT2 inhibitors have studies which have shown that they work equally good when you combine with the basal insulin. So to summarize my talk, timely insulin initiation can prevent beta cell exhaustion. We all know that basal insulin, by acting for longer time, gives good beta cell rest. Global guidelines vouch for basal insulin as an add-on to metformin also. And then there should be a holistic glycemic control should be there. And there are many types of designer insulins which are available, and we can go for it. And Glargine U100 has stood the test of time and has been the most commonly used basal insulin worldwide. Thank you so much. If there are any questions, I'll be glad to take.
Yeah, thank you, Dr. Manohar, for a very excellent talk. And as he has already mentioned, this is a very complex issue. What I think, even the USAID, IDF, and ADA has got a different opinion. What is the insulin to be started? That is what I learned. Anyway, you made it a very excellent presentation, and very happy to get any questions from the audience. And we didn't see much questions from the chat box also. So we'll move on to the next topic if no more questions. Okay.
Yeah. Thank you. Thank you, everyone. Namaste.
Our next speaker is none other than Matthew John. He was a widely invited, well-reputed, and well-acclaimed speaker in Kerala. I had the opportunity to hear his several talks. And I think I have chaired some of his sessions, some other conferences also. And he is one of the most wanted speaker. That is what I understood. And it's a very happy thing to have Dr. Matthew for this talk. And he'll be coming with the topic that is the basal insulin strategies in glycemic variability in time and range. And it's only depending upon the HbA1c and monitoring the blood glucose and decide the complication optimizing. I think there is some issues. Now the recent concept, they are moving into time in range and looking into that aspect of the glycemic variability and preventing early complication and treatment. I think Dr. Matthew will be talking on this newer insight into the area of controlling the blood sugar using the time and range concept, which is evolving.
Yeah, thank you, sir. I'll be speaking on basal insulin strategies for glycemic variability and time in range. So basically, TIR as a concept is very much evolving. So we don't have many studies which look into this particular aspect, but I'll show you some studies which are available. And we look at how the newer insulins are able to take care of this concept of glycemic variability. And we'll also look at the limited studies which we have comparing both Digludec and Tujo in terms of the glycemic variability and TIR. Okay, I have some problem with the, yeah. So the important thing is that why do we need anything beyond A1C? We know that HbA1c by itself is a very good test. And I think if you look at most of the studies which have been done in the world over, HbA1c has been chosen as the point where we are trying to reach. And even now, even with newer studies, HbA1c continues to be our best tool in terms of looking at integrated glycemic control. But there are certain limitations which A1C in terms of certain hemoglobinopathies where you can't use it, in cases of extreme anemia and in pregnancy where there are changes in blood cell turnover, you are not able to use this thing. So beyond this, most purposes, we are able to use A1C. One important area which has evolved over the last few years is that glycemic variability is associated with complications and you need to tackle that. So that is the reason why A1C is getting an added friend, I should say, in terms of parameters which look at glycemic. You can't replace HbA1c with a CGM-based method. You can supplement that with a CGM-based method. I have some issues with the, okay. So what is that? Why is the time in range important? So these are certain studies which have looked at people who are having the same A1C. So if you have people with same A1C, there can be people who have spent a lot of time within a normal range without much of fluctuation. There can be people with some fluctuation, and then there can be people with difficult fluctuations. All of them may tend to have the same A1C. So what has been found is that despite having the same A1C, if you are having increased fluctuations, you tend to have an increased risk of diabetic microvascular complications and also certain indicators of endothelial cell dysfunction, which shows that glycemic variability may be a lot of missing things which patients who have complication and normal sugar are likely to have. And also there are studies to show that patients have different energy levels. I think in OPD also we realize that some patients will come and tell you that sometimes they feel that they are not doing well. But when you look at everything, everything is going fine. So it is believed that this glycemic variable is probably the thing which is responsible for this sort of thing which is happening. Now, what is this concept of time in range? I think we have had experts in the previous talks looking into time in range, but basically in patients with diabetes, to prevent complications, studies have shown that at least 70% of the time they should remain within a range. And the range is usually defined as 70 to 180. That is the range in which people should behave, should be in. And that is helpful in terms of preventing complications. So if you can see the picture, the dark green ones are the ones which is showing time in range, that between 70 to 180. And you should minimize the time above the target range, that is high and very high values, that is above 180. And you should minimize also the amount of time that you spend in hypoglycemia, that is below 70. So these are all some of the requirements of which organizations have now put forward to reduce the risk of complications. This is in addition to the A1C. Now, just to show you some targets which we are trying to achieve for people is that one is for, I don't want to run through everything, but just to tell you the point which I just showed you, that people should have more than 70%. You can look at the first picture, the first column. The target rate of 70 to 180, the ideal thing is that most people should have more than 70%. And more than 180, you can see ideally you should be only into less than 25% of time you should be spending there. And more than 250, only less than 5% of time you should be spending there. And when it comes to hypoglycemia, also similar, you should be spending only around less than 5% of time below 70. So only when you have a continuous glucose monitor, we are able to identify these sort of time in ranges. Now, I'm not going into specific studies, but these studies, the one showing the retinopathy risk and the nephropathy risk, both of which increases when you have people moving out of time in range. So this is data which is actually modeled from the DCCT study. Although in DCCT study, CGMS was not done, a lot of people had multiple readings which was taken, the monitoring readings, and these readings were put together and analyzed to find that retinopathy and nephropathy increases with time in range when people are beyond the time in range in terms of, you had said that 70% is the idea. If it at least change by 10%, you have an increased risk of complications. Similarly, also data from neuropathy studies and also studies of endothelial dysfunction like and also carotid edema media thickness. So, lot of microvascular and some macrovascular factors seem to be related to glycemic variability. And now I think almost all organizations have put glycemic variability and time in range as one of the important parameters. If you look at the 100 patients that you see in your outpatient department, not even 1% of patients in your outpatient department will undergo a continuous glucose monitoring to really find out the time in range. I was listening to one of the talks by a person from the United States when he was telling that the futuristic clinics, every patient who comes into their OPD will have a time in range, will have a CGM done, because they say that this parameter is so important that they are finding it difficult to manage without this parameter. So that is probably a very futuristic decision. But as of now, what we can think is that even though we don't measure time in range for most of our patients, we can still use treatment modalities and therapies which will produce less of glycemic variability. So the question is, does insulin address the time in range? And among the insulin, which one can you use to take care of time in range? So we will be talking about basal insulin, that is a point of interest today, and how does it look at glycemic variability and TIR. So this is how from a conceptual model. So if you have a patient who is on insulin, you are likely to have a very much during the course of the day, very many times where people may be having peaks of blood sugar. And there also may be times when there are troughs of blood sugar. So we don't want the peaks, we don't want the troughs. We want the patients inside a very conservative range of 70 to 180. So how can we use therapies to prevent, or insulins to prevent this sort of thing? So the two things which we need to address is, one is the peak, one is the trough. The peak is caused by post-meal glucose excursions, and the troughs are caused by hypoglycemia during the interprandial period. So how does basal insulin take care of this? When you use glargine, your PPBS the postprandial becomes controlled, not directly. It gets controlled because the fasting sugar is reduced, so that the peak of sugar is also postprandial is also reduced. Similarly, when you have oral hypoglycemic agents, which you can use along with basal insulin, you can reduce the peak of blood glucose which happens. How do you take care of troughs? The troughs come because there is no calories in the interprandial period and the patient goes in hypoglycemia. So when you have insulins which are having less variability, you tend to have less of hypoglycemia. That is very well known that glargine as a molecule produces less of hypoglycemia than NPH. And again, glargine as a molecule produces less of hypoglycemia than a premixed insulin when you target fasting glucose as the primary target. Now, I'm not going to run through this entire slide, but just to tell you that basal insulins, we have been all using basal insulins for a very, very long time. And just like Manohar sir told, basal insulins are gaining in experience, have gained in experience over a period of time. And now they are at par or even better than the premixed insulin in terms of initiation in most of the areas. So basically, these are once daily insulins. It's easy to initiate, it's easy to titrate. And as you have moved from NPH to glargine, the variability also has come down. And your total daily dose is less in compared to premixed insulin. Hypoglycemia is less and weight gain is less. And so more people adhere to basal insulins than to premixed insulins. Now, not going into again these things, this esteemed audience is sure to understand or know that glargine U100 is a peakless insulin in terms of being better than NPH, but still there is a small peak. Detemir is also as good as an insulin with much better than the NPH. But when it comes to the second generation insulin, Digludec and U300 glargine, these both of them are better than the U100 glargine in terms of glycemic variability and the consistency of action. Now, how are the studies? So the important part of looking at the next few studies which I'm going to show is that first thing we should all realize is insulin as a molecule is equipotent. Whether you're using basal insulin or glargine or NPH, or you are using, say, Actrapid or what you say, premixed insulin, whatever insulin that you use, every unit of insulin will reduce an equal amount of sugar for the patient, irrespective of whichever insulin you use. But the importance is that some insulins have lesser variability, lesser hypoglycemia. Some of them have higher variability, higher hypoglycemia. So you cannot sort of compare the glycemic control between two insulins. You can only compare risk of hypoglycemia, risk of nocturnal hypoglycemia, glycemic variability, etc. between insulins. So this particular study, which I'm showing you first, this is made very simple for understanding. Compare the glucose control between U100 and U300 glargine. It's a 16-week randomized crossover study using a small number of patients, 59 patients, because you know that CGM-based studies are it's not easy to do with hundreds and thousands of patients, unlike the CVOTs. So during the study, the last 2 weeks of the study, there was a CGM being used. So they tried to look at glucose variability and mean glucose levels and A1C, and these are the endpoints which were measured. So what you can see is that between you can just the graph which I'm showing you. So the A1C reduction was similar between these two molecules. That I told you always, most of the time the A1Cs are not much different. And basically, if you look at the graphs, you can realize the fluctuation of the graph is less with U300 glargine in comparison to U100 glargine. And side is a measure of how the variability is. So you can use different measures of variability, but what is specifically looked at in this particular study is during the last 4 hours of the 24-hour injection period, that both of them are given once daily, what happens to the fluctuation of the sugar. So you can see that with U100 glargine, the fluctuation is around 28 milligram per deciliter. And with U300 glargine, it is only around 14 milligram per deciliter. So from a clinical perspective, how does this differ? So I think all of you are seeing patients in the outpatient department coming with self-monitoring blood sugars. And you realize that for these patients who come with blood glucose, one day the glucose is 80. And when the patient is quite happy, the next day the glucose is 140. The third day again it becomes 120. The fourth day it becomes 72. So this fluctuation of fasting blood glucose which happens when an injection is taken, this variability is less with U300 glargine than with the U100 glargine. That is basically what this study translates into clinical practice. That is a smoother insulin in terms of variability. And nocturnal hypoglycemia, because of the variability, is less with U300 glargine. Now, this is not a study in itself. This is actually a pooled data from edition 1 and edition 2, because we all are aware of the fact that our patients, even though we tell them glargine you should take at 10 p.m. in the night or 9 a.m. in the morning, many of them don't take that exact time of the insulin. They actually keep changing their time. Some days they take it a bit late, sometimes they take it a bit early, and some days they even forget to take injections. So the comparison is between patients who received flexible dosing versus people who received fixed dosing. So what you can see is that with U300 glargine, whether you are using a flex dosing or a fixed dosing of timing, you can see the hypoglycemia is not much different. And you can see the graph is shown the percentage of participants experiencing more than one hypoglycemic episodes. So whether you use flexible dosing or whether you use fixed dosing, it is not much different between when you are using U300 glargine. And this is again another study, which is again looking at a similar, I'm not going to explain too much about the study, but looking at only the thing which is circled in red. So similar study, CGM was used, type 1 and type 2 diabetes patients, U300 versus U100. And you can see that the variability of sugars is more with U100 compared to U300. This basically means, again, the same thing I told you. When you give an injection at night, the real thing you want is that you want the fasting glucose to be almost similar to the 3 a.m. glucose. But what happens in real life is that sometimes the 3 a.m. glucose may crash. The fasting will remain still normal. So that sort of variability is less with U300 glargine compared to U100 glargine. Now coming to how does the two new generation insulins, the Digludac versus the other one, the U300 glargine, how do they compare against each other? So I think one of the talks which is going to come in the sessions which we are doing in the next month in September 12th and 13th is, are these insulins really different or are they similar? So if you ask me, I will say that they have more similarities than differences. So this is the data to show how U300 glargine versus Digludac using a CGM based data. And you can see that they look almost the same. And even in this study, the time in range was similar for Digludac compared to that of glargine, U300 glargine. But the variability in this particular study was lesser with U300 glargine than with Digludac. So that means there's less fluctuations and more steady state pharmacodynamics with U300 glargine compared to Digludac. Again, a time in range study between Digludac and U300 glargine. I'm not going into the details. Just to tell you that even in this study, the primary endpoint was the time in range. Both the insulins had a similar time in range. But when it came to hypoglycemia, nocturnal hypoglycemia, the time spent in nocturnal hypoglycemia, U300 glargine fared better than Digludac in this particular parameter which was measured. So again, one other flash glucose-based monitoring study, again looking at TIR. Just to tell you again the same similar data, the TIR was similar between U300 glargine, but certain parameters like time spent in nocturnal hypoglycemia in this particular study was better with U300 glargine than with Digludac. So basically, you have less of hypoglycemia in this particular CGM-based study with U300 glargine than with Digludac. So basically, if you were to ask me which is a sort of a choice of insulin, you can say that both the insulins are having a similar timing, similar efficacy in terms of blood glucose reduction, but subtle advantages of using U300 glargine. So this is my last slide. The key messages is that glycemic variability is an important parameter which we should recognize. Even if you are not able to do continuous glucose monitoring in, say, 90% of your patients who are coming to your outpatient department, choose the patients who are at higher risk of hypoglycemia, like people with renal dysfunction, people with unstable sugars, people with recurrent hypoglycemias. Do a continuous glucose monitoring for them. See how much of time they are spending in time in range. Use insulins. Most of these insulins are more expensive than the conventional ones that we use. But use this insulin selectively, at least in people who will benefit from their effects on glycemic variability. And from studies which have shown basal insulin U300 glargine has demonstrated lesser glycemic variability compared to Digludac. Thank you very much.
Thank you, Dr. Matthew, for a very excellent presentation. And I've got only one or two questions to you, just for the discussion.
Yes,
and with our limited resources, how often you would like to get a CGM done? And it is not possible for us to go into the CGM in every nook and corner because of the non-availability and all. So in 3 months period or in 1 month, how often you would like to get a data on the CGM for a better monitoring?
Okay. Just like I told you before, CGM, even in my practice, I am not using it very extensively. I have limited it to very small number of patients. One is people with frequent hypoglycemia. Second, people whose HbA1c is not in keeping with their self-monitoring glucose values. That means they will have high A1C or their glucose values are reasonably normal. So such patients are there. People who are elderly, people with renal dysfunction, mild elevation in serum creatinine, EGFRs are below 60 or below 50. Then, so those are the patients. So I think both. So this is a small number of patients where I do it. And when I do it, what we do is that we don't repeat it frequently. We find out areas where the patient has got problems. Their post-breakfast is abnormal. Nocturnal hypoglycemia is there. The further glucometer-based monitoring will be looking at those specific areas where they had problems. So usually I'll say once or twice a year is maximum I would do for a patient, not beyond that.
One more question I have got. Now, minimum, how many days you want to like to get a TER that is maintain a blood sugar between 70 and 180 for prevention of a long-term complication? Do you have any such data or any such information? And I again understood that etc. will be better if you go with the TER monitoring and controlling blood sugar. So if so, I think you got the question.
Yeah, I got the question. See, this data of TIR versus microvascular complication is primarily related to data which has come out from the DCCT. So what they have done in the DCCT is to look at the large number of self-monitoring values which has been done during the DCCT trial and extrapolated that to the this particular complication. When we do a 14-day flash glucose monitoring, what we technically think is that this 14-day glucose monitoring is representative of what the patient is going through a normal life. So that is what a flash monitoring means. So I should say that we expect the patient to be in TIR of target of TIR throughout the day and throughout that every day of his life. That is what we believe. So this is only a representative.
That we don't expect to have. So any questions from, we'll check the chat box and see whether any questions for you. So I think there is no questions in the chat box. So I congratulate you over both the speakers for a wonderful talk. And I take this opportunity to thank Dr. Shabir for again inviting me as a chair. So we'll move over to the next session.
Yeah, thank you, sir. Thank you very much for the session.
Moving on to the last session of Diabetes Today 2020, this future diabetes. For chairing the session, I would like to invite Dr. Arun B. Nair, sir.
Thank you for this great opportunity once again. The last session of the marvelous conference, Diabetes Today 2020. It has been a totally novel experience for all of us because we were going digital for the first time. But the response session after session has shown that there has been a great success till now. So for the final session here, the recent advances in diabetes or future diabetes, as it has been rightly termed, we have got three very eminent speakers, all of them my friends from Trivandrum Medical College. So without wasting much time, let me introduce the first speaker of the day, Dr. Anand M. Pillai, who is a consultant interventional cardiologist, Anandaburi Hospital and Research Institute. And he would be addressing the topic, newer therapies to address dyslipidemia. So without wasting much time, straight away handing over the mic to my dear friend Anand, who is sure to enlighten us with great wisdom and in a highly entertaining way. Over to you, Dr. Anand.
Thank you, Dr. Arun, and thank you, the team, for the opportunity. I just want to double check the audio visual with the host as I'm logging in from a different computer than the one I had tested. Am I audible?
Yes, very much.
Okay. Not able to upload my slides. When I go there, it says open system preferences.
Please try now. We just gave you the permission.
Please try, Anand.
Yes,
It's okay now.
yeah. But when I hover over it, it says open system preference.
What's the real issue? What's the
When
actual
I
problem?
when I click on the icon where we are supposed to share it, it says open system preferences and it's not able to upload. It says allow web meetings to record your computer. Okay. Why don't you, Shabir, go ahead with your second talk? Let me just try and log in from a different computer.
Fine. I think I am. Where is Anusha? Is she here? Anusha?
Yes, she has logged in to the best of my knowledge.
Yeah, I will call her.
Can
Anusha
you
is
hear
there.
me? Yeah.
Yes. Anusha, can we go ahead with your presentation?
Yeah, sure.
Are you ready?
Yeah, I'm ready.
So I think Dr. Arun can introduce Anusha. She being my batchmate and my very close friend, you can specially introduce Anusha to this forum.
Okay, definitely. So this is the second time I get this great opportunity to introduce Anusha to this august audience. Dr. Anusha is a consultant vitreoretinal surgeon at Shankara Eye Hospital. And she was an MBBS graduate from Trivandrum Medical College and did a post-graduation from AIMS New Delhi with gold medal. She has a lot of publications in in-text journals, and she's an expert in vitreoretinal surgery. So the recent advances in the treatment of diabetic retinopathy is the topic which she is going to talk to us. Over to you, Anisha.
Thank you, Dr. Arun, and thank you, Dr. Shabir, once again for giving me this opportunity. Feel really fortunate to be a part of this Diabetes Today 2020. And as Dr. Arun said, it's been a really new experience for all of us. And I congratulate the entire team for such a wonderful performance and such a great success. Okay, so the topic for me today is, one second. Yes. Yes, can you see my screen?
It's uploading. Just wait, Anusha. Yeah, perfect. Go to the slideshow mode.
It's visible.
Yeah.
Perfect. Go.
Okay, so the topic for today is the session is the what's new or the future in diabetes. So I'm here to discuss what's new in the management of diabetic retinopathy. What's new? That's not moving. 1 second. Yeah. So first of all, the diagnosis. Only if you diagnose, you'll be able to treat. So that's the importance of screening, and that's where the artificial intelligence comes in. So what's new in diabetic retinopathy is artificial intelligence. In collaboration with Google, they have formulated a deep learning artificial neural network, which has been trained to detect even minor forms of diabetic retinopathy based on fundoscopic images. Now, it has achieved a sensitivity of around 75 to 96% and a specificity of around 93.4 to 93.9% in detecting referable disease. So once referred at peripheral centers, once labeled as a patient with diabetic retinopathy, they can be referred to future centers for further evaluation and management. Another is telemedicine. There are telemedicine booths set up in different hospitals when patients, even in the peripheral, even the rural villages, can access the access ophthalmic care. So based on the features, I discussed this in my previous presentation as well. So this is what the artificial intelligence does. It classifies into mild, moderate, severe, and macular edema. And very severe forms like the proliferative diabetic retinopathy, the presence of new vessels, the presence of hemorrhage, and the presence of retinal detachment, which requires surgery, can also be deferred using artificial intelligence and sent for us to further management. So that was about diagnosis. So once we diagnose, the next step is to image. Now, how do we image and confirm the diagnosis or assess the severity of diabetes and also assess what treatment to give and when? So the first is a fundus fluorescein angiography, which is always the gold standard. Then came the optical coherence tomography, which is actually a sort of a CT scan of the eye, which shows the different structures of the eye. But what is new now in the imaging is something called an OCT angiography. Now, this OCT angiography, it resolves the vascular details which are not achievable by the conventional angiography, such as the deep and the superficial capillary plexus of the retina. So it is equal to the FA in ability to detect macular complications of diabetes, such as microaneurysms and new vessels, and it also shows the presence of decreasing capillary density, the branching complexity, and increasing vascular caliber. So the application in diabetic retinopathy, it shows macular perfusion, shows the new vessels, shows microaneurysms, which are all present in the different stages of diabetes, and the early detection helps us to monitor progression and also the regression following treatment. So this is just to highlight the importance of OCT angiography. So this is an angiographic image. The importance of OCT angiography comes up in patients pregnancy or in advanced diabetic nephropathy where we cannot inject the fluorescein dye. So this is a dye-less technique. It is just based on Doppler. So this detects the movement of the red blood cells and gives a picture which is very similar to that found on the angiography. So this is the angiographic image of the eye, and this is the OCT angiographic image. So there was this with the dye and this is without the dye. You can see that it is very beautifully delineating all the details that is picked up even on a fluorescent angiography. Now you can see here, this is again an angiographic OCT angiographic image, and this is the fluorescent angiography, and you can see that it has picked up much more than actually the angiography has picked up. Now this is again a comparison between the angiogram and the angioplex map as seen in the OCT angiography. Another last picture, you can see the same thing, which is exactly how it is in the fluorescent angiography. It has come up on the OCT angiography as well. So now for the imaging of diabetes, we can do away with the dye in many patients, especially in pregnant females and nephropathic patients, and get an imaging without posing them any risk. The next was the importance of the glycemic control. HbA1c was recently found to be, if it is maintained less than 7%, it reduces the risk of retinopathy progression by 50% in intensive glycemic control patients. Also, phenofibrate, it causes lesser progression of diabetic retinopathy and reduced need for laser. As far as the treatment of diabetic retinopathy is concerned, the laser was always the gold standard for diabetic retinopathy. Surgery was always there, but now in the modern era, the anti-VEGFs have become of paramount importance. The anti-VEGFs have now revolutionized the management of diabetic retinopathy. Intravitreal VEGF inhibitors are the first line agents to now treat something called a diabetic macular edema, which is the known cause for visual loss in diabetic retinopathy. So the growing use in use of advanced disease such as a proliferative disease reduces the progression, less likely to have surgery or laser. So if you screen a patient with diabetic retinopathy and if you find that the patient does have an advanced diabetic retinopathy, this is an option that you can probably prime the patient for, that instead of directly going for laser, which is a destructive procedure, the patient can also do away with an injection, which is an anti-VEGF injection, which has been the most frequently used being a ranibizumab, which was recently FDA approved for treatment of all forms of diabetic retinopathy. So these are the different forms and these are the different targets at which they act. So you have these VEGF agents, then you have a VEGF trap, which I'll be discussing subsequently, which is the latest molecule which has come up. Then you have the protein kinase C inhibitors and something which anacortive acetate, which is a steroid, which is used to inhibit the angiogenesis or the new vessel formation. So again, pegaptinib, these are some of the anti-VEGF agents that are available. The pegaptinib, which is now out of vogue, bevacizumab, the ranibizumab, and aflibercept. Bevacizumab was initially used for the treatment of metastatic colorectal cancer. It is not FDA approved for intraocular use. However, because it is cheap, we still use it. Ranibizumab has been FDA approved. It is an fragment of the bevacizumab. And finally, now in the market is aflibercept, which is a slightly expensive molecule, but it is a fusion protein which binds to all the VEGF isoforms. So VEGF, it is a vascular endothelial growth factor, is responsible for the formation of new vessels in the eye. So that is inhibited by these molecules. So this ranibizumab specifically binds only the VEGF-A, whereas the aflibercept not only binds VEGF-A, but also VEGF-B and also the platelet-induced growth factors. Now, the anti-VEGFs, as I mentioned, they constitute an early and regular anti-VEGF treatment and can halt and sometimes even reverse diabetic retinopathy. Bevacizumab, I mentioned, it is not FDA approved, and ranibizumab, it has been approved for the treatment of DME. The recent advance is the presence or the use of an aflibercept or the VEGF trap molecule, which is a recombinant molecule which has high affinity for everything, for VEGF-A, B, C, D, as well as the placental growth factor 1 and 2. Now, apart from, so this is how diabetes causes diabetic retinopathy, the chronic induces leukostasis, which induces the releases of multiple inflammatory mediators, also causes release of VEGF, which is inhibited by the anti-VEGF agents, which we just discussed. But along with that, we also have some inflammatory mediators present, which also constitute an important role, which cause loss of retinal capillary endothelial tight junctions. They increase the vascular permeability and lead to macular edema. So to target these inflammatory mediators, we now have something known as a steroid implants, which has also recently come into the market. So a single shot of steroid, as all of you know, may cause cataract, may cause glaucoma, may cause increase in intraocular pressure. So these steroid implants are actually a sustained release implant. So these steroids work by inhibiting the leukostasis and mitigating the release of local inflammatory factors, including VEGF. So this is how it comes. It's like a pen. You just have to press the trigger button and it gets released into the eye. And this is how the steroid implant looks within the eye, looks inside the eye. So it stays within the eye for around 3 to 4 months, slowly releasing the steroid and gradually delivering the drug and decreasing the macular edema. So that obviates the need for frequent injections. Anti-VEGFs generally need to be given on a monthly basis till the edema is controlled, but steroids need to be given only once in 3 months. Now the lasers was, as I mentioned, was the gold standard initially, but now has been taken over by anti-VEGFs, but they still have a role. It's not that they are obsolete. They still have a role in proliferative diabetic retinopathy, where we do a pan-retinal photocoagulation to destroy the hypoxic retina. So this is a patient with diabetic macular edema, and this is how the patient would look after we've given laser treatment. So this is just a pictorial representation. The laser spots which actually look white, not black, as this is just a pictorial representation. Yeah, and this is another patient with a proliferative diabetic retinopathy where a pan-retinal photocoagulation has been done. So you can see these are the laser spots that have been given to the patient for the proliferative diabetic retinopathy. The last advance is in surgery. So initially it used to be a stitch, the patient had to be opened up like it was a 20 gauge surgery. So the 20 gauge means around 1.1 millimeters. So the patient had to be sutured after the surgery, the sclera had to be sutured. But now what we do is a very minimal invasive surgery, what we know as a micro incision vitrectomy system, which is a 25 gauge surgery, which is as small as 0.7 millimeters. So the patient comes out of the surgery sutureless. There is no stitch involved. And this is a minimally invasive vitrectomy system. You can see that there are 3 ports here for the surgery. And it is like you can say it's like an endoscopic surgery where you have a light which goes in and the cutter which goes in. And this is to maintain the infusion inside the eye. And this is a major advance that we have now very, very minimum gauge surgeries like 25 gauge, 27 and even 29 gauge, which have shown equally good results. And because of the improved instrumentation, there are less complications as well. So diabetic retinopathy showed that early vitrectomy within 6 months is more useful, especially for type 1 diabetics. Early surgery with PRP provides, that is pan-retinal photocoagulation, provides better visual results. And anti-VEGF agents have proven useful in the management of vitreous hemorrhage. So that's the end of my presentation. Thank you so much for your patient listening. And thank you once again, Dr. Shabir, for giving me this opportunity.
Thank you, Anusha. That has been an excellent, comprehensive, crystal clear, energetic, and enlightening presentation.
Thank you so much.
Thank you. We can spend 1 minute time to ask any doubts to Anusha if anybody wants to ask any doubts, because it's an extremely relevant topic in diabetes. We are inviting any doubts, please. If anybody has any doubts to Dr. Anusha about this topic, please feel free to ask. Okay, I think nobody is in a mood to ask any doubts. Thank you once again.
Thank you so much.
I hope Dr. Anand's technical issue has been solved.
Yes. Let me try and share content now. Okay, now it is working, I think.
Okay, I'm inviting Dr. Anand, interventional cardiologist and electrophysiologist from Anantapuri Hospital and Research Institute with a lot of fellowships in both interventional cardiology and electrophysiology from various foreign universities, and an MPH holder too, for this topic on newer therapeutic advances in the treatment of dyslipidemia. Over to you, Anand.
Okay, thank you. You can see my slides?
Yes, very much.
Audio is okay?
Perfect.
Okay, very good. So we'll talk about dyslipidemia beyond statins, touch upon CETP inhibitors and PCSK9 inhibitors. So the first thing is, we know that statins work very well for patients with vascular disease. Even with diabetes, you're able to bring down their LDL cholesterol to a very reasonable level to prevent events. So is there any further role for an additional anti-dyslipidemic agent is the first question. So if you see here, although statins are very effective, there is still some degree of remnant CV risk, which could still be further addressed. So we are pushing our science and technology these days to come to the best that we can achieve. Okay. So what are the current limitations as far as we know? We know that statins work well and they bring down LDL by almost close to a 50% level. But there is still another 30% reduction in in LDL levels, which can be obtained. A second thing, the higher the statins goes, the incremental benefit of reduction of LDL is less. We know about the common side effects of statins, and sometimes there can be poor tolerance as well. So we'll talk about two relatively new molecules, CTP inhibitors and PCSK9 inhibitors. CTP inhibitors are relatively new, and they're still kind of in the clinical trial stage and not in clinical use. So I'll briefly mention about them. CTP stands for cholesterol estase transfer proteins, which has a major role of transferring triglycerides and cholesterol esterase between the VLDL and liver. And the CTP inhibitor, essentially what it does is to increase the HDL in our body. We know that HDL is the good cholesterol, which we want it to be higher. And here you see that CTP inhibitors can improve your HDL from a baseline level of 40 to almost 100. And along with that, there can be a reduction in LDL as well. But unfortunately, most of the trials with these inhibitors have not stood the test of time. Some of them had a higher death rate. Some of them did not show any clinical benefit. So although numerically the HDLs were increased, there was no clinical benefit, except for the last molecule that you see here, which showed some modest benefit. But even the manufacturers were not confident about the overall performance of the drug, and it is being stalled. As far as I know, there is none in clinical use. There are probably some trials going on. So the take-home message is, although we know that HDL is good cholesterol and elevation of HDL is good, there has not been a clinical benefit by the increment in HDL is the lesson that we take from the CETP inhibition. Let's move on to PCSK9, again, a relatively new molecule. I'll talk about some basics as it may not be familiar to most of the audience. So what is PCSK9? It stands for pro-protein convertase subphylicin type 9. It is a protein which is seen in the circulation. Let's go back to a little bit of cholesterol metabolism basics. So this blue thing that you see here is an LDL receptor seen on the surface of the liver, which takes the LDL molecules into the liver and thereby reduces the blood level of LDL. And this is part of the normal cholesterol metabolism. And these receptors are recycled to the surface. So what PCSK9 protein does is to bind to these receptors in a normal fashion and metabolize them and kind of maintain a balance of these receptors. So if these proteins are inhibited, there will be more LDL receptors on the liver surface, which will take in more LDL into the liver and thereby reduce the LDL number in the circulating blood, which is what PCSK9 inhibitors do, which is actually a monoclonal antibody against this particular protein. And once this protein is bound, it is not able to bind to the LDL receptors on the liver surface. So there are more receptors, more intake of LDL into the liver, and the blood levels of LDL will come down. So PCSK9 inhibitors, and they're supposed to be very potent even beyond statins. Patients who are already on statin with the LDL which has come down to less than 100, they can bring down an LDL down to even in the 30s and 20s. So it's like a super statin. On top of the LDL reduction, it also has several other favorable roles, including reduction in ApoB, improvement in HDL, and reduction in triglyceride. The key thing which all of us need to know that this is a very expensive therapy. This is a subcutaneous injection given once in 2 weeks, and one injection will cost you 17,450. So a monthly expense of 35,000 and a yearly expense which can go into the lakhs. So that is a key thing which all of us need to be aware of. So it's a very expensive therapy, and let's see if this money is worth spending. So who are candidates for PCSK9 inhibitors? I have listed them here. Let's come to number 2. Number 2 are patients with familial hypercholesterolemia, particularly homozygous hypercholesterolemia, which tend to have a very high abnormal LDL. And these patients will benefit because there is a limit to which this can be brought down as far as the statins are concerned. And heterozygous familial hypercholesterolemia patients will also benefit. Then established cardiovascular patients who are high risk because of recurrent MI or their LDL levels cannot be brought down to target with statins are the patients who will potentially benefit from these drugs. So how much lower do you want the LDL to be? So our guidelines had gone to less than 100. Now it's less than 70. Now the guidelines are even talking about bringing your LDL less than 40 in high-risk patients, which is what PCSK9 can do, as you see here. And there has been a linear correlation between LDL reduction and cardiovascular events. So this is the intravascular ultrasound study using a camera inside the coronary artery. And these drugs have been shown to physically decrease the atheroma volume in patients with coronary artery disease. 4-year trial was a key trial studying the PCSK9, the evolocumab molecule, which was studied in patients, high-risk patients who have already had MI, stroke, and symptomatic peripheral disease, and patients who are already on statin, and despite of which their LDL is more than 70, are the patients who were studied. And an impressive reduction of LDL from mean of 90. So a 90 to begin with is pretty good as far as CAD patients are concerned. And that is on the statins. And on top of the statin, the PCSK9 brought your LDL down to less than 40 or almost 30. And there was a statistically significant reduction in cardiovascular events, 16% relative risk reduction and a 25% reduction at 2-year intervals. The lower you brought the LDL, so less than 20, the risk reduction was even better. And patients who are higher risk but with higher number of MIs and recent recurrent events also benefited with lower events. Pertinent to our meeting, the diabetic subset of patients also, there was equally good reduction in LDL down to the 20s. And not surprisingly, the benefit was also better because in the diabetic population, the events were higher. So was the relative risk reduction, 2.7% as opposed to a 1.6 in the non-diabetic patients. There has been a lot of controversy asking about, well, if you bring a LDL so low, is it not going to cause adverse events? And interestingly, there was no safety concerns. So even with patients with LDL less than 20 did not have any adverse side effects. So where do we stand? We have a molecule which is able to bring your LDL down into the 20s and 30s and have been proven to reduce cardiovascular event in these patients. I'll come back to my summary slide and which patients this is benefited. So in one way of putting, if you can afford it, any CAD patients will benefit, and you'll have to shell out around 30,000 rupees a month or 4 lakhs rupees a year. It's a twice monthly injection taken subcutaneously, and there has been a benefit in these patients. But a specific population who will benefit are high-risk patients who have recurrent MIs or recurrent multivascular disease despite statin, and despite statin, if their LDL is not less than 70 will benefit, and then patients with familial hypercholesterolemia. And not surprisingly, these have made it into the guidelines for the indications that I just talked about. Thank you.
Thank you very much, Dr. Anand, for that extremely lucid and brilliant presentation. It's always a pleasure listening to you. Any questions from the floor to Dr. Anand regarding this topic of liver therapies in dyslipidemia? Anyone has got any questions to ask Dr. Anand? Okay, seems that there is no question. Thank you, Dr. Anand, once again.
Thank you.
Sure. We come to the last the topic of Diabetes Today 2020. And the presenter now is none other than the backbone, brain, skeleton, flesh and blood of Diabetes Today 2020, Dr. Sabira Rashid, who is the Chief Consultant and Director of the Rashid Specialty Center and Managing Trustee of TDRF. And the topic is novel pharmacotherapy for obesity. Over to you, Dr. Sabir.
Okay, thank you, Dr. Arun, for the kind words. Is it audible, Arun?
Yes, very much audible. Your slides are also visible.
Okay, let me. One second. So before that, being the last topic, you can share from here. Before that, I think before going to the last topic, I think some small technical issues there. Wait for a moment. So I just want the opinion from few of my friends. Balash and Valued sir is there, Sunil is there, Arun is there. I can see few faces. How is the overall experience, Dr. Arun? Can you just mention in few words?
It has been brilliant. The online conference has been brilliant. Brilliant selection of topics and speakers. The only suggestion is that it would be great if we can keep some more time for certain vital sessions. Like, for example, the session on vitamin D and vitamin B12. I felt it should have received a little bit more time. Also, the exercise session by Dr. Roy R. Chandran should have been an extensive workshop mode, should have received a little bit more time. And also the ophthalmology session by Dr. Anusha, and a session on insulin also, the practical tips regarding that. We could have given a little bit more time and converted them into workshop models. It would have been much more practically useful for the clinicians. That's the only suggestion. Other than that, it was a brilliant experience.
Okay, perfect. So Dr. Balash sir is there. Do you have any comments, sir? Valued sir, are you there? Okay. Fine, sir. Please tell.
It's pleasure to see that you have organized such a great CAB during this. As I mentioned in my sharing session, there are a lot of adversity which is running in your state. But in spite of that, we don't have much of a technical hitches in the audio, video, and all. I expected that being in the northern part of Kerala, it will be difficult for me to interact and hear. But the audio and the system is very good, and I may be able to hear all the speakers very well. And again, I think that probably you can incorporate a little bit of posters in between show, in between the hall and other things in the next time, so that you incorporate a little of junior doctors also. Because in a virtual meeting, it is also possible. Some posters or some other things, or some, as I've mentioned earlier, some workshop like things can also be incorporated in this. That is what I think. It will make it a more useful for everybody.
Okay, sir. Thank you. Thank you. Welcome.
Really great congratulations for you and your team.
Okay, sir. Thank you. And Dr. Sunil, are you there? Sunil?
Yes, Sabir. I think
just few words.
Sabir, actually, first of all, let me extend my Sabir, because so many universities, the day before, I think we were really surprised and we were really happy in Kerala. Despite this, I think nobody would have dared to go for such a venture. But after seeing 2 days, I think we couldn't have asked for a better CME in the present context, because as everyone told, he dared to go for such a venture, and I think most of the sessions were good, excellent speakers, excellent tips, and we couldn't have asked for one in the present context. All congratulations to Sabir, and I'm sure that he will make up the hitches this time around, and surely he will come up with a better show than this next time around. Over to you, Sabir.
Thank you, Sunil. So we'll move straight away into the topic proper. I think we have crossed the time. It's around 6 p.m. So we have to wind up in few minutes. So I'll be just running through the slides. This is something regarding the newer pharmacological agents for obesity management. So what exactly is the obesity? Actually, is it a disease or is it just a terminology? So we all know that this obesity is disease of the civilized society. So we have to find out whether obesity is really a disease. The American Medical Association in 2013 declared obesity as a disease in its resolution 420, stating that it recognizes obesity as a disease state with multiple pathophysiological aspects requiring a range of interventions to advance obesity treatment and prevention. So what is the prevalence? We can have some few information regarding the prevalence of obesity both globally and in our nation. Globally, obesity has nearly tripled since 1975. And by the census of 2016, more than 1.9 billion adults over 18 years were found to be overweight or obese. In India, 13 to 50% of the urban population and almost nearly 35% of the rural population suffers from obesity. And obesity, that's an interesting finding. Obesity is commonly seen in women compared to men and is increasing in children and adolescents. And the state of Punjab in India, when compared to other states, state of Punjab has the highest prevalence of obesity Just 1 second. 1 second. Struck. Okay, so this is the state-wise survey of obesity in Indian states. Top the list with Punjab, then followed by Kerala, then Goa, Tamil Nadu. So the southernmost states, I think the level of obesity percentage is more compared to other states. So adult is a person who has stopped growing at his ends and is now growing in the middle. So, as per the Dr. E.P. Jocelyn, the father of diabetes, from an excess of fat, diabetes begins, and from an excess of fat, diabetics die too. So, how can we tackle this global issue, this obesity? We have many traditional weight loss therapies. As we all know, we have multiple options ranging from nutritional therapy, physical activity, behavioral therapy, pharmacotherapy, bariatric therapy, etc., etc. All these have to be individualized accordingly as per the suit of individual. So I'm not going to the details of lifestyle modification and all because our topic is concentrated on pharmacological agents. So as per Time Magazine, the best way to combat obesity is to build up your biceps in order to push yourself away from the dining table. Definitely, lifestyle modification is a major role or major part of obesity management. So diet, definitely, I'm not going into the details. All these sort of junk foods can definitely lead on to obesity and further lead to complications of obesity like cardiovascular and cerebrovascular, so many, and not going to the details. And this is a cartoon showing if we take the starring food like this junk foods and all, instead of mummy returns, the actual happening is that tummy returns. So we have to be careful. Definitely exercise is more important than diet in controlling obesity. So coming to the topic of pharmacotherapy, we have, I'm just going to the timeline of anti-obesity medications. Before 1900, actually the thyroid hormone preparations were used as anti-obesity drugs because when the hypothyroid patients start consuming thyroid hormone preparation, they found to lose weight, lose some minute weight and all. So they thought that thyroid hormone preparations were actually anti-obesity drugs, and initially, in the early 1900s and all, they were using thyroid hormone preparations as anti-obesity drugs. Then that concept was discontinued. Then came dinitrophenol because of the process of this preparation of dinitrophenol, it caused weight loss by generating heat. Again, it also discovered in the early 1930s and all, first amphetamines were introduced and it served as anti-obesity agent. Then in the late 1950s, FDA has given approval to phentermine as an appetite suppressant and anti-obesity drug. Then came early 1990s, combination of fenfluramine and phentermine, then sibutramine, and not going to the details. Then came orlistat, rimonabant, and last, lorcaserin and fusaimia. So, but unfortunately, most of them were banned by FDA due to their potent side effects. So all this, I'm just next. I think almost all these drugs, in one way or other, has been banned by the most of the official organization like FDA or EMA, etc., including sibutramine, rimonabant, amphetamines, etc. So coming to formerly known as fen, the combination of fenfluramine and phentermine. Fenfluramine, a serotonin agonist, when combined with phentermine, a dopaminergic agonist, was found to be effective in weight loss management, but was withdrawn from the market due to its potency in inducing valvular heart disease and pulmonary hypertension. Then came rimonabant by Sanofi by the name Acambila. It blocks the cellular receptor in the endocannabinoid system of the brain, believed to have significant role in the appetite drive, thereby reducing body weight. It was earlier approved by EMA in 2006, but in 2008, EMA recommended the suspension of Acambila due to its potency in inducing severe depressive disorders and increased suicidal tendencies. And FDA never approved rimonabant as an anti-obesity drug. The adverse event problems linked to rimonabant and its ultimate suspension have resulted in the termination of the clinical development of 3 other cannabinoid CB1 receptor antagonists named Merck's taranabant, Pfizer's otinabant, and Bristol Myers. It is not named. So all these 3 cannabinoid receptor development has been banned because of the adverse issues reported with the parent molecule. Then came sibutramine by the name Verdia by Abbott. It's a centrally acting serotonin norepinephrine reuptake inhibitor, thereby increasing the levels of the substances and helping enhance the satiety. But unfortunately, in 2010, both FDA and EMA voted against this in view of its potency to increase the risk of cardiovascular events and cerebrovascular events. So right now, we have only 6 major class of medications approved by FDA as anti-obesity medications. First one is phentermine, then orlistat, then phentermine topiramate, then again combination, lorcaserin, and naltrexone bupropion combination, and finally liraglutide or Victoza or GLP-1 analog at a higher dose of 3 milligrams. So these are the only 6 class of medications which are available as anti-obesity drugs approved by FDA right now. So I've already gone through this slide. So coming to all these 6 molecules one by one, orlistat, it's only known as Senecal by Roche. It's a saturated derivative of lymphastatin, a potent natural inhibitor of pancreatic and gastric lipases. When administered with foods, orlistat inhibits the hydrolysis of triglycerides, thereby reducing the subsequent absorption of monoglycerides and free fatty acids, leading to a reduced fat absorption by around 30%. So again, so many reported adverse events with orlistat, starting from oily spotting, flat, oily stool, fecal incontinence, etc. So orlistat prescribing information is it has to be taken 120 milligram twice daily along with main meals, at least with main meals. And orlistat is contraindicated for pregnancy and pregnant and lactating women, and those with chronic malabsorption syndromes or cholestasis. And mind you, there's a caution in using orlistat because concerns about a link between orlistat and colon cancer is being investigated. And in May 2010, FDA has approved a revised label for orlistat to include cases of hepatic injury with the use of this medication. So we have to be very careful and prescribe this medication, especially to our diabetic patients. Then came lorcaserin, name was Belvic by Arena Pharmaceuticals. It's a selective serotonin receptor agonist. It's a selective serotonin receptor agonist and thereby reduce hunger by the production of opiomelanocortin neurons in the hypothalamus. And after repeated rejections by FDA in view of its less efficacy and potent side effects, was finally approved in May 2012. And the FDA has requested for a post-approval trial to assess the long-term cardiovascular effects of lorcaserin. And it's available in India by the name Afens by Sun Pharmaceuticals. Next, combination of topiramate and phentermine by the name Cusamia by Vivus Pharmaceuticals. Actually, the combination of topiramate and topiramate is actually an anticonvulsant. When combined with phentermine and appetite suppressant, was found effective in weight loss management. Approved by FDA in 2012, but not by EMA as it was related to suicidal thoughts and birth defects. Studies are in favor of its use in diabetes and also in obstructive sleep apnea also. Again, so it's a study supporting the use of topiramate and phentermine. I'm not going to that. Another combination, interesting combination is sonisamide and bupropion by the name emphatic by Oregon Therapeutics. It's a new generation anti-epileptic sonisamide when combined with bupropion, an atypical antisuppressant, antidepressant is found effective in weight loss management. This is a study supporting the combination therapy. Next came the another good combination naltrexone and bupropion by the name Contrave. A combination of naltrexone 32 milligram and bupropion 360 milligram was approved by FDA as an anti-obesity drug. But the concerns are there with this combination also due because of the psychiatric side effects and the propensity to elicit depressive disorders. So currently undergoing late phase safety trials to assess its cardiovascular complications as such. So anti-obesity drugs which are clinically under pipeline, we have n number of molecules starting from setlistad to next tisofensine compound. See, we will just discuss a couple of drugs. So setlistad by Takeda and Alizine, it's almost similar to orlistat, which we have already discussed. This is the same class of medication. It's a pancreatic lipase inhibitor and similar action like orlistat. Completed almost phase 3 trial. I think it's almost into the market, and in certain countries and certain areas already there, and the physicians are prescribing the setlistad as anti-obesity drug. Tisofensine, it's an interesting molecule by neurosearch. It's a peptide reuptake inhibitor. It's a serotonin, noradrenaline, and dopamine reuptake inhibitor, originally investigated for the treatment of Alzheimer's and Parkinsonism, but results were supportive for weight loss therapy. So it was designed as a anti-obesity drug. It's almost completed phase 2 trials and was published in the Lancet and shows that almost weight loss over a period of 6 months of more than 12 kilograms with this wonderful molecule. So, but since this tisofensine is a triple reuptake inhibitor and tisofensine share pharmacological properties with sibutramine, so has the potential to increase heart rate, blood pressure, and psychiatric disorder. So the safety issue has to be taken into consideration. So another interesting molecule in the pipeline is eslopitant. It's a neurokinin receptor antagonist initially investigated for irritable bowel syndrome and for emesis induced by chemotherapy. But since studies suggest it can reduce the appetite for sucrose and hence decrease the, and it's interesting is that studies suggest that it can reduce the appetite for sucrose and hence decrease the consumption of sweetened foods and drinks. So this is an interesting feature of this molecule. This just completed a trial in animals only, so may take years to reach the market. Another wonderful molecule is beloranib by Samsung Pharmaceutical. It's actually an analog of the natural chemical compound fumagillin and originally designed as an angiogenesis inhibitor for the treatment of cancer, and clinical focus shifted to anti-obesity therapeutics once potential effect was realized. And in December 2015, unfortunately, phase 3 trial of beloranib was discontinued after a second patient death and thereby obstacles for getting FDA approval for this drug. Again, another interesting molecule is setmelanotide by Rhythm Pharmaceuticals. It's a selective melanocortin 4 receptor agonist. Regulate food intake and satiety. This is associated with small increase in plasma fasting glucose, so have to be careful in prescribing diabetic patient. Currently, also this is also molecule is also being evaluated for rare genetic disorders such as Prader-Willi and Prader-Willi syndrome, etc. And valniparin is a neuropeptide Y5 receptor antagonist. It decreases the hunger and increase satiety, and originally developed by Shionogi as an anti-obesity drug due to its anorectic effects. But recently, again, discontinued with the further development after disappointing results showing modest weight loss in phase 2 trials. And again, the Shionogi, they are trying to combine this valniparin with orlistat as an anti-obesity drug. So this molecule, I think everybody might be knowing, pramlintide by the name Cimalin by AstraZeneca. It's an amylin mimetic, aids in the regulation of blood glucose, also delays gastric emptying and promoting satiety, thereby cause weight loss. And approved by FDA for use in type 1 and type 2 diabetic patients along with insulin. And diamylitide, an amylin mimetic peptide, has demonstrated in animal studies to reduce food intake and body weight with enhanced metabolic activity. So next, the last slide is it's Saxenda, it's a GLP-1 analog. We all know liraglutide for the use of diabetes. We are using this liraglutide by the name Victoza at a higher from 0.6 to 1.8 milligram daily. At a higher dose of 3 milligram, FDA has given approval for this liraglutide as an anti-obesity drug, and this is named as Saxenda. But unfortunately, I think Novo Nordisk has not yet launched this drug in our market, maybe because of the cost effect. So thank you very much for the patient listening. So any comments, or since we are running short of time, I think we will conclude the session and
thank you, Dr. Shabir, for that extremely comprehensive presentation.
Shabir, one comment.
Yes, please.
Regarding sibutramine, I think we had conducted a study on in 2008 to 2010 using sibutramine. Yeah.
Okay.
Almost 600 patients were studied in two groups, and it is shown that almost 5 to 6 kg loss was there in 80% of patients. But unfortunately, by the end of the study, the drug was banned. Unfortunately. Actually, that is a very, very useful drug. We don't come across any of the side effects we say, like suicidal tendencies or increased CVD. But that was banned, unfortunately. That is a wonder drug. Did anyone use that molecule? Other experience with sibutramine? Orlistat definitely is a failure because we won't take fat as a 60% like Westerners. Our fat consumption is only 20 to 30% in India.
Another issue with the anti-obesity drugs are that if we stop the drug, what could be the weight gain and other thing is an issue of concern. So long-term use of most of these drugs may not be of much use.
But with almost I think almost 50% have got remission rate with proper lifestyle modifications. Very effective in reducing the initial weight, sir. Sir.
I think it's easy to reduce the initial 5% weight in all patients with whatever.
If you continue the lifestyle modification, we can keep the remissions.
But efficacy of drugs and continuing drugs, that is a concern. I think there is some horoscope problem with all the drugs which has been launched as anti-obesity.
Yes, sir.
Okay.
Okay, there are more questions. Any more questions? There are no more questions. We can wind up the session. Thank you very much for the excellent lectures. And thank you very much for the wonderful discussion points raised by Dr. Roy and Dr. Balakrishnan as well. And once again, my sincere gratitude to TDRF and Dr. Shabir for giving me this great opportunity to chair this session. So over to the organizers for the concluding remarks and for the valedictory function.
To give the vote of thanks, I would like to welcome Dr. Sabir Rashid.
There seems to be some connection problem at Dr. Sabir's end.
Yeah, some technical issues there. Is it audible now?
Yes, very much.
But still there is some issue, is it? Let me see.
Yes, Dr. Shabir has joined the meeting.
Due to certain technical issues, there is some lag in the vote of thanks. Can you just wait on?
Yes, definitely. We shall wait.
So is it okay, Arun? Am I audible?
Audible, clearly visible. Please go ahead.
Okay, okay. This is the main issue of such digital
I
summits.
think, Sabir,
Yes.
if everyone could switch on their video, it would be a good thing.
Okay, okay. I request all the faculty members or those who have assembled here can switch on their video, but try to mute your audio. But everyone can switch on their video. Yeah, Sibisar is there. Rajesh is there. I can see few of their faces. Yeah, Jacob is there. Shubhashri is there. Yeah, I can see few of the faces. Okay, still Sunil, am I still audible? Yeah, Dr. Roy is there. Hi, Roy. Fine. So slowly one by one is switching on the videos. Good. Actually, Sibit sir, are you doing treadmill exercise? Okay. Anusha is there. Good. Manikandan is there. So without wasting much time, I think we will have the vote of thanks now. So as we near the culmination of Diabetes Today 2020, I stand here in front of you with a great sense of fulfillment and a heartful of gratitudes to each and every one of you in making this hi Arun Gobi, making this humble event a great success. Actually, it was for the first time that we had to organize our update in an online format, and we at TDRF understandably had our apprehensions initially regarding how it would be received because of the increased number of webinars floating around every day in this COVID era. But I am extremely delighted to say that all our fears were melted on day one itself by the quality of the lectures, the enthusiastic participation from delegates, and the awesome feedbacks which we kept in receiving following session after session. As the time to draw curtains for Diabetes Today 2020, I would like to express my sincere gratitude to all faculty members and chairpersons whose amazing performance made this update an academically enlightening and extremely lively experience. I also express my heartfelt thanks to all the delegates for assembling over here, for registering and to listen throughout the like we have the duration was almost around 36 hours. So I had expressed my heartfelt thanks to all the delegates. My words of appreciation for farmer friends are also there, who played a significant role in making this a reality. And finally, to my team TDRF and the organizing committee, especially Dr. Sunil Prashok, who was there with me throughout the event, Dr. Arun B. Nair, my very close friend, Dr. Deepa, again, who contributed significantly for the event. I also thank my staff members, especially Mr. Harikrishnan, Midala Mahendran, Divya, and team led by them, without whom the event may not be a success at all. Last but not the least, I express my word of thanks to Mr. Praveen from Oxasia Pharma for the technical support given, and also to the EventGuru firm for the complete web support. They have wonderful web support they have given throughout from the day one, first minute itself. Mr. Rajil Das was from EventGuru. He just traveled from Cochin to Trivandrum in this COVID time, and he stayed along with us for throughout this all 3 days, and he was with us for conducting this program. And so I sincerely hope that we would be able to meet face to face in 2021 for our 5th annual update of Diabetes Today 2021. And I hear myself signing off from Diabetes Today 2020 as organizing chairperson of the program. So since we are all here, we will just, thank you. We are all here. Okay. Thank you. Thank you. Okay. So thank you very much for our. So we will stand up for a moment for our hands.
जय हे हत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे चाहे तब जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
So thank you everyone. Thank you all. My close friends are all there. Sunil, Arun, Roy, Shubhashri, Rajesh.
Shabir,
Yes.
this is Rajesh from US. Can I add few words?
Yeah. Why not? Please.
Representing some US. Nice to see all my batchmates and my senior. Proud to be part of this, especially from US. I may have to thank. We rarely get any chance to thank COVID. I guess due to the COVID this time, I was able to be part. Very nostalgic feeling. It may not be a positive note, but still, I feel proud to be part of it and being a part again with you guys. I also want to share that I did ask few of my friends to also join a few sessions. As you are aware, mostly it's nighttime here. I'm also kind of waking up this Sunday. I was able to listen to a few lectures. Thank you all the chairs and all the presenters and the organizers to keep me proud. They all were very amazed by how the program was organized and how the lectures were handled and all the presenters. So again, thank you. I feel proud to be part of this team and sharing this event with my friends here. Thank you all and hope I can join with you all next year too. Thank you.
Sure. Thank you, Rajesh, Anusha, Arun, all my batchmates are there. Sunil, my batchmate since nursery time. So Dr. Arun Nair is there. So I'm extremely happy to see all of you. And Balakrishna Valued, my senior faculty is there. Roy is there. Shubhashri, or well-wisher Jacob John from Pharma Field. So thank you everyone. Thank you. Bye. Okay. Bye. Okay.
Even Guru. Special
Yes. EventGurus also. Okay. Thank you. Okay. Fine. Thank you.
Anusha, Ormendo.
Of course. How are you?
Fine.
So good to see you after such a long time.